You can share your screen now.
Yes.
Doctor, we are live now.
Perfect. We can see your screen and you're
Yes.
also audible as well.
Yes, just a second. So is my screen visible?
Yes, and audible. Please go ahead.
Thank you, sir. So good morning, everyone. First of all, I would like to thank BOA and Team MOS for giving me opportunity to present my talk here. So let's start our day with remembering Charles Kelvin, who's the one who introduced the concept of phacoemulsification, as he garnered the idea by using the ultrasonic device, ultrasonic power in emulsifying the cataractous nucleus when he saw a ultrasonic device is being used for a plaque removal, a dental procedure. So with invent and evolution of new phacoemulsification machines, we are now able to give a good visual outcome from 660 to almost 66. That's a crystal clear vision, even if it's a hard or NS4 grade of cataract. So what exactly has changed in these machines that the unrevealed mystery we are going to disclose here? That does the phaco-dynamics have an effect on the visual outcome? We conducted a study aimed to compare the phacoemulsification platforms for similar grade of cataract based on the phaco power in the form of cumulative dissociated energy, phaco time, endothelial cell loss, and best corrected visual acuity. So in this study, actually it was a prospective randomized interventional comparative study in which we got a thorough preoperative evaluation of the patients. Ethical committee approval and a written informed consent was obtained from all participants. And the patients were operated by a single experienced surgeon here. Inclusion criteria were patients in between the age group of 20 to 70 years were included. Patients with cataract grade of NS2 to NS4 as per LOC3 system of classification were included. And patients who were willing for giving an informed consent were taken into the study. Patients with traumatic cataract, with corneal dystrophy or corneal opacities, endothelial cell count less than 1500, cases with complicated cataract, coexisting glaucoma, or any intraoperative complication if happens, those cases were excluded from the study. We divided the cases. We actually took 90 cases from each group. So 30-30 we divided as a subgroup for NS1, NS2, NS3, and NS4 grade of cataract. Total 90 cases. We grouped in a group 1 and second 30-30-30 from each subgroup of NS2, 3, and 4. Total 90 cases. We form a group 2. Group total 180 cases. Group 1 underwent of cataract surgery by an Alcon Centurion platform, and group 2 underwent a cataract surgery by Infinity platform. Preoperatively, proper workup was done in the form of visual acuity by Snellen's chart, a slit lamp examination for grading of the cataract. Tension was checked with the help of non-contact torometer. The IL was calculated by IL master. We did a proper IO to see the fundus of the patient. In cases where required, we did a B scan for dense cataracts, and spatial investigation in the form of specular microscopy was done to know the endothelial cell count. The patients were operated either on topical or local anesthesia. The grading was done according to the lens opacities classification system 3. Regardless of the equipments, all cases underwent stop and chop technique of phacoemulsification. For Infinity, we had a 30-degree Kelvin 0.9 mm turbosonic mini flared ABS tip. And for Centurion phacoemulsification, we used a 30-degree balanced 0.9 mm Intrepid tip was used. The settings were already set to avoid any bias. For NS2 and NS3 grade of cataract, the power put was 25%, vacuum was 300 millimeters of mercury, and the aspiration flow rate was 30 millimeters per minute. For NS4 cataract, it was 35, 500, and 45. Post-operatively, all patients were evaluated on day 1, 7, 30th, and 90th for visual acuity, refraction, and to check the best corrected vision, measurement of intraocular pressure, and specular microscopy on post-op day 30th. The statistical analysis was conducted using SPSS software. and it was performed using chi-square and t-test. Snellen's visual acuity was analyzed using logMAR, a chart, and p-values less than 0.05 were considered statistically significant. Our results we compared in the form of intraoperative parameters and the postoperative outcome. So intraoperative parameters in the form of cumulative dissipate energy and effective phaco time, and postoperative result as endothelial cell loss and the best corrected visual acuity. So in our study, if you go for a gender-wise distribution, there were 54 males and 36 females in group 1. There were 42 males and 48 females in group 2. With age-wise distribution, if we consider, there were maximum population was between 50 to 70 years of age group. The cumulative dissipated energy used in the for NS2, NS3, and NS4 cataract in group 1 was significantly lower as compared to group 2, and p-value was less than 0.5, which states that there was statistically significant difference between the CDE of the both group used in both group. Second parameter we checked was the mean effective phaco time in seconds for NS2, NS3, and NS4 cataract. However, we found that in NS4 grade cataract, the mean phaco effective time was lower in cases of Centurion platform as compared to the Infinity platform. So group B had a little bit higher time required for the phacoemulsification of grade 4 cataract. Mean endothelial cell loss as compared to a Centurion Infinity platform. Sorry. The mean endothelial cell loss was more in Infinity platform group as compared to the Centurion platform group, and that was also clinically statistically significant as the p-value was less than 0.5. The preoperative visual acuity and the postoperative visual acuity, irrespective of the group, was statistically different. However, postoperative visual outcome in the both groups was comparable, and there was no statistically different in the visual outcome. So in short, our results are cumulative dissipated energy in the Centurion platform group was less compared to the Infinity platform group, suggestive of efficient active fluidics in Centurion platform. Effective phaco time in Centurion platform group was 32.87 seconds, and that was 47 seconds in Infinity platform for grade 4 cataract. Endothelial cell loss among all grades of cataract was more in patients of Infinity platform as compared to the Centurion. And postoperative visual acuity among two groups is similar and comparable, but no statistically significant difference was seen. Coming to the discussion point, we have two higher aid machines. One is Infinity. So it mainly works on the gravity-based fluidics. It uses a torsional, Ozil torsional power for phacoemulsification with the help of Kelvin thermosonic mini-flared ABS tip. As the tip is torsional, it reduces the ultrasonic energy required. The surge protection is better, and it gives a better chamber stability.
You have to conclude, Dr. Priyanka.
Yeah. So the conclusion is both CP and IP are safe and effective machines for phacoemulsification as compared and are comparative to each other. Centurion platform has better fluidics and offers more endothelial protection in hands of experienced surgeon. So take home message here is the visual acuity is good with both platforms irrespective of cataract grade. A higher end machine achieves less endothelial cell loss even with hard cataracts. So here, in cases where endothelial cell count matters, higher end machine does make a difference.
Thank you, Dr. Priyanka.
Thank you so much.
Yes, that was an excellent presentation. Point well taken with regards to the machine and endothelial cell count. I now call upon Dr. Navneet, sir, to give his next talk. He's a brilliant academician and he has a training program where people come even from abroad. And I know that I have referred one such person to him and he was in full praise. He's written a lot of textbooks on phacoemulsification. So who better than to introduce phacophotography or photography of phacoemulsification than Dr. Navneet. Over to you, sir.
Thank you. First of all, thanks to Lanesh sir Madam, all the team MOA, Samuel, thank you for introduction, all chairperson and participants, and team MOS also. This presentation.
Good morning, Malai Bhaiya.
This presentation is of its different kind. Last 18 years, I am in this training program, and we are recording the cases. And after recording, we discuss, we analyze our own cases, our doctor's cases, and everything. But then I realized that the photographic analysis is the more important. What we are doing is taking the video and taking the snapshots of the every step, right from incision to foldable IOL, and 50-50 snapshots of every case. And then we are getting the very clear-cut idea that what we are exactly using the instrumentation, what are the steps we are doing. We are going to see some highlights. Now, if you will see this figure, it's the incision is going on. And you can see that next day you will avoid such a type of pressure. And these small points is important for analyzing ourselves. That's, I think, very, very important. Your internet connection. I am audible, sir?
Yes, you are audible. Please go ahead.
You can see the angulation of the cannula with respect to incision here, touching of the iris with the cannula here. Now, this figure is very interesting. If you will see that what has happened in this figure, I'm doing trench, but I cannot see the distal end of the trench. When you cannot see the distal tip end, you should not proceed. You should not go for the next stroke even. And again, you can see here the iris is going towards, stucking towards incision side. So it means that you are giving more pressure, because this point at incision side is one can miss anytime. So that's the point, that avoid the pressure. Your angulation is different. You cannot see your distal end of the tip. All these things are very important. We can catch in this photograph. Now, in the part of the division, you can see the how one can put the instruments in. If you can see the chopper, it is in an awkward position. Then when you are removing out and putting in these instruments, if you cannot remove it out in a horizontal fashion, it may stuck to the iris. This is very, very common finding. And then you can realize really, yes, what happened, why chamber get collapsed, what to do next. So this is not just the photography, it is the evaluation. It is the evaluation for next thinking. And this thinking is very clear cut. I always mention that when you see your previous photograph, functional videos and all that, you may miss, but when you see photographs again and again, it will keep in your mind. So that's the base of this photographic analysis. You can see here the pressure on the left side of the incision. You can see clear cut the corneal folds, which we can avoid clearly once you see these photographs. In a hold and chop, that's very important. That you can eat here like a trench. The next step, when you eat more and more, your bulk is finished. Now you can realize that, oh, I have given the wrong stroke at a wrong point. Maybe more energy than needed. Maybe my angulation is not correct. Maybe I didn't go to the mass. So many things we can get idea due to this one figure. Now you can see here the chopper is at an acute angle and the piece is close to you. So the distance between the phaco tip and chopper should be very at each direction. You are hitting the tip many times. This figure I like, because here the chopper is going, crossing the phaco tip. So avoid this. That's very important, because otherwise it is a double decker and it can injure to the endothelium. In small pieces removal, phaco tip is over the piece, you are near the cornea, you can damage it. Here, You are entering in the center to remove it. You may hit the iris from behind and people can get constricted. Sometimes you can see this beautiful figure. You can cross from center. You can see the distal end of the tip. Nothing is in front of you. You may catch iris. That's the point. Another point, this is a very classical side. Then when you are eating the pieces, you should not cross this 180 degree. Otherwise, you may catch iris. You can go to catch the pieces, but you should not emulsify. That's the one figure will change our career. That's important. Now in irrigation aspiration, you can see here 4 strands of the fibers you catch. You will 100% miss in the video this, but you can take the pickup because such a type of catching of the 4 fibers at a time may give the pressure on a zonule. So my point is that when you do the photographic, it is not only for training program as per se. It's important for our own way to improve every day. And this is not in the phaco, it is in the every part of the surgery of the cataract. Here you can over the mask so that you can give the again stretch on a zonules. You are not in a perfect plane. Here your aspiration port is toward endothelium. So you may catch the endothelium. That's the difficulty. So the point is that these are the multiple figures. You can see now this figure, maybe the last figure. You can see the viscoelastic when you are putting. If you are not putting in a proper way, you feel that, oh, PCR has done. So it's a very skill to how to put visco also. This is also we are discussing for 15 minutes, one hour sometimes. So that's the way photographic analysis is very, very important, I think. And I got personally, for me also, I learned many things every day from my own cases. Thank you very much for your patience, Siri.
Thank you, Dr. Navneet. That was very nice of you to say that we are learners every single day. And if we can see it, yes, we can do it. So documentation is extremely important. I now call upon Dr. Santosh Bide to give his talk. He is a very busy phaco practitioner in Pune and is an active participant in MOS as well as Pune Ophthalmic Society. He's going to be talking about viscoelastics in cataract surgery. Over to Dr. Santosh. Dr. Santosh, we cannot hear you, but we can see your slides.
I think he's not unmuted himself.
Yeah, Dr. Santosh, if you can unmute yourself.
Yeah, I think I have unmuted now.
Yeah, we
Yeah,
can
now,
hear
now
you.
we can hear you. Now we can hear you.
Okay. Thanks for kind introduction, Dr. Soumil. Thank you, BOA, Team BOA, for an excellent program and for giving me opportunity to share my thoughts on a very basic topic of viscoelastic substances. I do not have any financial interest in any of the products mentioned here. Our aim as a phacosurgeon is to give crystal clear cornea on day 1 postoperatively and to achieve 6x6 and N6 vision. And this we can achieve only after protecting endothelium intraoperatively. There are different factors which damage endothelium during surgery. Ultrasonic factor. The ultrasonic waves themselves can damage endothelium. There is a generation of heat, so there can be thermal damage. There is also liberation of free radicals, and due to which there can be oxidative damage of endothelium. There can be excessive handling of the tissue with the instrument, so we can damage endothelium with instruments, or the lens fragments can fly in the anterior chamber and they can hit the endothelium and damage endothelium. Or our irrigation fluid, there can be turbulence in the fluid. The irrigation fluid osmolarity and pH may not be ideal. The composition of irrigation fluid may not be ideal, and that can also damage endothelium. So to protect endothelium, we have different viscoelastic substances, and these are hydroxypropyl methyl cellulose, which is synthesized from cotton and wood. It has to be sterilized by autoclaving, but it has a tendency for inflammation and microbial contamination. There is another good viscoelastic substance like sodium hyaluronate prepared from rooster's comb and chondroitin sulfate, while the other substances like polyacrylamide and collagen are not used and they are withdrawn for the risk they produce. So there has to be some ideal properties for viscoelastic substances. Clinically, it should maintain anterior chamber throughout the surgery. It should coat all intraocular structures, especially endothelium during surgery, thereby protecting it. It should be optically clear. It should not have any effect on intraocular pressure. And at the end of the surgery, it should come out of the eye very easily. Chemically, it has to be inert, isoosmotic, sterile, non-pyogenic, non-antigenic, free from particulate matter. It should be hydrophilic. And most important, it should not interfere with wound healing. Physically, it should have proper viscosity, elasticity, pseudoplasticity. It should have a proper surface tension and coatability. And most important point is molecular charge. See, there are liberation of free radicals during phacosurgery, which are positively charged. So those has to be neutralized by negatively charged molecules. Sodium hyaluronate and hydroxypropyl methyl cellulose has single negative charge on its surface. Chondroitin sulfate has 2 negative charges, while Viscoat and Discovis, being a combination of sodium hyaluronate and chondroitin sulfate, it has 3 negative charges. Hence, it protects better in oxidative damage. Rheology is a science which deals with deformation and flow of matter. This science studies behavior of material and its response when the externally forces are applied to the substances. And rheologically, viscoelastic substances can be divided into cohesive and dispersive. Cohesive substances have high molecular weight, long molecular chain, high viscosity, and they come out of the eye very easily, whereas dispersive have low molecular weight, short molecular chains, low viscosity, better coatability, but it's very difficult to remove them at the end of the surgery. There are 2 new classes of OVDs like viscoadaptive and viscodispersive. Helon 5 is a viscoadaptive which has biphasic behavior at low shear rate. That means in the beginning of the surgery, during capsulorhexis, it behaves like a cohesive viscoelastic, while during surgery, because of the fracturing of the molecules of Helon 5, it behaves like a dispersive. Viscous dispersive substances are Viscoat and Discovis. They are combination of dispersive viscoelastic and cohesive viscoelastic, sodium hyaluronate and chondroitin sulfate. There is no financial interest, but they are the best substances. Now we should know Arshinov's soft shell technique. In this technique, we have to create an immobile space just below the endothelium to protect by injecting dispersive viscoelastic. Just below the dispersive viscoelastic, we have to inject cohesive viscoelastic on the surface of the anterior capsule so that it's very easy for us to do capsulorhexis. And when the phacoprobe is inserted, a soft shell of dispersive viscoelastic remains inside the anterior chamber to protect the corneal endothelium. During intraocular lens implantation, a cohesive viscoelastic has to be injected in the anterior chamber and capsular bag. In the center of cohesive viscoelastic, we have to inject a small part of dispersive viscoelastic. And once the lens is implanted, the entire bolus of viscoelastic can come out of the eye very easily. There are certain special situations like compromised cornea. In these situations, it is better to use viscous dispersive or dispersive viscoelastic. If there is a shallow anterior chamber, we have to create space and maintain the space. In such situations, we have to use cohesive. In small pupil or floppy iris, we have to use viscoadaptive like Helon 5 for viscomydriasis. In dense cataracts, again, the viscous dispersive are better. In congenital cataract, for better capsulorhexis, we have to use cohesive viscoelastic so that the anterior capsule remains flat and it's very easy to do capsulorhexis. In case of posterior capsular rupture, we can plug that rupture by using a cohesive viscoelastic. Few points about Vistacia. There is a combination of lignocaine plus sodium hyaluronate 0.3%, which we can use as a topical anesthetic for better availability of lignocaine. Plus, we can use it intracamerally also during surgery. So clinical tips, like Dr. Navneet said, injection of viscoelastic is also very important. You have to start injecting from the distal end or from the opposite end, and you have to backfill anterior chamber so that all the aqueous is removed out of the eye. If you are using dispersive viscoelastic, you have to completely fill anterior chamber with viscoelastic substance so that there are no squiggly lines. When you are using Helon GV or Helon 5, then before doing hydrodissection, you have to create a space for the fluid to exit. Otherwise, there can be iris prolapse just before the surgery. In infants and in children, to flatten the anterior chamber, you have to inject and re-inject again and again. And one has to take care of all the bubbles because otherwise bubbles can be troublesome during surgery. There is an interesting video which I would like to show, which compares 4 different types of viscoelastic substances. This is Viscoat.
You have a minute left, sir.
Yes, this video is only of half a minute. This is Discovis. This is Heal-On, which is a cohesive viscoelastic. Now I am putting hydroxypropyl methyl cellulose. Note that it is a dispersive, so it spreads. Now this is Viscoat. So initially it beads up, but later on it also spreads and coats the substance. This is Discovis, so it beads, but there is hardly any spreading. And this is Heal-On. It just beads, but it doesn't spread. Now notice when I put saline, cohesive viscoelastic goes out of the antechamber very easily. While though I am injecting fluid at a high flow rate, dispersive viscoelastic doesn't get out of the eye very easily. And Viscoat is remaining there in spite of putting fluid. So to summarize, viscoelastic substances are the best devices for intraoperative endothelial protection. Use of OVD in combination is useful for better protection, and mastering Arshinov's tri-soft shell technique is extremely important for protecting endothelium. I would like to thank again Team BOA for giving me opportunity and congratulate them for excellent scientific program. Thank you.
Thank you, Dr. Santosh. Very comprehensive and very informative. I would like to now invite Dr. Mandar, then the next batsman also from Pune, a very busy anterior segment practitioner actively involved with MOS as well as POS. He's going to be talking about a very relevant topic in opthal, artificial intelligence in cataract management. And I keep reiterating this fact, though we may use artificial intelligence, it is not a substitute for natural stupidity. Over to Dr. Mandar.
Very good morning to you all. I hope I am audible.
Visible and audible. Sir.
Yes, thank you. Thank you, Saumil, for the kind introduction. Thank you, Dr. Lahane sir, Dr. Ragini madam, for the opportunity, and congratulations to Team BOA and Team MOS for a fantastic scientific program. We know that artificial intelligence is being used increasingly in various fields, and medicine is no exception. In medicine itself, artificial intelligence is being used in many areas. As regards to ophthalmology, it has been used mainly in the field of retina, glaucoma, and now increasingly in the anterior segment diseases as well. So just to briefly summarize what is artificial intelligence, it's a science and engineering of creating intelligent machines for a variety of applications. It operates by understanding the interrelation of multiple complex variables. It helps recognize patterns derived from big data. It uses various tools like machine learning, deep learning, and artificial neural networks. So as I said, artificial intelligence has been increasingly used in ophthalmology for the last about 5 to 6 years. And the advantage with ophthalmology is that we generate lots of data, so it needs that data, and we also generate lots of images. So these are the two critical variables that we have, and which we can leverage using the artificial intelligence. It is by and large been used as an additional tool in diagnosis, and now to some extent in management. Now, coming to the application of artificial intelligence in cataract, we know it is the commonest cause of blindness. It is rising because there is aging population, and naturally the treatment, which is only surgical, we are performing 20 million cataract surgeries per year worldwide. Unfortunately, the ophthalmologist to population ratio is still not catching up to what it should be ideally. There are 3 main areas in which artificial intelligence has been used in cataract management. One is the diagnosis, second is the biometry, and third is the workflow optimization. Let's quickly look at each one of these. So as far as the cataract diagnosis is concerned, so AI has been used as a traditional method for diagnosis by using slit lamp based classification. The LOCS3 system. It provides a timely diagnosis in cataract. It's an objective diagnosis. It can also be used as a mass screening tool. It increases the reach of medical facilities to areas which we cannot access, the rural areas or the urban underdeveloped areas. There were many studies which were done using artificial intelligence. This is one of the pioneer and landmark studies which was done in China, wherein universal AI agent was used for cataract diagnosis. The AI-based medical referral pattern to improve the collaborative efficiency and medical resource coverage was the aim of the study. Deep learning versus residual neural network, or ResNet, was the protocol. And there were 3 steps involved in this study. One was the capture mode. Second is the diagnosis using mydriatic slit lamp mode, which classified the images into normal, cataract, and post-operative. And it was also used to identify referable cataracts. As you can see, the area under the curve for all 3 parameters was extremely impressive. There was also one more study done a few years ago in which pediatric cataracts were diagnosed using artificial intelligence. And again, the sensitivity and specificity was extremely high. This is typically what was used, the image types that were used in diagnosing cataracts. So you had the mydriatic slit lamp, the mydriatic diffuse, the non-mydriatic slit lamp, and the non-mydriatic diffuse. And they were broadly classified as normal, post-surgery, and cataract, again subdivided into mild and severe. So this was the flow chart that was used. And after the slit lamp image was captured, it was classified by the artificial intelligence agent. And after that, then depending upon the age, less than 18, more than 18, it was classified as pediatric or adult. And again, it was further classified whether it is visually significant. And if those patients who the AI agent identified as visually significant, they were referred to the medical team. This is just to show you the area under the curve, which was extremely impressive for this evolving technology. So in real world, how does this work? So you have level 1, where you have a mobile device or a slit lamp, which will capture the basic information. The mobile device, which will capture the basic information like the demographic data, the visual acuity, the history. So whenever there is a history of blurred vision, a photo will be clicked. The suspicious images then are graded, which is then referred to level 2, and then the slit lamp photo is taken. The AI agent then categorizes it further into suspicious and non-suspicious images, and only the suspicious images are upgraded to level 3, which are ultimately referred to the ophthalmologist. So this is a very effective way of triaging patients at a very early stage in the cataract diagnosis. By using this AI agent, it was found that 30% referable patients were, there was an increase in 30% of the referral patients. So essentially what it did was that it increased the ophthalmologist to population ratio by 10 times. Now we come to the second application of AI in cataract. That's the AI and biometry. We all know the importance of accurate biometry for a successful cataract surgery. And the acceptable results are less than or equal to 0.5 diopters, unfortunately achieved only in 80% of eyes, unfortunately, because we want 100% accuracy as far as this particular application is concerned. So, but IOL calculation is difficult in outliers like myopia, hypermetropia, or post-refractive surgery. And there is also very poor agreement between various formulas. This is where AI comes in. So this is just one of the examples of use of AI in biometry. This is a super formula designed by Dr. John Ladas et al. This is basically a 3-dimensional framework for areas of similarity and disparity between IOL power formulas. The best portion of 3rd generation formulas are chosen. there is an amalgamation of the IOL formulas, which leads to a super surface from which a super formula is derived. And the graphical depiction of this using multiple formulas increases the accuracy to 100% in all eyes. So this is typically how this is done. So you can see at the in the left figure, there are three at the top, that there are three formulas which are placed one over the other, and ultimately you get this super formula, which is an amalgamation of these various formulas. As far as the third application of AI, you have the workflow optimization. So we know that how important it is to have a seamless optimization of patients in our hospitals. So automated patient scheduling system with prior appointments, prioritization, triaging based on pre-recorded patient data can be done through AI, saving manpower hours and also increasing the efficiency in the system.
You need to conclude, sir.
Yeah, so this is the last slide. So you have the Internet of Things. Again, I won't go into the details because of paucity of time, but this is one more evolving area in the AI. And as far as the future trends are concerned, AI optimized software in monitoring trainees during surgery can be done. AI agents will integrate pre-operative biometry data with post-operative data to increase the efficiency, and also can be used increasingly in teleophthalmology. For those who are interested in reading more about AI, you can always refer to this beautiful book, Deep Medicine by Eric Topol. I once again thank BOA and MOS for the opportunity.
Thank you, Dr. Mandar. That was very crisp. I would now invite Dr. Harshul. Everyone knows him for his social group Life Beyond Ophthalmology, but he has a very, very significant contributory role in Ophthal as well. He being active very much in AIOS, ARC, as well as Rajasthan Ophthalmic Society. He's going to be talking about a very relevant step in phaco. I feel it's one of the most important. If you can rescue or have the perfect capsular access, all subsequent complications can be avoided easily. Over to you, Dr. Harshul.
Thank you so much, Dr. Somil. And at the outset, I'd like to thank entire BOA MOS team, Dr. Lahani sir, Ragini ma'am, Dr. Swapnesh for inviting me. So I'll be sharing this video clip with you, which shows that there are many situations in which we need to salvage the capsular access and how to do it, because we need to know all these things. And we all know that capsular access is the most important part in phacoemulsification. So here the capsular access is being initiated, and look at this. So if you see a situation like this, that your axis is going outwards, you need to stop at that time. And now there is a technique described by Brian Little of pulling in technique. So you need to go and put viscoelastic in front of it to flatten the anterior capsule. Try to grasp the capsule near the base with the microaxis forceps and pull it centripetally towards the center. So once you do this maneuver, you get this rhexis back on the track. So this direction of this pulling is very crucial and very important, and you should have these microcapsular axis forceps in your armamentarium, because you need these microforceps in situations like this. This is another case which was angle closure case, and having very shallow anterior chamber, and the pupil was also not dilated. Now again, see at this step, when I'm trying to make rhexis, is going beneath the iris and it slides down. So now I can't see that where the leading edge is, leading point is. So without seeing, you can't get this rhexis back on track. So what I did here is I used an iris hook, make a side port incision so that I can retract the iris from that side and try to get the rhexis back on the track under direct visualization. So no blind procedure there. So once I put iris hook, retracted, Now you can see this leading, the edge is here. So I again hold it and bring it right back on the track by giving a centripetal pull. So this is the way you can get this rhexis which is going outwards back on the track. And now I take off this iris hook. So don't shy away from making extra paracentesis if you need. Now this is the case done under topical anesthesia. This is the intumescent cataract. So what I usually prefer is to make a very mini rhexis and debulk the capsular bag. So I'm debulking from main port, I'm debulking from side port. So see what happens sometimes, that patient suddenly moves his eye and I'm debulking from this place. You see when the eye moves, because these capsules are very fragile. So at this stage I go ahead and, because this is a weak area here, you can't continue. So I give a relaxing incision cut here with the micro scissors, and then I go ahead and make a capsulorhexis. So once you complete this rhexis here, you see that there is a weak area here. Again go ahead, give a small cut with micro scissors and complete this capsule, because you can't leave that weak area there. And now you have your intact capsulorhexis. Here's another case very fibrotic cataract, the capsule here. So, but the good thing was that the fibrosis was just inside the size of the rhexis which I wanted. But you need to be careful that your direction of pull is always remain in the center and it doesn't go outwards. So again I'm holding it here, pulling it back in the center, complete from one side and give a cut here. So this area is free, there is no fibrosis in this part. So this is the last pull, and in just one go you finish this capsulorhexis here and it completes. Now another case, now here the fibrosis is in the place where your capsulorhexis is going to be. So in these kind of cases you need to cut with scissors, you can't continue with capsulorhexis forceps. If you see this fibrotic area is too large here, so I go ahead, make a small rhexis in the beginning, use bimanual method, hold with my left hand this fibrotic area and put micro scissors from other side and start cutting this fibrotic capsule. So once I reach at this place here, now I can't continue from this paracentesis, so I make one more paracentesis on nasal side, get my microforceps from there. So this entire area is fibrotic, so you need to cut with, I'm just separating this fibrotic area with the Kuegelin's hook. So once I free it, and this is the last part. So you need to use both your hands, micro scissors, forceps, everything. And again I'm cutting this fibrotic area, and that finishes the capsulorhexis. So we have a adequate capsulorhexis here. This is the case which had lens-induced glaucoma, very shallow anterior chamber. It's done under topical anesthesia. You can see I'm not even able to just put my cystitome vertical, and as I start making capsulorhexis, the eye moves, and again see, instead of being curvilinear, it becomes a straight kind of this initiation. So again I go ahead from paracentesis and give a cut here, and so in these cases, as Dr. Santosh has also said, that you need to use sodium hyaluronate or a cohesive kind of viscoelastic, and this completes the capsulorhexis. but this axis is small in size in this area. So again, I give a small cut here and make it to adequate size. So don't shy away from giving extra snip and enlarging it to the required size. And one last case I would like to share, that this is a case of microspherophakia. We all know in subluxated and these spherophakia cases, the zonules are very lax and it's very difficult even to initiate the capsulorhexis. So here, so this is a case, I put viscoelastic here and see, I'm not able to initiate the capsulorhexis with cystitome. So what I use is the RF capsulotomy probe, which is there in the Artley phaco machine. So what I do there is I just go ahead, give a small burst of energy, and it makes a hole in the center. So without putting any stress on the zonules, it's created a very tiny hole in the center. Then I give a snip with micro scissors and complete capsulorhexis. So many times you need to use capsular hooks to complete the capsulorhexis in these cases, but here I was able to do it without capsular hooks, and this completes the capsulorhexis. So I think they are, I have showed many cases and different situations where we needed to do something different and salvage the capsulorhexis. Thank you very much for giving me this opportunity.
Very nice, Harshul. Very excellent videos actually, and very nicely done imaging. I now call upon Dr. Jatinder Bhalla. Everyone knows him to be an excellent academician. He's also won many awards at various levels, be it DOS, be it AIOS, or be it IRSI. I actually happen to know him from an article of his that I came across talking about Q values in IOLs, and I was very, very impressed by that, and I use it very often in my practice. Over to Dr. Jatinder.
Am I audible?
Audible and visible.
Okay, sir. So I'm going to start my presentation. Thank you for your nice words. I'm thankful to Dr. Lahane and Dr. Ragini ma'am for this opportunity. Yeah, I'm just starting screen share.
It is shared, sir. We can see your presentation.
Okay. So cataract surgery is the most commonly performed surgery in the world, and 19 million operations have been performed annually, of which 6.4 million have been performed in India alone. The journey of cataract surgery began in 800 BC with couching, and it has gone to flax, which is the newest innovation. These are the advances which I'm going to consider. The advances in phaco technology are immense. Phaco recently turned 53, and during these 53 years, phaco machines have undergone incremental upgrades. Today's phaco machines offer advanced fluidics, IOP control, and AC stability. These are the prototypes: Alcon Centurion, Stellaris Elite, and White Star Signature Pro. Stellaris Elite has adaptive fluidics with iTelligence. Alcon Centurion has active fluidics with balanced energy technology and applied integration. The torsional and transversal ultrasound are great innovations because we know that in longitudinal bone, the linear movement are repulsive and there is no cutting in all 100% of the stroke. Whereas in torsional and transversal, neither there is any repulsion of the bone, and also there is cutting during both the side strokes. Femtosecond laser cataract surgery is a great advancement, and what we found was that during this technology which was adopted from the refractive surgery has brought us immense advantages in cataract surgery also. But we are still at crossroads and we do not know whether the improved outcomes are really cost effective or not. Highly focused femtosecond laser pulses create plasma that rapidly expands in cavitational bubbles and which creates a cleavage planes. The femtosecond laser corneal incisions are much more better architecturally because there is less endothelial misalignment and the sealability of the flax incisions are much better. The laser fragmentation is also a very important component when we find that there is 51% reduction of effective phaco time with femto compared to the conventional phacosurgeries. This was paper published by Konrad Hengerer in 2009 is the JCRS, where they found that the effective phaco time with femto was significantly less compared to the conventional phaco time. This was a remarkable study which was published in JCRS, and it compared, this is called EuroQ study, where they compared 2,800 flax cases with 4,900 conventional phaco cases. And what did they find? They found that the flax was a major advancement and better than conventional method, although the intraoperative complications were similar in both. So what we find is that flax is better than manual cataract surgery, particularly in complicated cases like white cataract, pseudoexfoliation, iris syndrome, subluxated cataracts, and also in patients with age-related macular degeneration. So flax has helped elevate cataract surgery into a refractive procedure, and the advantages are self-sealing corneal incision. The arcuate keratotomies are big advantage, precise capsulotomies, nuclear fragmentation, the effective phaco time decreases, but there are disadvantages like it's expensive and it takes longer phaco time, and there are limitations in patients with small pupils, corneal opacity, unusual orbital anatomy, and patients with neck and back problems. Then came Zepto, which is another advancement. It is cost-effective capsulotomy, and what we find is that advantages are that it is much cheaper than flax, the strongest capsulotomy, no capsular staining is required, and can be introduced anytime during surgery. And it is also advantages in immature cataract, but the limitations are there that it needs to be inserted in anterior chamber, which becomes problematic in cases with shallow AC where there is more endothelial cell loss. On top of that, there may be inability to open the device and difficulty in taking out the device after folding it. Capsule laser is another advancement where we can make precise round capsulotomy, and it's a portable technology where laser is delivered in single circular pattern, and it is by wavelength of red-orange range of spectrum, where the blue dyed anterior capsules, there is selective laser absorption, and it is also supposed to have excellent ocular safety profile. The intraoperative OCT in cataract surgery is a big advancement, and what we do is that the proper incision construction, we can assess the morphological features of the wound. We can also adequately assess the strobal hydration and wound apposition. We can assess the status of posterior capsule in cases of posterior polar cataract, traumatic cataract, iatrogenic posterior capsular defect. Depth of trenching can be assessed by novice surgeon, and it is also advantageous in white cataract where we can find out the presence of fluid clefts, and position and stability of IOL can also be assessed. Intraoperative barometry is another addition to the armamentarium of calculation of IOL power, and the available technologies are Orange, Aura, Analyzor, and also Holos. The advantage are that it's a fast, accurate, and it gives continuously displayed data, no snapshot results, and it takes multiple readings within 1 second. But the advantage in routine cataract surgery is still not been established. Another advancement which is been published is laser-induced refractive index change, where we can use femtosecond laser at suboptimal energy. And what we do is we can give multifocality to cornea, and this can have diffractive multifocal pattern can be imparted, so the depth of focus in these patients can be increased. Refractive index shaping of and optimization of implanted IOL can be done, where we use femtosecond laser again, and the lens within the lens is created by altering the hydrophilicity of existing standard IOL. And what is done is that after exposure of polymeric material to femtosecond laser radiation, water slowly diffuses into this lens. This causes change in the refractive index of the lens. So what we can do is we can change the power of IOLs. We can convert monofocal IOL to multifocal or toric IOL, and convert multifocal to monofocal IOL. Modular IOL is another advancement, and what is done in modular IOLs that it is implantation of a base unit along with exchangeable optic. So this optic can be changed throughout the age of the patient. This allows for adjustment of the optic throughout the patient's life. Light adjustable IOL is a remarkable innovation where we implant a silicon monofocal light adjustable lens. And what is done in this is that when you bake silicon, entire lens is polymerized and refraction is locked. But in light adjustable lens is half baked. So polymerization is incomplete. So refraction is not completely locked in. So about 10% of this unlocked lens has a photosensitizer attached so that when ultraviolet light hits this lens, it polymerizes and the power can be changed. SIMVIS is another innovation where we have the ability to preoperatively offer simulation of the type of vision expected, so the patient can make a choice of the various IOLs, because preoperatively they can see the type of vision that is being imparted by different kind of IOLs. Gemini refractive capsule is an intracapsular device that has ridges that allows the shifting of IOL in these ridges, so the effective lens position of the lens can be changed. So can the power of the lens, the refractive power of the lens can also be changed that way. New normal for cataract surgery due to COVID-19, I feel can be the immediate sequential bilateral cataract surgery, 3D visualization, which increases the distance between the patient and the surgeon, and also robo-assisted simulated cataract surgery. The ISBCS is a new paradigm. It was advocated by Steve Arshinoff, and there are a lot of proponents for this, and it results in half OR, half OPD appointments, requires less PP for staff, lower clinic costs, and less crowded waiting rooms. So this is slowly making its way, and maybe in the era of COVID-19, where we want the patient to come for lesser visits, maybe this can make its mark. Robo-assisted simulated cataract surgery is another innovation where it is supposed to be the next major advancement, and where we have slave surgical robot that enables restitution of surgeon's movements. So even above of surgeon can keep on continuing the surgery without bothering about their tremors. But the hurdles for use of robo in ophthalmic surgery is the high cost and the absence of specific instruments to match the robotic surgery. Ingenuity 3D visualization system is another advancement, and it is heads-up cataract surgery. And what it does is not only increases the distance between the patient and the surgeon, patient can really avoid having back and neck problems. And this is supposed to be another major advancement. So that's how I have compiled the various advancements, and it appears to be very fascinating developments in store for all of us. Thank you, everyone, for your kind and patient hearing. And I'll end my presentation by saying that every great advancement in surgery has developed from a new audacity of imagination. So we should not stop imagining, and that's how we can keep on having newer innovations. Thanks to BOA and MOS and Dr. Lahane and Dr. Ragini Parekh for this opportunity. Thank you, everyone.
Thank you, Dr. Jatinder. You have actually shown us the future of ophthalmology. My next speaker is someone who's also the future of ophthalmology. He's the first Padma Shri speaker for today. Dr. Lahane sir, I invite you today. He's a born leader. Behind him, not only JJ Hospital has rallied, but also Bombay and Maharashtra. And I'm pretty sure very soon, India will also completely rally behind him. But we are talking academics here, not just leadership quality. He's an academician par excellence. And if he gives us 10 important successful steps of phacoemulsification, I'm sure we need to listen to him. Over to you, Lahane sir, please. Ragini madam, has Lahane sir? He was there.
There, I think, you know what, both of us have lost the Wi-Fi, so something is the problem. I'll just go check and see what is happening. Yeah. So even I lost the Wi-Fi, so I joined from my phone. I'll just go run, check and come back.
Sure. Can I go to Dr.
We
Matthew
can,
Kurian?
Yeah, we can go to the next speaker.
Yeah, I think we can go to the next speaker.
Okay. Should we go to the next speaker with the permission of the chairperson?
Yeah. Please go ahead.
Yeah, I think we can go to the next speaker.
Yeah, Dr. Matthew Kurian has already put his slides. He is the medical superintendent of Chaitanya Hospital, a hospital that is owned by a very close friend of mine, Dr. Unni. And let's go straight on to his presentation. Dr. Matthew, over to you, please. Dr. Matthew, we can't hear you. Maybe you need to unmute yourself.
Yeah. So thank you to Team BOA for this opportunity. And it's 17 years since Charlie Kelman died. And I think this is a good place to put tribute to him. The ideas that I speak from come over the last 20 years of teaching and training phacoemulsification. I have no financial interest in any of the products. So basic phacoemulsification even today is divide and conquer and chopping. And the skills that are required for divide and conquer is to create a trench, which is identify the posterior plate and to crack the trench once you have reached the posterior plate. In chopping, you're attempting to impale the center of the nucleus and then create a lateral separation. Irrespective of whether you're doing divide and conquer or chopping, you remove the segments by essentially the same technique. So when teaching, I came across this problem, which is that in conventional divide and conquer, 2 long crochet trenches were made. And then distally, the problem was that there was a possibility of a punch through the posterior capsule and an unrecognized PCR. And this always happened across the midline. This is what Dr. Toshniwal was also showing. Okay, on the up, and this is because the upcurve of the posterior capsule happens distally and the hardest nucleus is at the center, and then it becomes progressively softer. So a few adjustments are required by the surgeon, and the beginning surgeon finds this a challenge. The challenge is that the phaco tip has to move upwards in the distal portion, and the foot pedal has to ease up in foot position 3 as they come to the softer nucleus. So in this video, we can see what happens. They've already trenched adequately, but then continuing to trench, and then you can see that the posterior capsule is ruptured over there. So the safer modification has also been described about 30 years ago, which is the downslope sculpting. 4 short proximal trenches are made, and then you join them up to create the classical 2 crochet trenches. And this makes it almost impossible to rupture the posterior capsule. So in trenching, the questions that we answer are how long we need to make the trench, and typically we just need to make it smaller than the rhexis. How wide? In a soft cataract, it has to be as narrow as possible, while in a harder cataract, it can be wider because it has to allow the sleeve of the trench to enter, sleeve of the phaco tip to enter the trench. And the majority of nucleus in DNC is removed well away from the endothelium. The final question is how deep it is to be. And this is where I had a confusion, because whatever was given in the books at that time was 2 to 3 phaco tip deep, the quality of red glow, etc., which was all very subjective. So I wanted to look for a method which would be much more objective. And that is where I came across this idea of the lens fiber orientation. So as we start trenching, the initial trench reveals the cross striations of the cut lens fibers. And this is what I term as a superficial trench. And this is useful for doing a petaloid chop in very brunescent cataracts. As we go a little deeper, the proximal subincisional trenches are cut across. But as we come to the central portion of the nucleus, we see the linear fibers on the floor of the trench. And this is what I call as a intermediate trench. And this helps the phaco tip impale in the very center of the nucleus. And this is what I call as a primary chop. Intermediate trench suitable for primary chop. Finally, as we go further deep, you are cut all the cross striations, all the Subincisional fibers are cross striations are vertically stacked and are not visible in the view from the microscope. And what is visible on the floor of the trench is basically the linear fibers throughout the floor. And you can also, in several situations, when you focus, see the posterior Y suture. And this is what I call as a deep trench, which is suitable for divide and conquer. Let us see these in videos now. So here, this is a soft cataract and a small subincisional proximal trench is made. The nucleus is rotated 180 degrees to create a longer trench. Okay, and you can clearly see the posterior Y suture there. So this is where the divide and conquer, the posterior plate is reached, divide and conquer can be performed at this stage. Now, this was just one long in trench. We need to make that into a cruciate trench to get the 4 fragments. So gently shape, since this is very soft, only a minimal amount of force is required. And even in a mature white cataract, you can do this, and the posterior plate can be exposed as we go deeper and deeper. So you can see the Y suture there at the bottom there. The physics of cracking, once you have reached the posterior plate, is fairly simple. The resistance of the posterior plate needs to be overcome by the lateral separating force. When it comes to chopping principles, every book will tell you that you have to impale the phaco tip in the center of the nucleus in X, Y, and Z axis. So X and Y, what you're seeing from the top of the in the microscope view, the ANFAS view, is very easy. Any child will also give that. The Z axis is what comes with experience. And once you impale it correctly in the center, the second instrument exploits the natural fault lines of the nucleus. And this was again almost 30 years back, Nagahara had described this method. So this was published by us in JCRS in 2013. Let us see the video. So here we are doing a small trench. The superficial trench moves into a intermediate trench. You can see cross striations near the phaco tip, and more centrally it is the linear striations, and then impale and a chop is performed. This was a vertical chop that was performed. Dig directly in and then almost touch the phaco tip and then do a lateral separation. Here again, another vertical chop. Dig directly in, almost touch the phaco tip and do a lateral separation. The nucleus, once there is a complete separation of the posterior plate, the nucleus fragment can be brought into the center in the safe zone and emulsified easily. This is already cracked, so just a peeling off the epinucleus and just eating up the endonucleus again in the safe zone. The second instrument does the work. The phaco tip actually sits more or less steady in the center of the nucleus. The horizontal chop is when the phaco tip is impaled again in the center, but the second instrument goes to the equator of the endonucleus, and then there is a horizontal movement of the phaco tip to create the chop. So petaloid chop is a variation of this. This is very useful in harder cataracts. The regular chopper can be used instead of a long sharper chopper. And this is useful for very brunescent cataracts. Here, a superficial trench is made and then the phaco tip is impaled little more distally, not in the core of the endonucleus. The chop that is initiated actually separates the outer portion of the endonucleus, and the core hardest endonucleus just remains there without getting split. Circumferentially, this is carried out. The posterior plate is not split by this technique. This is to sort of open up the petals of the endonucleus to expose the core endonucleus. Once the core endonucleus is exposed, it can be then eaten up, prolapsed into the anterior chamber if required, or eaten up within the protective area of the superficial portion of the endonucleus. Here we are attacking the 4 endonucleus. And once that 4 endonucleus is eaten up, then we have to revisit each of the posterior, each of the rest of the petals and split it at the posterior plate to complete the segment removal. So segment removal in all situations is the same. I will not go into that. So in conclusion, I would say that lens fiber orientation helps us to identify where we are in relation to the thickness of the nucleus. When you are seeing only cross fibers, this is a superficial trench, and the surgical technique that is preferred is the petaloid chop and is used for Brunus and cataracts. When there is cross and linear striations, this is an intermediate trench and is perfect for primary chop and is suitable for almost every type of nucleus. When it is only linear, you have reached a very deep level. It is not possible to impale at this stage. Only divide and conquer is suitable at this stage. Thank you very much for your patient hearing.
Dr. Matthew, those were very clean videos, very commendable, I would say. Dr. Vikas Mahatme, the next Padma Shri in line, I would like to introduce him first, and we'll come back to Dr. Lane sir, as Dr. Vikas has requested me. Dr. Vikas May is, apart from being a Padma Shri and an ophthalmologist par excellence, he's also a parliamentarian. And we actually want people like him to represent us. That keeps up the nobility of our profession. Dr. Mahatme, over to you, sir.
Good morning, everybody. Can you hear me?
Yeah, you're nice and clear.
Yeah, okay. Thank you to everybody, to the organizers. Actually, whenever I want to speak at BOA and MOS, I have very sweet memories, and I have demonstrated surgery, the woodcutter's technique also previously. 3-4 days back, Dr. Lahane asked me, and he gave me an opportunity to talk on this topic. My topic is very simple, and it is, I shall like to share the slides. It is simple, different, and better. Whenever I come to we talk in BOA, I am life member of BOA, and I have good friends like Dr. Natarajan, Dr. Quresh Maskati, and professors like teachers like Dr. K.K. Mehta, and so many others. Friends, coming to my topic, that is simple, different, and better. Okay. Can you see the slides? Yeah.
Yes, sir. Visible and audible, sir.
Okay.
Visible, sir.
So you can go full screen if possible.
Yes, I shall go.
Sir, you can go to slideshow.
Slideshow.
From beginning, go to the leftmost.
From beginning.
Go to the leftmost icon.
Left. From beginning. No, sir. On the left-hand side of the screen.
Sir.
Top left. From beginning.
There is an icon called from beginning.
Green arrow.
Top left.
On the top left side, just below file.
Yeah. From beginning. Yes.
Yeah.
Okay.
That's good.
Yeah. Thank you. So we can be very simple, but still different and better. I don't have financial interest that we every time tell, but I feel we should tell about the emotional interest. I am quite interested in this topic because, and the BOA also, it gives my ideas, it spreads my ideas. So that is my emotional interest that I feel very good whenever I come to BOA. And I am attached to this topic, so my opinion may be a little bit biased also. I shall at the outset thank you everybody, every ophthalmologist, because those who have, everybody has worked during as a corona warrior, and they have helped the people in every way. We have many learnings from corona. That is, the science is the only thing which can save us. That has been proved. beyond doubt. Secondly, the importance of public health, that we have understood to a great extent. And thirdly, we have to be evidence-based whenever we treat any patient. These three teachings or learnings are very important. And one more thing I want to tell, that 3 or 4 years back, I went to the health minister that I want one health center at Nagpur. But at that time, he referred me to secretary also, but secretary was also not aware and they were not interested. What is One Health Center is a concept floated by WHO. It includes the veterinary doctors, the physicians, and environment specialist. So these three together, when they come, they can treat the patient in a better way. They can suggest the policies for the public health in a better way, because we know that in Kerala there was an Epha virus, that in South Africa there was Ebola virus, and that can spread. So unless and until we come together, the veterinary doctors ourselves and the environment specialists, this will not be possible to prevent these outbreaks. And I wanted to have that in Nagpur, and then it was conceptualized, and 100 crores were given to this center and it has been started. And afterwards, secretary came to me that whatever you said was very important, because this corona has also come from the animal origin. We say Pangola, or in Marathi we call it Khawla Manzar. So that is One Health Center. I feel very good that I could start it at Nagpur, India's first center. What we learned from another thing which is possible is the telemedicine. Those who want to have a better practice, those who want to be connected with many clinics, those who want that they should reach to the rural areas, not only rural, even city, other areas, they can do telemedicine. I feel it is not used to a fullest extent. Even private practitioners can have sub-centers where the patients can be seen by way of telemedicine. Even on the street lamp attachments are there. So that is underutilized. Let us utilize this. This is a simple, better, and very effective way. This is what I used to say previously. This is my school where I learn a lot. Yes, this is Masti Ki Pathshala hai. And here there is nothing like a stress. You have to learn this and you have to memorize this or nothing. Similarly, now for me, this is the Masti Ki Pathshala, whole India. As being a member of parliamentarian, it becomes whole India now. I feel of work. This is the difference between what I learned from this school, India. You can see learning is not restricted to only human beings. Any animal wants to learn and to live better. It is beneficial also.
Dr. Ashok, please mute your mic.
So it's not teaching, it is about learning. And we have to learn how to learn. I don't know why we don't teach this or why we do not transfer this, but we have to learn how to learn, because learning is a continuous process. Now also everybody is learning. We want to learn, but not at the cost of the vision of the patient. That is also very important. But how? This is a simulation technique. I have just seen this 2-3 months back only. I used it. But still, I personally feel that the things which we are using since last 25 years in our hospital is more important and is more beneficial, because the skill transfer is very easy and better, and that is on the goat side. If there is a wet lab on goat side, you can teach better. And with that, on the goat side, this is, I think, around 22 years, 23 years or back video is there, because I have not prepared any new video this time. But you can see that I have pushed a nucleus removed by small incision cataract surgery into the goat side after capsulorhexis, and now made a, that was sutured, and now made a new incision from the opposite side. And now my student is trying to do a phaco, learning phaco on that. So this is better way. Of course, after 10-15 years, simulation may be better way, but it's very costly also at present. I personally feel that this should be the way in every medical college, because we are directly asking the students to learn on the patient side. That is not a good thing to happen. Everybody must have a goat or wet lab where in every medical college or every teaching institute, and then only I think this is not very costly, and definitely skill transfer will be better. Though this is simple and better way of doing the things. About my woodcutter's nucleus cracking technique, I have demonstrated this in BOA, MOS, in the surgical workshops, but still I shall like to talk on it because people are benefited. That is what I think. This is my style of nucleus management, which I shall like to propagate. And yes, of course, it's a woodcutter's nucleus cracking technique. Whenever we cut anything we want to cut, a knife is a better way to cut. As you have seen, with that, cut this part, this block. But the challenge is what you see here is if you move the knife, the cut never extend beyond the passage of the knife. That is very important. So it will never go beyond the passage of this knife. That is when. While if a woodcutter is there, what he will do, he will fix one chisel here, and with the X, he will go on hammering. And when he reaches this place, what will happen? A crack will develop automatically, which will extend beyond this chisel, which will extend beyond the hammering of the X. That is very important. And the depth is also there. So your instruments may not go deep, but still you develop a crack beyond that. And your instruments may not go to the periphery, but still you develop a crack. And that is what we want in hard nuclei, especially in Indian context. What happens in Indian context, the nuclei are very hard. We have brown nucleus more common. So this is the way if we go ahead. So in chop technique, what we do is this is a sharp edge and we move like this. But in the woodcutter's technique, this is the thick part, like X has a thick part. The saw will not serve the purpose. It has to be X only to crack. The saw which cuts the wood will not serve the purpose. So similarly, instead of chopper, if we move the tip towards the chopper, that is a better solution. It is simple, different, but still better. And it's very simple. We get fascinated by very instruments which are very costly, but these are the simple ways by which we can improve on. And this is the video which I will like to share with you, but it's a very old video, so you can see the instruments also. The tip of this is a brown nucleus, the tip exposed is more, but you can see once it is embedded, then there is no problem of damaging the endothelium. I have moved the nucleus to the opposite side by 1 millimeter, and then I shall embed it. I have embedded, the chopper is there at the distant part, and now I shall move the tip towards the chopper. And you can see the crack has already developed beyond the chopper. So the crack is already developed. That is very important. And that just you separate. And then you can go. I have purposefully shown you the roid glue, but that is the way So it's so what we do is move the nucleus to the opposite side, embed the phaco tip, and once the phaco tip is embedded, fix it with the chopper, and once the chopper is fixed, move the tip towards the chopper like this. So then you get the crack. So this is a nucleus cracking, hard nucleus, it is better, and we can go ahead with that. Secondly, very simple, one more thing which we are doing it here is whenever we want to put the lenses inside, there is one you can say injector, which is just no screwing. If it is a screwed injector, you have to rotate it, and with one hand, both the hands will be, then you will have to insert with both the hands. But with this, the plunger you have to push, but rarely, once in time, means one in 100 cases, this push may be jerky and it may traumatize the capsule. So what I do is I use a sleeve, which all Indian injectors do have. That sleeve is put on this. So it acts as a shock absorber. So the movement of the lens going inside the eye will not be jerky or will not be sudden thirsting on the capsule. So simple way of reducing the rent in the capsule because of sudden release of the IOL in the back. So this is the another thing. So it's very simple way. Another thing which I shall like to put is the corneal tattooing. We have forgotten this art. Why we are not doing? Because we had previously bad experience of irritable eye and we used to put it on the Bowman's membrane. So what is the simple, different and better way is to put it below the Bowman's membrane in superficial stroma. So when the problem is complex, try a different approach. So what is the different approach? Simple, different and better. If suppose the opacity is in deep lamella, what you will do, this is the look. What we will do is make an incision on temporal side, which is 3 to 4 millimeter. Superficial stroma is there. I am injecting hyaluronidase with saline, that is hyaluronidase with saline, so that the lamellar separation of the cornea becomes very easy. Then I have hydrated it. This is with spatula, iris spatula. I am separating the lamellae of the cornea. I am going in the layers and then pushing the pigment inside, and that is the end of it. So it's a simple but very good way of doing tattooing. And in different things, suppose it is a superficial, if the corneal this way, if it is superficial opacity, then what to do? If this is a superficial opacity with 24 gauge needle, pick up some tattooing pigment and put it below obliquely so that you are in the superficial stroma. This is what is done in case of superficial fine opacities, nebulomacular opacities. Suppose it's totally thesical or something like this, little bit thesical also, but doesn't look nice. Then what you can do, so this is the cut section, you can see like this. Remove the epithelium, then remove the conjunctiva separated. It is little bit you make it away from the limbus, then take the donor cornea, take the lamellar flap of the donor cornea, put it over it, suture it, and in between the two layers you have to put the pigment. So now the look is better. Suture that lamellar graft at E180, and I have done it reverse way, that previously we, because what happens sometimes if you want to spread it at this juncture in between the two layers, sometimes it may go on the sclera which is exposed, so that also turns black. To start with, you have to, I have in this video I have shown you a smaller opacity, but you have to mark the opacity because afterwards it's not possible to see the opacity once you start doing tattooing. So mixture of all these three procedures can be done. So it is a simple, different and better approach of doing tattooing. So that's all about this. Thank you.
Thank you, Dr. Vikas Mahatme. Those were very, very useful tips.
Actually, I'm very much thankful to Dr. Lahane because he invited me to speak on this topic. We know that he is contesting the election for the vice president also now, and I wish him all the best of all his efforts and luck. And I know he is a winner every time. I am very much thankful to Dr. Ragini as well as Dr. Lahane and the organizers, Dr. Saumil also. Thank you very much.
Vikasji,
yes.
Thank you very much. Really proud of you. I'm really proud of you, the Maharashtrian person doing an excellent in India. And I salute you, your work, your devotion towards the work and devotion towards the health. Your all the strategies and planning is accepted by the government of India. And I'm very happy that you are the forerunner for the policies of the government of India in health. And because of you, I think we will definitely lead the country in ophthalmology also. Thank you very much for joining with us. Thank you very much. And also for the support. Thank you.
Thank you, sir.
You are so busy with looking after the people, holding meetings and fighting a big battle in COVID in Maharashtra, in India. Thank you so much for taking out the time. And, you know, for the ophthalmologist, your presence in this big platform is so relieving to us that we are never scared of anything because you are always there.
Thank you. Thank you, Dr. Taki.
Jagatram sir has also joined. Sir Vikas ji has also joined. Jagatram sir is PGI Chandigarh.
Sir, your mic is muted. Lahane sir, your mic is muted.
That was nice seeing you.
Jagatram sir is the chief of this. Jagatram sir, Vikas sir has joined.
Yeah.
Namaskar to Professor Dr. Mahatme.
Thank you, Dr. and Professor Jagatram ji. I know your work and I am very happy that PGI Chandigarh is doing very well under your guidance. Thank you. So I shall take the leave because I have some functions to attend. Thank you.
Thank you, Dr. Mahatme.
Request Professor Lahane sir.
Okay. Thank you. Thank you. Samar has also joined. Samar, welcome, Samar. Jivan, welcome.
Good morning, sir. Good morning to all of you.
Thank you.
Thank you, sir.
Thank you very much. So I think our first session got slightly delayed. The electricity in JJ Hospital, there was no electricity, so I have joined from the phones this one. So I think it was the so I think my topic was there, but I can skip it. You can continue your topic, and I think Jagatram sir. So I can you can start actually Saumil, they can start second session.
No problem.
Samant is the moderator.
Pritam is the moderator.
Mishra sir is not there.
Jivan Titial sir will be taking over as a chairman because Dr. Aryan Misra is not going to join. So Titial sir, please go ahead and continue the session.
Yeah. Over to you, Pritam. Pritam, please take over.
Thank you.
Dr. Lahane, I'm Dr. Mishra speaking. When I saw the program, I couldn't resist to say no to you, so I came. So, all the best. You are doing wonderful, Ragini, and
welcome, sir. Okay,
it's my
very good, sir.
To join and see your faces.
I'm very happy. I'm very happy.
Thank you.
Please go ahead. Please go ahead.
Thank
I
you.
won't waste time, but I have to wish everybody. So pranam, and my respect to all the stalwarts, all the teachers in ophthalmology. Pranam.
Thank you, Ragini. So good of you to see you.
Yes, sir. Go ahead, sir. Mishra sir, go ahead for the session.
Yes, sir. So I'll invite all the chair
It gives me great pleasure to invite Professor Dr. R.N. Mishra, sir, illustrious eye surgeon from Allahabad with many years of ophthalmology under him. I invite you as a chairperson to this session on phacoemulsification. I invite Padma Shri Dr. Jeevan Titiyal, sir, as the chairperson for this session. I also would like to invite Dr. Deepak Athavale, sir, a very dynamic ophthalmic surgeon from Jalgaon. Is he here with us, Dr. Athavale? Sir, I think he has still to join. He will join us soon. Dr. Gopal Arora, sir, has he joined?
Hi, I'm here.
Hi, there you are, sir.
Hi.
Dr. Gopal is our own Maharashtra Ophthalmic Society. He's been the president of Maharashtra Ophthalmic Society, Vidarbha Ophthalmic Society, and he's been a guide and mentor to me for for all the work we've done for Maharashtra and Bombay Ophthalmic Society. Welcome, Dr. Gopal. And with that, we will start this session, the second session on phaco. I would like to invite none other than our dear Dr. Jagatram sir, who's currently director of PGI Chandigarh. He's been a teacher and mentor for many generations of ophthalmologists all over the country. And today he's going to speak on multifocals in children. Sir, the stage is yours, sir. Dr. Jagatram sir, welcome.
Thank you very much, Dr. Preetham. Professor R.N. Mishra, chairman of the session, Professor Jeevan Titiyal, Dr. Deepak, Dr. Gopal Arora, Dr. Preetham Samant. First of all, I am thankful to Professor Lahane and Dr. Ragini Parikh, that Bombay Ophthalmological Association and Maharashtra Ophthalmological Society invited me for this symposia, and it was nice to see so many people. I have more pleasure in meeting you than speaking on multifocal IOL. I will be today speaking on the use of multifocal IOL in children. Although we are very commonly using multifocal IOL in adult, but its use in children is very, very limited, and we are using selectively. And because in children we most commonly use the monofocal IOL, and among the multifocal, among the premium IOL, we use toric IOL more commonly, and then followed by this multifocal IOL. Aim is to achieve a high grade of binocular single cataract surgery, the loss of lens. This can be provided by the multifocal IOL. So as it is shown, these are at least two type of them, refractive design. These are the have several concentric ring with the different curvature for distance and near zone, and diffractive design, concentric ring over the entire surface of the IOL. These are the Technis multifocal IOL and Acrisof IQ Restore IOL. These are older design, and among the newer designs are Technis Synergy continuous range of vision, and Technis Symphony extended range of vision of the IOL. And here are the Atliza Tri 839 MP IOL, that is from Zeiss, and Acrisof IQ Panoptix IOL. There are several issues of concern while we consider multifocal IOL in children, because while we do posterior capsulotomy, that can compromise the centration. Rapid axial length growth in the first 2 years of life is another issue. That's why we do not implant IOL in the very, very smaller children. Uncooperative, these children may be uncooperative for biometry. Practical compliance is an issue. Amblyopia is another issue, particularly unilateral cataract, and there may be marked capsular bag fibrosis. This is our study which we have carried out, bilateral intraocular lens implantation, that is monofocal and multifocal. These were the children 5 years and older. This study shows
the presentation
spectral independence for near and stereopsis was better in children with multifocal IOL. Similar contrast sensitivity and PCO rate was seen among these groups. So it concluded that multifocal IOL in children is a viable and safe option in children. These are some of the other studies of multifocal intraocular lens implantation in children. And this is some other study of multifocal IOL implantation with the pediatric cataract surgery. In our study, what we did is children were more than 5 years of age because till that time there is stabilization of the axial length. We can achieve accurate biometry. We took the informed consent from the parents or the guardian of the child. While the contraindication were chronic and recurrent uveitis, complicated cataract, preoperative nystagmus, corneal pathologies, and retinal pathologies. Intraoperatively, we have to achieve a well-centered, continuous curvilinear capsular axis. IOL as should be covered circumferentially with capsular axis. IOL must be in the capsular bag. A well-centered primary posterior capsulotomy, if it has to be done, particularly we did from 5 to 8 years of age group. This is one of the child, 15-year-old boy who had bilateral developmental cataract. Here, this is removal of the cortex from the capsular bag. And so any of the cortex from the bag has to be removed. And we are implanting 24 diopter IOL. And it must be implanted into bag. And you have to remove the viscoelastic from behind the IOL and in front of the IOL to ensure that there is no viscoelastic left. Otherwise, there may be high intraocular pressure in the postoperative period. These are other children because there is much more fibrosis. This is a child, 12-year-old child, bilateral Alcon Restore IOL is implanted. This is another child, 14-year-old, where Symphony IOL is implanted in the capsular bag. These are some of the other studies showing, published in American Journal of Ophthalmology, of the trifocal toric and bilateral. Here we have also used Panoptix IOL in the child. This is a 5-year-old girl having zonular cataract. This is preoperative anterior segment OCT. This is a classical zonular cataract. And here is a continuous curvilinear capsular axis followed by hydrodissection and removal of the cortex from the capsular bag. And here we are doing capsulotomy with the vitrectomy cutter, although we do several times with the Utrata forceps also. Here is a Panoptic IOL which is implanted in the bag, and we removed all the vitreous tag and as well as removed the viscoelastic. So here is this child is reading that this is the near vision of the child.
इधर को थल्ले को, ठीक है। उसको थल्ले वाला बताओ, तान, ठीक है। उसको थल्ले वाला बताओ, वेरी गुड।
And this is in the post-operative period, you can see well-centered IOL. So key to success is accurate biometry. IOL power calculation has to be accurate. IOL power should be IOL power should be undercorrected, meticulous surgical technique, and you have to do very selectively the accurate selection of the children for IOL implantation. Take home message is that spectacle independence for distance, intermediate and near visual acuity, better stereopsis, clear near vision for playing and school activities, and smaller children may not be compliant for glasses and contact lenses. So multifocal IOL is a safe and viable option in selective group of children. It may not be all the children where we can implant these multifocal IOL. Thank you very much. Once again, I am thankful to Bombay Ophthalmological Association and Maharashtra Ophthalmological Society, particularly Professor Lahane and all the team members for giving me this opportunity to speak on this topic. Thank you very much.
Dr. Jagat Ram, thank you very much for the brilliant and excellent talk. You are, after all, the top person. May I ask one question to you, that which trifocal you prefer in children, whether Alcon Panoptics or Symphony or other, and what age you prefer to start this multifocal IOL in children? And then will you prefer the monofocal IOLs or multifocal IOL in children?
Sir, by
below the 5 years of age.
Yes, sir. By and large, we are doing almost 98 or 97%. These are the monofocal IOL which we are using in children. That is our first IOL of choice. But where we are using selectively these multifocal IOL, age group of the children is more than 5 years, and they should not have any contraindication for multifocal IOL implantation, such as there should be no corneal pathology, there should be no retinal pathology, there should be no corneal opacity, or there should be and axial length should also be well developed. And other is the type of there should be no such as astigmatism. If it is more than 1.5 or more, we are trying to avoid. As far as this IOL choice is concerned, this is variable, because when we had Restore IOL, we use that Restore IOL. After that, when we had the Symphony IOL, we use Symphony IOL. Now at present, even those depending upon the affordability, we do not pressurize the child or their parents that, okay, you have to use this IOL, but if they can afford, only then we go for it. So Panoptics is one of our currently what we have used. So choice is very, very limited, sir, and indications are also not universal.
Dr. Jagat Ram, I know I fully agree with you, but may I ask another question? At what age, minimum age, you advise to people like us to do the IOL implantation?
But actually, we have not used in less than 5 years of age. We considered 5 years, and then also you have to adjust the IOL power, because there is still axial length elongation from 5 years till 18 years. You expect increase in the axial length, so that under correction that you have to calculate. So, sir, you have to go deeply into this multifocal IOL implantation into adult, only then we can understand. Particularly children, it is much more difficult, sir. Very rightly said, sir.
Thank you very much for the giving all information about the IOL. Thank you so much.
Thank you, sir.
Thank you, Dr. Jagat Ram, sir. I think we'll move on to the next talk in this session, and that is none other than Professor Dr. Amar Agarwal, sir. Welcome, sir. Good morning, sir.
Nice seeing you, Pritam.
No, I think sir doesn't require any introduction. He is the head of the Agarwal Group of Eye Hospitals, and I will just describe him in one sentence. Sir is the innovator and icon of progressive ophthalmology all over the world. Mind you, not just India, all over the world. So with that, I invite Dr. Amar Agarwal, sir, to present his topic on glued IOL in sticky situations. Sir, please.
I'll just share my screen for a second. And
Professor Amar Agarwal.
Sir.
Welcome you. I'm seeing you. When I saw your name, I just thought I must see you. You are looking 20 years younger than what I saw 10 years back to you.
Is the screen coming full screen?
Yes.
Okay.
Yes, we can see.
First of all, pleasure to see everybody there, especially Professor Mishra, Preetham, Professor Lahane, Ragini, and the entire team for inviting me here. Let me first see this case. I'll show you. Someone had implanted a PCIOL in the AC. Now, what I thought was, I'll take out this PCIOL, transfer it from the anterior chamber to the posterior chamber. But look carefully, it is stuck to the iris. So I didn't know what to do. I thought, let me enter the anterior chamber. But in the bargain, look what my knife did. It cut the haptic. Now I was stuck. I had no other choice, but I have to explant this IOL. So I'm trying to remove this haptic. Remember, I was trying to transfer it from the PC to the AC to the PC, and I'm not even able to remove it. It's so badly stuck to the iris. I'm using two hands, still not working. Never implant a PCIOL in the AC. That's not the place where the lens should go. And see the complication it has created. Now, I don't know what to do. So my only other alternative is I have to cut my iris. I'm chewing up the iris, trying to then separate this iris from the haptic. And you can see how much of chewing up of the iris I have to do to explant that broken haptic. I don't want the haptic to fall down, so I'm using the handshake technique to explant the broken haptic. Now, once the haptic has come out, the remaining portion of that IOL also I have to remove. So again, I'm going to use the handshake technique and explant this IOL out. So far, so good. Now look at my second problem. I have to do the glued IOL. I already have a large incision. So all I can do is implant it like a non-foldable IOL. One haptic is out. Now I'm going to externalize my second haptic using the handshake technique. Both haptics are out. Look carefully the amount of haptic externalized. It's a lot. I create my Gabor-Charrier 26 gauge pocket, tuck it inside, suture it. But look at my problem. I had created this iris defect. So now I'm trying to repair it with a single pass 4th row pupiloplasty. It's a very simple technique. You need a paracentesis only on one side. Remember the number 4, and that's it. You don't have to lock these sutures. That means you don't have to do a 3-2 throw. It's just once. I've done one side. Now I'm doing the single pass 4th row pupiloplasty on the other side. I need to make that pupil smaller. Once I have done the other side, see the portion on the top superiorly, it's still wide open. So I'm doing the third portion. Now the next thing which I want to show you is this new technique which we started, which is the trocar assisted hangback technique. If someone has an iridodialysis, fix a trocar. This is a modification of Michael Snyder's hangback technique, in which I'm using a double arm Prolene, but first I fixed a trocar which makes life very easy. Pull it and suture it. Now wherever the iridodialysis is, I am now fixing my trocar right opposite that. Now you see I'll take a double armed 9-0 Prolene needle. So now you see it goes through the trocar. Now it will go through the iris. And then from the other side, you can take a 30 gauge needle through the sclera, railroad the two, and pull that out. The advantage of the trocar is it becomes fast. It will not get stuck. My incision, the suture will not get stuck in the corneal incision. So you see now I just pulled out the first suture. Now I take my second arm of the same double arm Prolene, pass it again through the iris, then through the sclera. Now you've got both arms. All I need to do is pull. See, I'm pulling it, and you can see my whole iridodialysis has become repaired there. Now look, when you do that, the gap has become again large. So again do a single pass 4th row pupiloplasty. In other words, I'm doing a two-fold technique. I did first a trocar assisted hangback technique, followed by a single pass 4th row pupiloplasty. Look carefully at the Purkinje image, and you can see the Purkinje image is hitting the iris. It's not on the pupil. The reason is you can see a iridodialysis superiorly also. So again, I'm fixing another trocar right opposite that iridodialysis. Once my trocar is fixed there, again, I'll do the trocar assisted hangback technique. So now watch carefully. I'm passing my double-armed needle through the trocar. It's a technique which any of you can do when you go back to your OR once the lockdown is over. You'll see now, I just pass my 30 gauge needle from the sclera, railroad the two, bring this needle out. Once my first arm is out, same thing I'll do in the second arm. So again, you see it goes through the iris. So fast this can be done. And now all I need to do is pull it. My game plan is very simple. I need to pull it in such a way my pupil and Purkinje image match. Now look at the Purkinje image. P1 is centered onto the pupil. And that completes this case where I've shown you glued IOL, trocar-assisted iridodialysis, and I've also shown you the single pass 4th-row pupilloplasty. Saying that, I'll just show you the last video which I wanted to show you quickly about, and that is another case of a complicated glued IOL situation in which you can see a patient has an anterior chamber IOL. But look at this case. Here, the cornea has become so bad. In the first case, I showed you the PCIOL implanted in the AC, where it was a bad case. The cornea had not gone this bad. But this is the next scenario where if I leave it like that, you can see the cornea has become so bad. I'm taking off that epithelium, and you can notice that anterior chamber lens fixed inside. All I do is fix my trocar for fluid inside the eye. I'm making my two scleral flaps, and you'll see my two scleral flaps there, created there 180 degrees apart. Now, always in such cases, I do not know what the surgeon has done behind. So all I will do is fix a vitrectomy inside, because I want to go in and see somebody might have dropped an IOL, a nucleus, something inside. I always check, is there anything inside? Now I have to explant this AC IOL. So you see me now, I'm going to explant this AC IOL. The problem with these AC IOLs are, these haptics are quite bad. They get locked onto the iris. So when you remove them, you have to be very, very careful. And this is the type of spider type of lens which is implanted with 4 haptics, which are very bad to the iris. So after I'm removing them, you can see them broken. So partly I'm removing it. Now you can see one more haptic coming out, and the last haptic is still stuck inside the iris. I need to remove this carefully before it gets too locked inside and produces a bleeding. And I'm trying to do it with 2 hands, but look carefully. Even when I'm doing that, slight bleeding has started. But luckily for me, my fluid is still on. So the pressure prevents further bleeding. Do my vitrectomy some more. Now take my glued IOL. Again, in this case, as I've shown you an AC IOL, I don't need to inject the lens inside. I can just use it like a non-foldable IOL because I already have a large incision. So it becomes very easy. One haptic is out. Do the handshake technique. Do now transfer the haptic from one hand to the other and externalize the second haptic. Now remember, once you have tucked this glued IOL inside, I need to make my pupils small. Why should I make it small? Because 1, if there is a closed angle, it will become open angle. 2, my air will remain in the anterior chamber. 3, I will make it like a pinhole pupil. So you see in the single pass 4th-row pupiloplasty animation, I've taken the Prolene, passed it from one end to the other, bring the loop out. Remember, you need a paracentis only on one side. Remember the number 4, put it 4 times, pull it on either side, and that is game, set, and match. So you can see that on the animation. Same thing I'm just doing in actual surgery here. Once I have brought this needle out through the paracentesis, all I do is bring this loop out, put it 4 times through that loop, and that completes it. You notice my assistant is holding an endolumeter from outside to help me see better. Now, once I have done that, my next step is to fix air in the anterior chamber. Remember one thing, I need air going in the anterior chamber because I can then do my desmotorexis very comfortably. So you'll see me doing that just now. You can see there's air is there. Now you create the bubble. This is the type 1 bubble. Remember, look, you're looking at the endothelium. So where is the air? You have the endothelium, Descemet's, Duas layer, then the air. This is PDEC. We never do DMEC. We never do D6. Because please understand, in D6, you're taking a very thick cornea. In DMEC, the donors are above 50. So here you can see now, I've got trocar in the anterior chamber. This is an air pump assisted PDEC. All I need to do is take off my endothelium and Descemet's, which is bad. Once I have removed it, all I need to do is take my graft, PDEC graft, which is just 25 micron, inject it in through a normal injector or any technique you want, unroll it, and once it gets unrolled, put air inside and fix it. The advantage in PDEC, why we never do DMEC and DSEC is this. 1, I only use under 35 or 40-year donors. We never go older donors. and we can move the graph wherever I want, not like in DMEC, which tears. Apply the glue, seal the thing down. Let's see the final case to end this video. This is the case when it is completed now. Now let's see how the case looks post-operatively to end this particular video. So you can see now on table how the patient is looking. Now let's see the patient post-operatively, how the patient looked on the table here. 2 weeks post-op, you can see the patient improved to 636. 1 month post-op, you can see the preoperative picture on the other side here. 2 months post-op, you can see how the patient has come to. That's 3 months post-op. And then you can see now the final picture, 9 month post-op. Look at the pre-op scarred cornea and post-op picture where you've done a glued IOL, SFT, and PDEC. I want to thank once again Professor Mishra, Preetham, the entire team of BOA, Professor Ragini, and Professor Lahane for this session. Thank you very much.
Thank you very much, Amar, for a wonderful job.
So I would like to thank
Amar,
yes,
thank you very much for joining.
Thank you, sir.
Thank you, Amar. Thank you very much. Thank you. Go ahead.
We'll move on to the next topic with the permission of the chair. Next is
Preetham, can I interrupt for a second? Sorry, I must thank you, Amar sir, from being a mentor and everybody here today. In 2007, outside a hall, Mishra sir, Shroff sir, and every Basak sir, Jagatram sir, all of you are family, first family. In 2007 or 6, we were outside a hall for a SICS program, Tityal sir, and Amar sir was in the neighboring hall. He comes up to Lahane sir and said, "Ki arey Mumbai badhao, tum karo, tum take over karo, tum karte raho." And from there, Lahane sir's journey started. He's a mentor, guide. All of you are. Without all of you being present here today, in spite of all your busy schedules, big hospitals, directors of PGI, Tityal sir in AIMS with such a huge workload, RN Mishra sir has somebody in the hospital, Shroff sir, Samar Basak sir, all of you are our mentors and guides, and it is you who have made BOA a success. Amar sir, what did you start in 2007?
But I think, Ragini, what Lahane sir, Jagat, Jeevan, all of you people are doing for Corona is something phenomenal. I mean, you people are leading from the front, and this is a really bad disease, and which all of you are fighting so much. Really, hats off to you, Professor Lahane sir, and all of you.
And sir, one more thing is that this whole idea of 4 Sundays was Preetham's idea. He said that we should spread it apart so that, people have time, and working hard as the president of BOA. Preetham is such an integral part of Dr. Lahane sir, his son. And the credit of these 4 days goes to Preetham.
Thank you, those kind words, madam.
Sorry for the interruption, Tityal sir, Mishra sir, so sorry.
So we'll proceed ahead. We have none other than Dr. Ashok Shroff sir. Welcome, sir. Dr. Ashok Shroff sir is a very senior ophthalmic surgeon with a vast experience. He's from Navsari, and he's going to talk on effective phacoemulsification in cataract with corneal opacity using the advantage of chandelier light. Dr. Ashok sir, please share your screen. I would ask all the chair to please give their comments. Dr. Gopal sir, Dr. Deepak sir, after the talk gets over, please feel free to just unmute and your comments.
And I forgot about Mishra sir. When Panna was studying here, he was the one who pushed Lahane sir. Mishra sir, I can't forget your encouragement.
Thank you, Ragini. Thank you so much. So good of you. Thank you.
Ready?
Yeah, we can see the slides, sir.
Yes, thank you. Good morning, everybody. And at the outset, I thank BOA and the Maharashtra Ophthalmological Society, particularly Dr. Lahane and Dr. Ragini, for having me invited here with the stalwarts in ophthalmology. I would like to share my experiences with this little novel technique. No, this is not very new. It has been an old one, but we have been doing this about 2 years now, and with that we are very, very happy. The surgery in the cataract with the corneal opacity is difficult because of poor visibility. There is a lot of reflection of scope light from the corneal opacity surface. Then the the poor transmission of the scope light. In such cases, there is a lot of scattering. Then the less scope light it goes internally. So the internal structures are poorly illuminated. And when it comes back through the cornea, again they are curtailed. And when they reach the surgeon, it is very, very little. So moonlight phaco we introduced way back in 2001. And I had my first presentation of moonlight phaco in 2003 at ACRS, where we put the scope light off and the illuminated chopper or the illuminated probe, what we use in a vitreal surgery in the anterior chamber, so that the structures are illuminated properly and the surgeon's view becomes a little better. You can see here, that was the first. See, here we are using here the blunt pipe. But see, the structures in the anterior chamber are very well illuminated. You have to put the scope light off. You can see that. The limitation is it's a blunt pipe, so the cracking is a little difficult. And you can see with the scope light on, the structures are poorly visible. Then we have developed illuminated chopper with the help of Epsilon. You can see that this is a chopper with illumination, and it goes into the anterior chamber through limbus, and the structures are better visualized. And but there are limitations of even distribution of light. It gives you the illumination only where the light falls on the structures. So again, difficulty, but still you can do that. In this, by using the chandelier, we have used in 36 cases. Of course, this is a little old slide. The numbers have increased now. And the cataract is very important. The cataract has to be between 3 and 4, not very hard, because we have not done yet. And the mean IOP was normal. The central corneal opacity was in 26 eyes, and the central and paracentral in 10 eyes. The concept is the illuminated this fiber optic, the chandelier is introduced to the pars plana into the vitreous cavity. The whole vitreous cavity is illuminated, and then you can see here through the scope.
The central lexus in the central part, center to the capsular plaque, which is there. The
you can see here.
Now I'm creating it. Once it has been created
to the pars plana, the chandelier light source is introduced here.
The second case, I'm going in with a flat, dissector.
I use some other voice too.
Created different
now the scope light is put off and the rexis is being made. You see the very good illuminated pupillary area. It's very, very easy then, because now both the hands are free. You are doing a normal phaco because you have introduced the light source to the pars plana. So both of your hands are free. The hydrodissection is done. The nucleus is rotated. You can see that it's very good. And you can start doing the sculpting and then the cracking. Very well seen. It is rotated, and now again it is cracked. See, each and every detail is seen very clearly through the scope, because of course our view is always better than the video recording. So it's now you can see the cortex is brought into the center, and it's difficult, so we will use the coaxial and will remove the cortex. Now the incision is enlarged to facilitate the foldable IOL. Now here the scope light is also on, and the chandelier light is also on. While rotating, you can see that it is beautifully seen, and the loop is put into the bag. It is done just to facilitate the inferior vision, and you see the very thick corneal opacity. Now these cases, now they are long-standing This is very interesting case. It's a very thick corneal opacity covering almost all pupillary area. Now this patient has corneal abscess. It is resolved. Now it is left with the corneal opacity, very thick. Now I had two minds whether I should go for the corneal graft first and then do the cataract, or whether I should go for the combined procedure, corneal graft and the cataract and the lens. But then I decided, because of this chandelier light, because I'm sure that it would give me a better visualization during phaco. So I wanted to do phaco. This is what I did. And now, no sooner the eye donation is available, eyeball is available, material is available, we'll go for the corneal graft. Now you can see here, in spite of very thick corneal opacity, pupil is small, so we have done the enlarge with the capsule care. Now you see the pupil glows so good. Okay, so the procedure becomes so easy. You can see that the cracking, sculpting, cracking, beautiful glow. In spite of so thick corneal opacity, it is easy. Now both the lights are on, chandelier as well as the scope light. Just wanted to, we have already introduced the lens, little do the sphincterotomy. This is very thick corneal opacity. And now this is the last, the end of it. What we have done, what we have observed, that the rhexis is not that easy in all cases. It was put in 14 eyes, but it was irregular. Either it was large or small in 22 eyes. There was small intraoperative PCR in 2 eyes, which we could manage with the vitrectomy. Foldable aspheric hydrophobic lens were implanted in all creases, in the bag in 17 and in sulcus in 19. The postoperative visual acuity corrected was finger count in 3 meter to 6 by 60 in 6 eyes and 630 to 680 is 22 eyes. This is quite good with the corneal opacity because it was a long-standing corneal opacity, and in 612 to 69 in 8 eyes. So phaco in cataract with corneal opacity is a challenge because of poor visibility, risk of intraoperative complications. But visibility can be improved by endoprobe in anterior chamber. It is a cold light, so it's not going to harm the structures. Then we have developed illuminated chopper, and then of late we have been using chandelier light, 2 pars plana, where we have used, now you can use 2 sources, either xenon bulb, which is a 750 nanometers to 2000 nanometers wavelength, and LED bulb, 400 to 700 nanometer wavelength. So we have used indigenously made LED light source, which is made in India. And when the scope light is off, the illumination becomes superb. The procedure becomes very easy. Complications are less. Anatomical and visual recovery, very satisfactory. And there is no threat to retina. So to summarize, 36 eyes were selected for this. Indigenous LED chandelier light source was placed in vitreous cavity 2 pars plana. Excellent glow in pupillary area to accomplish all steps of phaco and ion insertion. Intraoperative complications were very few. Post-operative period was good with reasonably good recovery. Thank you very much.
Thank you, Dr. Shroff. It was an eye-opener, and I'm sure watching such innovative videos motivate all the general ophthalmologists to taking up something different, something new. It was a wonderful talk. I appreciate, sir.
Thank you.
Well, I'm going to invite next Dr. Samar Basak. The name needs no introduction. And had the Calcutta conference not being cancelled because of the pandemic, we would have witnessed the hospitality Disha Hospital is known for. So over to you, Dr. Samar Basak, to tell us more about the challenging triple procedure.
Thank you. Thank you, Dr. Lahane sir and Dr. Ragini for this wonderful morning. I am sharing my screen. Yes.
Thank you, Basak sir, for being here. Thank you so much.
So I'll be talking on challenging endothelial keratoplasty triple procedure. Already we have seen beautiful videos of Dr. Amar Agrawal and Dr. Sharaf, and all are challenging to do a cataract. But I'll show the 3 cases. One was pretty long time, and recently I have done 2. So this is case 1 with advanced Fuchs with cataract. You see the left eye is already the normal keratoplasty PK triple, and you know the condition is like this after 2 years. So what I decided to do a SICS triple in this case, a manual SICS with manual dissect. You see the visibility is so poor. So only I think those who are doing SICS, they always tell that they are doing in their spinal level. So you have to be very careful in these cases not to damage the posterior capsule. That is the only thing. Deliver the nucleus. It is not so hard. Cataract grade 3 might be. The epinucleus and cortex has been washed away. And the visibility is a little poor. This is a PMMA IOL given in the posterior chamber, maybe in the sulcus, maybe in the back. So we did desmetorexis under Hilon, and after removing it, then wash the rest of the Hilon, then put a dissect graft. And you see that the dissect graft is opened and air was given to give internal tamponade. Graft was centered, and you see that it is basically a sutureless procedure. So this patient, after 12 weeks, you see that patient vision is 6/12 part and excellent visual recovery of this eye. So this is another patient. He is one-eyed, referred for PK IOL, and this patient has multiple attacks of herpes simplex viral endotheliitis several times, and other eye was lost in early childhood. So you see that there is severe vascularization, and you see that then only this supratemporal area is a little clear vision, clear cornea, otherwise the cornea is very thick. So what to do? Do I go for PK triple? We know that PK with HSB is not a good option. So we started with oral prednisolone and oral acyclovir 7 days prior to this. And on surgery day, I planned for actually SICS. Then I thought, why not try a phaco in this case? So visibility is only, I didn't use the chandelier kind of light, but if you have coaxial, this microscope, this Lumera, it is excellent view. You do the Rexis, it is not so hard cataract. And gradually I am operating from the superior approach, and I do stop and chop in this type of cases because the visibility is not at all there. And ultimately I could do phaco and then cortical cleaning. And I put a single piece hydrophobic in the bag, extend the incision because I planned for it for dissect surgery. So this desmetorexis is tougher because of adhesion at the inferior nasal part, and I remove it. Then this is also a dissect, and you see that you just put the graft. I am a very fond of dissect, already completed my 1500 dissect in recently. So I do, the people are doing very good. Over a period of 15 years I am doing, then centering of this graft, and you see that it is also a sutureless surgery. So I put the patient on prednisolone and acyclovir for a longer period of time, and other medicine. You see on the 7th, the picture is horrible. And you see there is stromal necrosis of herpes, and it has been aggravated. So what to do? I started on acyclovir ointment, and I increased the topical prednisolone dose. And you see that on day 21, it is gradually reducing, and there are areas of lipid keratopathy, and you see the vascularization on right side of the picture. Oral acyclovir continued. This is 6 weeks. You see that opacity is much less, and there is still vascularization. The patient continues. The lipid keratopathy areas also reduced. This is 3 months. You see that picture is much better. The patient is having 6/18 PARD vision, and this is after 6 months. And you see that good specular morphology, good count, and the patient is continuing with oral topical prednisolone and oral acyclovir for another 6 months. So very happy picture. So this is my 3rd patient, again a one-eyed patient, 58, farmer from Tripura, and you see that referred for PK triple, and he is also recurrent herpes simplex keratitis in various form. You see the cornea is barely visible, only PL visual. You see that there are severe vascularization. We know that PK will be not a good option for this. So I am showing this video I presented earlier. So USG B scan is normal in this patient, and you see that ASOCT picture, there is thick epithelium, and so all 3 options are there: PK triple, DSEC triple, and maybe DMEC triple. So PK triple is a pharma suture related problem. DSEC triple, if cataract surgery then done, then why not DMEC? And we accept that this can be done. So again, like previous patient, we started with the oral valacyclovir and prednisolone. This is on table. You see that the thick epithelium, when you remove it, you can have certain vision. So it is just I planned for phaco. You see the amount of vascularization, 360-degree deep vessels. So this microscope is better, but when you go in, there is again corneal edema increases, and you see, then I removed the Desmet. I thought my vision will be much better. Clarity is little better. And I take the whole thing in the anterior chamber. I thought I have to save the posterior capsule because anyway I am removing the endothelium. So anterior chamber phaco was done in this particular phase. But I was stuck with epinucleus because my visibility is so poor. I just converted, increased the incision so that I could remove it manually. Then you see that this is just before IOL implantation, visibility much better. And you see that I removed that whole viscoelastic. I did one inferior PI that is important. Desmodex is already done. So I do always prefer DMEC because I never tried PDEC, though I started long time back. Then this is my typical procedure of doing DMEC. And you see that I taken the graft in the injector system and then put the graft inside. And it was a large incision. I have to put suture, otherwise there is a chance of graft being out. So then with the play of BSS and tapping, I unfold the graft and then I put the AR, and you see the S stamp is normal. So I have, but when the suture broken and it was not replaced because it is a good incision. So again, this surgery was a totally sutureless surgery, DMEC triple. And this is post-operative like previous patient. Patient was receiving antiviral and steroids. And you see that first day picture, graft well attached. That was my concern. This is day 5, vision 2200. And this is 6 months. You see that patient 2060, cornea clear, compact, and vascularization gone. So ASOCT perfectly, and this specular count is also showing good. So this patient go back to his work after actually 3 months of it. So he was a farmer, he has to work in the field, and there is no risk of the graft, except that he has to take antiviral and antifungal. Life is beautiful. Thank you very much for your patience sharing.
Thank you, Samar. Wonderful presentation. I know that I think world over you would be the most experienced endothelial keratoplasty surgeon.
Hello.
And, you have been a great teacher to
I cannot
all of
hear
us.
you, Jiban.
Can you hear me?
Please unmute.
I'm unmuted.
Okay, I can hear.
I think you've been a great teacher to all of us, and the presentation you have showed us are a great teaching videos. And I think you and Dr. Shroff rightly talked about handling cataract in corneal disorders. And it is very clear the type of corneal disorder will decide what type of surgery you're going to plan. And endothelial disorders, like you showed, herpetic disorder, and the decompensated endothelium, you could do any type of surgery. And with your experience, you can do a DMEC in these cases also. But Dr. Shroff very nicely showed a difficult situation in cataract where you have a corneal scar, where sometimes patient may not have a good ocular surface, or sometimes patient may be one-eyed, where you may not like to do a corneal procedure. There, I think you're bound to do those type of cataract surgery. And most importantly, as he highlighted, visibility is the key point for a success in these cases. You might do a phaco or you might do SICS, but once you see clearly, you can do a good surgery. Only thing I want to add in those cases, after we complete the phaco and implant the IOL, we might, reconstruct the pupillary size in these cases as per the opacity. Sometimes your opacity may be paracentral, or it may be you can make a pupil slightly open to the area where your cornea is clear. So that might improve the visibility for these patients. So these type of optical iridectomy or a reconstruction of pupil, we have found the vision does improve better in these cases. Otherwise, sometimes what happens, your opacity is too big and doesn't allow gross improvement. So that can be one option. But as Dr. Basak talked about, we being a corneal surgeons, more often we like to have these opacities removed so that patient can see better with better understanding of endothelial keratoplasty. Even cases where you feel you may not succeed, as Dr. Basak showed 360-degree vascularization, huge scar, post-herpetic. Many people will think this will not sustain the endothelial keratoplasty, but we have seen cases doing very well after EK also. So we have to assess these patients and plan your surgery accordingly. And as Dr. Amar also talked about, triple procedure where you fix the IOLs and do various pupilloplasties. Ultimately, the pupil has to be manufactured in a way where patient can benefit. Beautiful presentation.
Thank you. Thank you. Thank you.
Yeah, Preetham, we can go for next.
Yes, yes. So next is none other than yourself, sir.
Oh.
So I would like to invite Padma Shri Dr. Jivan Titiya, sir. He's like a godfather to anterior segment surgeons and corneal surgeons all over the country. He's has vast experience under his belt, and his topic for today is going to be phacoemulsification in posterior polar cataract. I also take the opportunity to invite Dr. Namrata Madam, who has just joined. Welcome, Madam.
Thank you, Preetham. Thank you for making me a part of this.
Always a pleasure, man.
Thank you, Preetham, and the entire
Good morning,
team of
sir.
BOA.
Good morning, Dr. Mishra, sir.
Yeah.
Good morning, Namrata. Good morning.
See all of you.
Yeah, Dr. Lahane and Dr. Ragini and Preetham, thank you for inviting me for this very, very important morning session. As we are talking on cataract, I'll take you through the newer technologies used in a posterior polar cataract surgery. We all know posterior polar is a difficult scenario for many of us, and sometimes the results can be very, very disheartening if proper planning is not done for these patients. We know that proper examination of cataract is important for a successful outcome in most cases, and holds true for a posterior polar cataract also, where a slit lamp assessment can delineate the type of posterior polar cataract, the intactness of posterior capsule, and the defect in the posterior capsule can be very clearly picked up in a slit lamp assessment also. But it is the optical coherence tomography which has made change in our entire thinking in our approach to ophthalmic surgery, not only for posterior segment surgeries, but also for anterior segment surgery like cornea and cataract. In pre-op assessment with anterior segment OCT in posterior polar cataract, we can really characterize the type of posterior polar cataract, especially the amount of size of disc, its density, and the intact posterior capsule can be seen. And it is very apt to say that in all these difficult situations, you need to assess the other eye also very, very carefully, which may have a telltale signs. Now we have an intraoperative OCT microscope, which can give you a similar assessment, what you can do in a sitting position of patient with the ASOCT in a lying position on the table of surgical table with these IOCT guided microscopes. And with the new laser devices, which also has OCT attachment, you can again assess the posterior capsule and posterior pole in these cases. So based on this intraoperative OCT pictures, we have looked into the type of posterior polar cataracts and the dynamics which happens during your surgery in these posterior polar cataracts with IOCT. We have classified them, excluding the open posterior capsule in these cases, in 3 types of polar cataracts: type 1, type 2, type 3. Type 1 were cases where we could clearly delineate the posterior capsule all around, and the entire disc could also be assessed. We had a clear space between the posterior polar disc and the posterior capsule, which made things simpler for us for a planning for surgery. Type 2 were those posterior polar cataracts where periphery of capsule were clearly delineated, but central area we could not delineate the posterior capsule from the disc. Similarly, in type 3 cataracts, the entire pole of posterior polar cataract could not be delineated in terms of the clarity or distinction of posterior capsule in these cases. We can understand with these 3 types, type 2 and type 3 will be a difficult situation, while type 1 will be easier because we could delineate the entire limit of a posterior pole with the disc also. So this is a type 1 type of polar cataract where I'm doing a hydro delineation. So this is what you can see with the delineation. We have created the epicortical cushion and the nucleus separation. And this is the amount of fluid which has been there to cause delineation, which normally we see with a golden ring in a normal video. This is after decompression, the fluid has come out, but you can see the intactness of the posterior capsule, and we have done hydrodissection in this patient without rotation. So that is important in the posterior polar cataract. You don't have to rotate, but you can do a hydrodissection in type 1 cataract. So we have a hydrodelineation and hydrodissection. The surgery becomes simpler in these cases. So you can see now I'll be completing my phaco. After completing the phaco, you can see entire epicortical cushion is still left intact, and posterior pole is clearly distinguishable at this stage also. And the surgery is very, very comfortable in these cases. This is toward the end of surgery, clear posterior capsule. And after implantation, the capsule is, lens is well balanced, and trifocal panoptic lens has been put for these patients. Type 2 and type 3, we don't do hydrodissection. This is a type 3 cataract. We just do hydrodelineation only. You can see a delineation here. Multiple delineation lines will come up in posterior polar cataract. Normally, these are soft cataracts, but sometimes, like this one, you can have a harder nucleus, and these are cases where you have a more difficulty. So delineation becomes difficult in a harder nucleus, and surgery becomes much more difficult in these cases. So we had type 1, type 2, type 3. You can see the percentage why type 1 is the most common and type 3 is the rarest one, around 22%. But looking at the incidence of posterior capsular dehiscence, type 1, no dehiscence happening. Type 2 and type 3, you have a higher chance of posterior capsular opening in these cases. The importance is to make surgery safer, and that in phacoemulsification, hydrodissection, hydrodelineation is key in making surgery simpler and faster. So if you have a type 1 where you have an OCT picture clearly delineating the posterior capsule, we can do hydrodissection also with a gentle procedure. You can do a very effective surgery, and the chances of a defect happening is nil. But if you have a type 2, type 3 variety where a posterior capsule cannot be delineated on the table or with anti-segment OCT, then you should avoid hydrodissection in these cases, and then you can make safer surgery in these cases. The same thing, same approach we have described in laser cataract surgery also, where we do a safety rings, 3 safety rings of laser with 8 chops, and that makes multiple blocks of a nucleus. Those can be taken out subsequently in the phaco by block by block, primary block, secondary block, tertiary block, and towards the end we remove the epicortex, and that is like a layer by layer phacoemulsification assisted by femtosecond laser application. This is the new sign we have described recently, published in the JCRS, intraoperative posterior polar cortical disc defect. This is a sign for an intact posterior capsule. You can see after completion nuclear, you can see this type of defect in the most posterior polar cataract, and sometimes people feel that you already have damaged posterior capsule, which is not very, very true. If you see the type of PPCD, that is a posterior cortical disc defect in the posterior polar cataract, we could see in almost 87% of cases this defect. In 91%, it was complete, and around 7% is an incomplete disc defect in these cases. So once you see this disc defect, the chances of posterior capsular dehiscence is almost nil. If you see stages where we can see, this is towards the end of nucleotomy and towards the aspiration of epinuclear, you can see this defect in almost 90% of the cases. In 9% of the cases, you have happening after cortical removal, and around 2% of the cases you'll see after the nucleotomy or a nucleus removal in these cases. So this is a normally type 3 type of posterior polar cataract. You have this appearance. This is normally type 2 type of cases, and this is normally type 1 type of cases. And it is very important. In 9 patients, we could not see a posterior polar cortical disc defect. There we have more chances of posterior capsular opening. And there you require in-block aspiration. At that time, you might open the posterior capsule when you remove the in-block posterior pole in these cases. So it is very, very clear that in most posterior polar cataract with no disc defect happening, there are type 3 or type 4, more chances of posterior capsule opening is there. I would say people who see this defect, you should be feeling safer. And just to show one classical video of PPCD happening, this is a type 1, type 2 of type of cataract. I'll directly take with the nucleotomy stage. This is a hydro dissection delineation being done. You can see a beautiful hydro dissection delineation happening, and hydro dissection also been done and no rotation. And we are doing a nucleotomy now. It's a stop and chop technique. The rotation may not be possible, so you may have to do a multiple chop and take out each segment one by one slowly and leave the intactness of epicortical cushion, which you have created by doing a good delineation. You can see here, you clearly see the epicortical cushion in these cases. Now I'm trying to remove, and this is the defect you can see here after I remove the epicortical cushion. So that doesn't mean I have an open posterior capsule, because OCT could delineate the posterior capsule very clearly in this way. You can see the intactness of a epicortical cushion is still left in the periphery, and the posterior capsule is clearly delineated. So you are safe that in this particular case, you had a defect, posterior primary posterior polar cataract showing the intact posterior capsule in these cases. So that's the importance of happening of this defect in a posterior polar cataract. To differentiate the posterior polar cases with opening of posterior capsule, which is normally, you can see it is begins the center, then radius to periphery in a very elliptical fashion, while the iatrogenic damage is more in the type which is like a flap type of cases, which is irregular with the pattern, which is normally would enlarge with subsequent procedure in a different ways, may become larger in all areas, while posterior polar gives an elliptical type of opening classically in these cases. And chances of vitreous loss in posterior polar is quite less compared to the iatrogenic damage posterior capsule happening. Just to summarize, devices like anti-segment OCT enhances your visibility or examination of a real-time examination in these cases. If you have IOCT microscope, that can really gives you a dynamicity of steps of phaco in these cases, and you can classify the type of posterior polar cataract, modify your surgical approach subsequently to decrease chances of posterior capillary dehiscence and decrease the nucleus drop in these patients. If you have a femtosecond laser, that also significantly improves your understanding in these difficult situations also. Thank you for kind listening, sir.
Okay. Yeah.
I can't hear you, Preetham.
Thank you so much for the lovely presentation, sir. Any comments from the other stalwart seniors here?
It was.
No comments. He's the best. All of them are the best. So no comments for any presentations. We are just learning. They are all the best. All of them, teachers. And so this is on YouTube, and we've had more than 30,000 views when we saw last time. So this continuing medical education for starting with Namrata and me, who are your first students, and then a generation of students.
So you are all teachers now. You people have grown up to a
teacher is always a teacher.
Yeah.
So you are our teacher, and we have teacher of teachers, Dr. R.N. Mishra sir here. For years,
and,
I can't
have
remember.
been a
Yeah.
teacher for everybody.
Ever since
And he's still young. That is a remarkable thing.
Still
You still
young,
look
yeah.
same, sir.
Same.
I think this is the कहते हैं ना गंगा के किनारे रहने का फायदा है सर.
So I first met him when I was around 26, 27 years old, and he came as a DNB examiner. He was so ill, but he still came, and I learned how he was taking exams, and he was asking the most basic questions. And then Patna was with us, so luckily we had a chance to share some part of his life with us, and I agree with all of you. He's a great teacher and a great father to all of us, and me especially.
No, Ragini, not you especially, us especially.
As Namrata,
I met him before you did.
Here, so I think both of you will Kaan Pakad Ke us especially. All of you, Tityal sir, Shroff sir, Basak sir. I think what a lineup, and all of you are teachers. All of you are mentors, teachers. Ane sir, do you want to say something?
Sir is muted. I think sir
I
must
think
be on.
Preetham, we can go to the next talk.
Okay. We'll proceed. We have next talk is by Dr. Namrata Sharma, Madam, our dear General Secretary of All India Ophthalmologist Society, Regional Secretary of Asia Pacific Academy of Ophthalmology. She's a senior ophthalmologist at the RP Center, AIMS, Delhi. And her topic for today is OCT guided phacoemulsification. Madam, over to you. We can see your screen.
Thank you, Preetham. At the outset, I would like to thank BOA for making me a part of this session, and particularly yourself, Preetham, Swaptesh, Ragini, and Dr. Lahane sir, and the entire organizing committee of BOA as well as MOS. And it is always a pleasure and honor to be presenting in front of Dr. R.N. Mishra sir, who's been a teacher of teachers. Wonderful to see him today. And of course, my teachers, Dr. Tityal sir, Dr. Basak sir. So thank you, Dr. Tityal sir, for procuring so many IOCTs so that all of us now have and we can do it. And I think I would be talking to you about the intraop OCT guided phacoemulsification. There are no financial or proprietary interests, and this is a video to show how it can help in several occasions. Right from your making of the incision. So when you make the side port, you know at what level it has been made, which can be seen on the intraop OCT microscope. It's a full thickness incision, so that can be appreciated. If you make a uniplanar or a biplanar wound, that also can be appreciated on the intraop OCT microscope. And when you're doing a capsulorhexis, you can see how the flap is everted. Of course, it's not of much use when you're doing a case like this, but when there's corneal haze, then it does help, especially when you lose the edge of the rhexis. And it is important to see the intersection of this blue and red, because wherever this intersection is going there, actually that frame actually you are seeing here. So you can see that the frame is moving with the rhexis margin, and you can actually see it here. And like I said, it does help in cases of cases where corneal haze is there, and if you lose the edge of the rhexis here, maybe it doesn't help so much when you're doing a simple cataract like this. Now, when there is a wave of hydrodissection, then actually you can see at what level the dissection is occurring. You can see the hydrodissection wave, which is moving very slowly between the posterior capsule and the overlying cortical layers. And likewise, the same thing can also be appreciated here. And very nicely shown by Dr. Tityal sir that it makes a lot of difference, especially when you have to differentiate between a posterior subcapsular and a posterior polar cataract. Then again, when you are making a crater there, by looking at the fragments or the shreds here, you know at what level you are. As especially in cases which are total cataracts or hard cataracts, as you go deeper, it gets clearer. So again, you can make out where the cortical plate is and the posterior capsule bulge also, because it tends to come up, and as soon as you put the viscoelastic, it goes behind. So you can see that the PC is intact or not in these cases. Then when you are inserting the intraocular lens, again, notice that the bulge is, it is the PC is intact and it is actually concave and it is not trying to come up. Something which you probably don't need a microscope, but it just helps you to ascertain that. Then when the intraocular lens is put, again, it is very useful because if there's any viscoelastic which is remaining behind, that can be ascertained. This is the distance between the IOL and the PC, and as you aspirate, this gap would decrease because the PC will come near the IOL. And we've done a study where we've seen how this is affected by the 3-piece or single-piece IOL or hydrophilic or hydrophobic material. So this gap is now decreased as the viscoelastic is aspirated. Again, when you hydrate the wound, you can actually make out that spindle sort of a thing will form, and you can make out the wound hydration is occurring, and also make out that on this side, it's whether there's an external wound gap present or whether there's an internal wound gap present. That can be very nicely delineated. Again, wound hydration is being done. Notice that there is a little bit of this small DMD, which you can see here, but cannot see here because of the fact that it is hydrated and emphysematous. So if that DMD is there, then in those cases, one can put an air bubble and see that it is attached at the end of the surgery before finally leaving the case. Then there can be other different situations in which it is helpful. Posterior subcapsular cataract, you can notice that there is a distinct gap which is present between the PC and the overlying cortical layers, and then you can delineate this. And if it is a posterior capsular polar cataract, like Sir showed very nicely, that there will be a gap which is present. Again, Dr. Tityal sir has very well defined the ways the white cataract looks like on intraop OCT microscope, and his elegant and landmark paper will tell you how we can classify these cataracts. So if there are clefts which are present in these black areas, it means that again the flap is everted, and if it is not strained properly in that area, you can also see it here. And if these black areas are present, that means there are fluid clefts which are present, and as you give a nick in the capsulorhexis or initiate the capsulorhexis, the fluid will not come out because of the fact that these dark areas are already present here. And then as the capsulorhexis is being initiated, you can follow it up on the IOCT. Again, useful in those cases where where you have hypermature cataracts or where there's underlying fibrosis where connections can be seen in between. And if there are no adhesions, then of course it comes out clearly. Then again, this is a white cataract, and as soon as you give a nick in the capsule, the fluid comes out, and just see how dense it is, and there are no clefts at all. And when you have that dense sort of a structure, then you absolutely know with no fluid clefts that this is going to happen. Now, this was a case of capsular distension syndrome with myopia. And when we did an anterior segment OCT, we did see that there was viscoelastic, there was in fact a gap which was increased between the PC and the overlying lens, and there is also phimosis of the capsule. So with the help of the ILM peeling forceps as well as scissors, this stricture was relieved. And then notice how the lens is now sitting bang on the posterior capsule. And this helps you to titrate and know that there's no gap now present between the PC and the overlying intraocular lens. And then you know that you have addressed the problem. Now, apart from this, like I said earlier, when you have a white and a tattooed cornea, which is, white and tattooed black, both in color, and if you do lose the edge of the rexis there, like in this case, you can actually relocate it by looking at the intraop OCT microscope and get it back to position. If you've lost it there, you can actually see the flap, which is just present adjacent to the tattoo that is there. And again, it helps in the subsequent steps also. This, I think, is beautifully covered by Sir, so I will not do this. Now, again, for us as corneal surgeons, again, it is very helpful. This is a case in which penetrating keratoplasty has been done and a DSEC has also been done, and there is a white cataract now. So in such cases, when you're doing a cataract surgery, you can actually make out the incision. Then you can do a capsular rexis is being initiated. Again, it's a white cataract, so it will help you to know whether fluid is going to come out or not in such cases. And notice that the graft is not moving at all. And you think that it doesn't move. It helps you to understand the dynamics of the graft better. And once you do irrigation aspiration, it is still not moving. And when you put the intraocular lens, it goes in easily. There is no problem. This is a single piece intraocular lens which is being implanted. But when you hydrate the wounds, just notice how this graft moves. Now this graft has started to move. So, and this occurs when you've just hydrated the wounds, and also possibly occurs because slightly the ACs become shallow. So, and then when you discover this, then you know that in the end you will have to put the air bubble so that this does not unzip in the post-operative period. So in such complex cases, it does help a lot, and it helps you to achieve this endpoint when the graft is completely stuck to the back of the cornea. And this is the last bit, just to show that when you have a phacoemulsification and you've done a DALC, then in these cases, there's a Descemet's membrane detachment in the post-operative period, and you can't see, it's so stormy, you can't see where you have to put the air bubble. So you put the air bubble looking at the intraop OCT microscope, and even after putting that air bubble, it has not got quite stuck. But if you do the intrastromal drainage from the anterior side, the fluid comes out, and the Descemet's membrane, now after putting air bubble, is quite stuck to the back of the cornea. And all this is, visualization is not possible because of an edematous or hazy cornea. So it does help you in tricky and difficult situations. So thank you very much for your kind attention. And if there are any questions, I will be happy to take.
Fantastic, amazing talk, Dr. Namrata. Always a pleasure to watch your videos.
Thank you, sir. Dr. Mishra, sir, can you unmute, sir?
Thank you, Namrata.
मिश्रा सर अनम्यूट कीजिए. मिश्रा सर अनम्यूट करना है. नहीं सुनाई नहीं दे रहा है आपको. You have to unmute.
So you have to unmute. Mishra sir, you have to unmute.
Can the admin unmute?
Admin
Mishra sir and Tityal sir.
Manjula, can you unmute Professor R.N. Mishra sir?
Mishra sir and Tityal sir, you all have made such a wonderful student like Namrata, who's so dynamic, and now as your student, she's working so hard for India and putting up such beautiful programs, scientific, though she's a secretary, and for the amendment and for the betterment of all the ophthalmologists, sir. I must say that the teachers have inculcated good ethics, good qualities, and hard work in her.
Yeah, that's absolutely true. I think Ragini, you rightly pointed out, she's one of the most hardworking person I've seen in my life, with a lot of dedication, sincerity. I think she puts a number of hours wise, nothing less than Mr. Modi in that regard. Maybe every day puts almost 14 hours a day, which is remarkable. Working for our family, working for our center, working for our various societies. Talent-wise, she's wonderful in terms of writing papers, doing surgeries, organization, name anything. I think if you look into ladies in our ophthalmic scenario, they've done so wonderfully well in last 2-3 decades, and I see the future belongs to them only, and they'll be the front runners, in the torch bearers for a younger generation to come. So Ragini, you are also a great teacher. You have a responsibility to make younger people do things which will be known by name of their teachers, and they become teachers themselves. So it is our students who are going to be teachers. That is how things improve, and we are very happy that younger generations are so well equipped in all respects.
Thank you so much, sir. We will definitely follow your footsteps. And thank you so much, sir. I agree with you about Namrata. But Namrata and I have, she sees you. I see Rane sir working so many hours, and so you are our role models for both of us, like Mishra sir.
Ragini, can you listen me?
Ragini, sir, Mishra sir, now we can hear you.
Yeah, I just want to comment about Namrata that I think, remember 25 or 30 years back when I used to go institute, I used to feel that everybody, Dr. Dada, Dr. Tiwari, all. And I remember 15 years back, probably I asked Dr. Dada, why don't you come in conference and present paper? Well, where is Namrata? She always used to prepare my talks. Who will prepare now? So she was so indispensable in the institute even at that time. And she's doing wonderful. Congratulations, Ragini, to you and Namrata also. Thank you so much.
Thank you
Now
so
she's
much.
indispensable not only for the institute, for the entire country now.
No, that I must put on record all the support.
Sir,
and
coming
help
from a teacher, this is the biggest award that Namrata can get and I can get. We don't need anything more but your blessings, and we must keep on following your footsteps.
Thank you, Ragini. Thank you. You are so sweet, so good.
Ragini, I have to put on record the amount of support sir has given Dr. Tityal sir. I don't think any unit head, anybody could have given. As a friend, as a philosopher, as a guide, teaching surgeries and everything, and so tolerant. I think I must even give it to sir that he'll be so tolerant. And,
but Namrata, I'm seeing this thing from 1995 that everybody is supporting you. Everybody is dependent on you.
Yeah, that's true, sir. That's absolutely true.
So parents are like that, Namrata, and we are both blessed.
Thank you. Thank you, sir.
Okay, Preeta, we have
we have one more talk in our session, and shall we move ahead, sir?
Yeah, Dr. Vineet Ratra.
So, I would like to invite Dr. Vineet Ratra. Dr. Vineet. Dr. Vineet Ratra is a senior eye surgeon and consultant at Shankar Nethralaya. Good morning, welcome Vineet. And I was myself a fellow at Shankar Nethralaya when Vineet was there, and he is a fantastic human being, always uplifting his the morale of his colleagues, of his juniors, of his students. He's been he's trained a multitude of postgraduates and fellows all over the country. Vineet, over to you. His topic for today is correcting handling astigmatism in cataract surgery.
Thank you so much, Preetam. Can you hear me?
Yes.
Thank you, Ratra sir, for joining and being with us today.
Thank you so much, madam. Thank you, Dr. Lahane sir. Thank you, Preetam. Thank you, Swapnish, for having me over here. My greetings to all the starwards in this session. So, well, I'll be talking about cataract, correcting astigmatism in cataract surgery. Astigmatism we do know is a vector of both magnitude and axis, and total astigmatism would include both the anterior and posterior corneal astigmatism and the lenticular astigmatism. Astigmatism is with the rule in the younger age, and as one gets older, it becomes against the rule. So, well, how can we change corneal astigmatism surgically? This is by changing its corneal shape, where one could flatten the steep meridian by taking an incision on the steep meridian, or to steepen the flat meridian by taking compressive sutures, or by neutralizing it by using a toric intraocular lens. So, well, what is surgically induced astigmatism? It refers to the astigmatism which is induced by surgery And we do know that 2.4 millimeters is an astigmatic, probably the most astigmatic neutral width of the incision. However, flattening would also depend on the architecture, whether it's a single plane, where our location is, whether it's temporal, where it is least, and will also depend on the cornea, where a larger corneal radius or a thicker cornea or a more rigid cornea would actually decrease the magnitude of the surgically induced astigmatism. Well, is it reproducible? Well, each cornea does have its own corneal biomechanism with different corneal hysteresis, elasticity, and stiffness. What was previously believed to be 0.5 diopters has now been subsequently reduced. We now have the centroid SIA, which is more scientific, as it is a vector analysis based on the double angle plot where one would have 0 and 180 in axis. So you have it in a double angle plot like this. And one could see that though the magnitude of the vector is all over here, it's the central which is more important. And this impact of SIA becomes negligible, which is around 0.1 diopters. So what about astigmatic keratotomy? This is nothing but a pair of limbal relaxing incisions, which is taken around 90% depth at the steep meridian. It has variable factors. One would need the AK marker and the AK knife. And there are different nomograms which would help decide onto the size of incision, like the Fukuyamas, the James Hayes, the NAPA, or the LRI calculator.com, where one could just feed in the details. But however, this is losing its usage more so because of the potential complications. While doing the LRI, one could end up with a perforation, one could end up with decreased corneal sensation, discomfort, infection, and over or under correction with irregular astigmatism and also corneal ectasia. So that's why probably using a toric intraocular lens where one is neutralizing the is a better option, which is available in cylindrical powers of 1.5 to 6, which would correct up to 1 to 4 diopters at the corneal plane, which is available in both the mono and the multifocals. But however, there are some contraindications for a toric intraocular lens. One would not want to use them in patients with an irregular astigmatism, a patient with a zonular instability. A relative contraindication would be one where there is a posterior capsular dehiscence or a poor pupillary dilatation, but Suvain with his BX has sort of made that no contraindication now. And a chronic dry eye where calculations of the toricity become difficult. Since we know that astigmatism is a vector of both axis and magnitude, one could end up with errors or variables in both. One could end up with a post-operative rotation early or late. One could have difficulties or inaccuracies in marking or corneal measurements in corneal toricity or IOL calculations. So the first thing that can go wrong, one could end up with a post-op rotation of an axis like this. And even if one was to have a 10 degree of misalignment, one would lose around 35% of the residual cylinder. And with a 30 degree of misalignment, one would lose 100%. One would end up with a residual cylinder of 100%. So one could have it as early in the early post-operative day, like in this patient, where one would need to reposition it. So these are easy to reposition in the early post-operative period, where one would just need to separate the capsule, make the knob of the haptic released, and then one could easily rotate it into position. So if reposition is needed, it's better to do it early than at late. But one can also do it in a late period, like in this patient, but one makes the surgery much more difficult, and one could even end up with zonular dialysis. So, well, that brings us to the next point is how much do I rotate? One could use the iTrace or the Astigmatism Fix, the website. The iTrace has the toric caliper, the toric calculator, and the post-operative toric IOL enhancement. Well, all of us do not have access to it at all times. So the astigmatismfix.com is a probably a better option to use. We normally mark the axis with the patient sitting so as to avoid cyclotorsion. The other way is to do it on a slit lamp, which is probably more accurate. One could do it in an undilated state where where the pupil it passes right through the pupillary axis. But what's also important is to do an additional surface marking of blood vessels, pigmentation, or pterygium or piniguella, because in case these markings were to go away, one would still know what the horizontal and the vertical axis is. One could also use a superimposing reticule from a Hack Street, but well, this is expensive. Or a digital like a Varian or a Castello. I have access only to a Varian and have only experience with that. Well, but there are fallacies, more so with the registration. It would just not register at some times, or once it registers, one could have a loss of registration. And if one was to move the microscope, the registration is frozen, so one needs to re-register again. So the other keys to success are the accurate measurement of the corneal astigmatism. One would need to use at least 3 methods. We do use the keratometry, the autokeratometry, and the optical biometer as normally the 2 techniques. But in certain cases of toric, one would also use a corneal topograph, iTrace, or a Scheimpflug imaging system. But we use the third as the Varian because we have access to it. And the reports between all these between these 3 different methods should agree. The axis, the difference should be not greater than 10 degrees, and the magnitude of the K values should match. One needs to rule out that if there is a dry eye or the distance between the cornea and the measurements or cyclotorsion has caused a change in the K magnitude. One also needs to take into account the posterior corneal astigmatism, which acts as a minus lens. It is generally against the rule and stable over time, and it has been found to be only 10% of these have been found to be on axis. The rest are either in the opposite axis or oblique, and nearly 45% of them are greater than 1 diopters and 20 greater than 1.5 diopters. If one was to avoid these with the rule astigmatism patients, one would overcorrect a factor of 1.38, and in an against the rule, one would undercorrect by around 0.65. So one can measure the posterior corneal astigmatism with the IOL Master 700 with total K, which measures using the SSOCT, or the Scheimpflugs, where one could actually end up with more intra-device variabilities. The predicted PCA, posterior corneal astigmatism, one can do with the different formulae which are available. For the positional cytotorsion, it is important. One could end up with up to 15 degrees of cyclotorsion, which could actually misalign it again to around 30 to 50%. Thus brings us to what an approach should be. One needs to measure the total SIA. One needs to mark correctly to avoid cyclotorsion. Rhexis size is important. It needs to cover the IOL all around by at least 0.5. Otherwise, one would end up with a tilt. An IOL centration, looking at the Purkinje image, the corneal light reflex, and the Varian. It's always safer to leave it around 5 degrees anti-clockwise and finally align it after an OVD removal. There is this interesting guest editorial in the JCRS 2018 where they did say that the total SIA and the actual post-operative refractive astigmatism depends on different factors, including refraction, the corneal astigmatism, the IOL alignment, and tilt, which could also induce an astigmatism. Well, what is the role of femto? Yes, it does help in that the rhexis is more regular, more predictable. The arc length, the arc incisions are smoother, but one would need to separate the wound with the Sinskey hook. But however, there can be effects with tilting or bleeding from the blood vessel. Then it's obviously more expensive. And there have now been reports of irregular astigmatism and corneal ectasia occurring even with femto-assisted LRIs. So, well, the take-home message is one should correct astigmatism as a part of integral part of phacosurgery. One can correct up to 6 diopters. One needs to select our cases correctly, do accurate readings, take good care that cyclotorsion doesn't affect our results. It's always good to flip and leave the patient a little near to the nearest within the rule than to leave the patient with against the rule astigmatism. And well, astigmatism correction is still an enigma. Thank you very much.
Thank you, dear Dr. Vineet, for putting such a important topic in such a precise, concise nutshell and presenting it. Thank you so much. I would like to invite some comments from the chair or maybe from Dr. Ragini Madam before we wrap up this session. We have already overshot a little bit.
Dr. Samat, I'm just thankful to the great chairpersons and all speakers, and especially my thanks goes to Dr. Ragini and Dr. Lane, who invited even non-entities like me. So thank you very much, Dr. Lane. Thank you, Ragini, taking care of me. And thank you to all who have made us more wiser. Thank you.
So with apologies to all the teachers present here today,
Thank you,
Titya sir Padma Shri hai, Lane sir Padma Shri hai. आप नॉन एंटिटी शब्द निकाल दो और श्रॉफ सर बहुत सीनियर ऑफ्थल्मोलॉजिस्ट है, ये पहले आपको निकालना पड़ेगा, नहीं तो ये सेशन खत्म नहीं होगा.
Thank you, Ragini.
Thank you, everybody. It was a nice session.
Sir, any comments from Dr. Deepak sir? He has been quiet. Deepak sir.
No, I mean, it's wonderful to listen to all the great advances. It was great to hear all the teachers. Thank you so much.
Thank you, Athamle sir. Thank you, Athamle sir.
I would like to make one statement. I would still like to be student of Dr. all the senior teachers. I would like to be student again.
Yeah, all of us. Yes.
Thank you.
Gopal sir, any last words?
As I compliment the speakers for putting in such a informative knowledge about all we knew, but we are basically have forgotten, and coming back to the people who have chosen these speakers. I mean, the credit goes to you, to Lahane sir, to Ragini Madam and Swapnesh for actually making these stalwarts being a part of this session. So congratulations to all in one.
It is their love for us and their love for teaching that makes them come here and spread this beautiful knowledge.
Thank you again, Vineet. Thank you so much. Thank you, everyone. And with that, with permission from Dr. Ragini, we'll move on to the next session. That is a Phaco 4. And Manish Sharma is already there, waiting eagerly. Manish, you're the moderator. Over to you.
Thank you so much. Thank you. My respect to all the teachers and everybody, Gopal, Dr. Deepak Bhaiya, everybody. Thank you so much.
Thank you so much.
Preetham has put this 4 days program, and I think Preetham, lots of blessings to you.
Yeah. Hats off.
Good afternoon. I welcome everyone to this Phaco 4 session in Duke Holders Hall. And I would like to begin by inviting Dr. Virendra Agarwal to chair the session, and Dr. Kulin Kothari also to chair the session. And I would also like to request Dr. Ravi Matani and Dr. Praveen Patil from Jalgaon to join in as conveners and co-conveners. Are you there, sir?
Yes, Matani sir is there. He's good morning.
Good morning.
Dr. Kulin sir.
Good morning, Ragini.
Good morning, sir. Thank you. Good morning, Manish.
Or rather, good afternoon now.
Good afternoon, sir. Yes.
Good morning.
Dr. Mishra sir, Dr. Shroff sir are there. Dr. Arup Bhaiya, good afternoon. Thank you so much. We've been keeping you busy this morning. Dr. Ravi Matani is my senior alumni from JJ. He's now at Himachal.
Yeah, he's in Kulu.
He's in Kulu. His first job was given at Bombay City Institute.
Yes,
Ravi, how are you?
Me that. Dr. Praveen Patil sir is also there.
Ragini ma'am, some of our speakers are busy in the court-martial session. So we will start with we will request Ashok Shroff sir to start with his talk, and then as others join in, we will ask them to.
Dr.
If that is okay.
Agarwal sir is also in court-martial, so the session is all yours. Kulin Kothari sir, you are a senior teacher, please. And Mishra sir.
Yes. I think this is a wonderful session with faculty from all over the country, from Navsari, Coimbatore, Trivandrum, Kolkata, and they are all very senior, very experienced surgeons as well as teachers. And over to our first talk, Dr. Ashok Shroff, my dear friend for last 45 years.
Oh, thank you very much. Just battery is running low, just for a moment, please.
Yes, sir. Meanwhile, Ragini ma'am can say a few words while sir is getting his presentation running.
So I really thank everybody for these wonderful sessions, all the stalwarts who are present here today for this lovely teaching, and the science which continues in spite of the fact that, I remember Arup Bhaiya posting some pictures last week of the storm, which was very bad through his window. COVID times, increasing COVID cases, but to come together over here today for this scientific program so that, people's minds can be taken off COVID. And to be here today, I really want to thank everybody from the bottom of my heart for teaching us, for teaching generations and generations of students. Arup Bhaiya is the ARC proceedings chairman and busy with his hospital, the new one, and everything. Kulin Kothari sir runs a big setup with doing a lot of charitable work. And, we were with Dr. Shroff sir in the last session. Dr. Tityal sir is here, and in spite of busy schedules, Dr. Mishra sir is here, Dr. Matthew sir attended, talked. So the wonderful science and the teaching that has been going on, and we are learning lots of things. And I'm so happy for the students that this technology continues their education even in these difficult times. So thank you everyone for being with us.
BOA and MOS are very, very close to our hearts. I think it is, and you and Lahane sir are doing fantastic work. Of course, Pritam and all your team is there, but very, very appreciated. Very, very appreciated.
So stalwarts like you made Mumbai and put Mumbai on the map, and it is our duty to continue what you started forward, sir.
Okay, so I'm ready, if you allow me.
So, Shroff sir, yes, please. Thank you, sir.
So at the outset, it's my pleasure to join you here with the excellent program. And I thank BOA and the Maharashtra Ophthalmic Society for having me invited with such a stalwart galaxy of faculties. I would like to share my experience with the visco-free hydrophaco, the evaluation of anatomical and functional results. The safe phaco is the ultimate goal in any whatever you do, but the safe phaco includes protection of endothelium by effectively maintaining the anterior chamber. There should be no surge or minimum. Phaco procedure is to be done at the pupillary. Am I audible? Hello?
Yes, sir, you are audible.
Yes, sir. Can you see the slides?
No, sir. You have to click on the presentation. The presentation has not started yet.
Now, how to share?
Just double click on the presentation, sir. We can see your screen. You have to just double click on the presentation to start it, sir.
Okay. Now, can you see the screen?
We are not able to see the slide, sir.
Oh.
We can see your screen. You need to start the presentation.
Now, can you see the screen? Now, Manish?
No, sir, we are not seeing your presentation yet. We are seeing your screen. We can see the list that you have, but The presentation is the second one from below, sir. If you click on it and start.
Now, the first slide is already there.
Yes.
Can you?
No, sir. Now, in fact, your screen share has stopped. We are seeing you. We can't see your screen. You need to do a screen share.
I'm so sorry. Yeah.
भाषा ज्वाइन થઈ है
मैं तो कर रहे हैं, मैं ट्राई कर रहे हैं।
नहीं बस शेयर स्क्रीन में नहीं होगा इसको भी देखो
तो एक मां जाने लगा मुझे पकड़ा से तो देख मां जाने Can you ask somebody else to start the topic?
Yes, I think, Dr. Sroff, if you don't mind, we'll ask other speaker who may be ready to start.
No, but then I can check the later on, after first speaker. I don't know whether it is even not available on my screen too.
Dr. Arup is here, sir. While you sort the problem out, we could request him to. Dr. Arup Chakrabarti, sir.
Yeah, he has to stop sharing the screen, otherwise I can log in.
Yeah. Ashok, sir, can you stop sharing your screen?
Yeah, we'll do that, sure.
Thank you, sir.
So is my slide visible and I'm audible?
Yes, sir. Yes, sir.
Okay. So good afternoon, friends. We meet once again, and I'd like to thank the organizers for giving me another opportunity to talk today. Nothing financial in whatever I'm going to talk to you today. The first step in the management of small people is to ascertain the maximum pharmacological mydriasis. Sometimes I am quite surprised in the operation theater where in the case sheet it is written that the small pupil strategy is called for and the pupil is well dilated. So maximal pharmacological mydriasis evaluation should take place in the OP, and a clear-cut note should be written in the case sheet as to the amount of dilatation. Now, if the pupil is still suboptimal, not conducive for a safe cataract surgery from the patient's as well as the surgeon's point of view, we need to modify our surgical approach. We need to modify the pupil size by various methods. And somehow I'm not a big fan of topics like phaco in unmodified small pupil, phaco sans OVD, phaco sans BSS, phaco sans consent, so on and so forth. So if at this stage, my pupil is less than 3 to 4 millimeters in diameter, or even if it is slightly larger, but it has associated comorbidities, for example, very soft cataract, very hard cataract, and uncooperative patient, shallow anterior chamber, I would still like to modify my pupillary size and go ahead with a safe approach for cataract surgery. So these are the various devices that are available in the armamentarium, and I have used some of these devices over the last couple of years. But I must say that I'm not a big fan of going to the devices as the first resort. Because devices are basically invasive. You have to perform intraocular manipulations and there could be complications because of that. And then they may be expensive. So before I use a device, I would definitely try to use non-device methods to dilate the pupil for a safe phacoemulsification. So I would like to establish the etiology of small pupil. If it is a non-IFIS type small pupil, then traditional causes of small pupil, my approach is going to be different. In 2005, Campbell and David Chang came up with the concept of IFIS in small people situations, and it was published in 2005. It is quite a historical publication. Since then, we have prepared a list of medications which can make a patient IFIS candidate, intraoperative miosis and IFIS-like symptoms. So we have to be on our alert whenever a patient is on those medications. Pupillary fatigue has to be avoided at all costs. Now, if you really want to dilate the pupil the day before surgery, for whatever reason, you haven't seen the fundus or whatever, don't use cyclopentanol 1%. Use tropicamide 1%. Because it has been shown that if a tropicamide 1% gives you a pupil of 6 millimeters on the day of the surgery, if you had used cyclopentanol instead, you will have 0.3 millimeter less dilatation, which means 23% reduction in the pupillary area. So you need to avoid cyclopentanol the day before surgery. There are a few more IFIS risk predictors that have come up in the literature. Actually, there have been articles which show the red flag if your maximum pupillary mydriasis is less than 7 millimeters, 6.5 millimeters, or 8 millimeters. So whenever you have a pupil which does not dilate beyond it, you can consider your patient as an IFIS candidate. But for you to measure so accurately, you need to take an anterior-segment picture. You may have to measure with the caliper. So it becomes a little more time-consuming and cumbersome. So what I do is I do an intuitive pupil-to-limbal diameter ratio. After maximal pupillary mydriasis, I look at the limbus and then make a mental picture. Is the pupil less than 60% of the limbal diameter? And then if it is less, then again, I consider this patient as an IFIS candidate and take precautions. Sometimes I get people like that on the surgical table, and on inquiry, it is revealed that this patient was allergic to Tropic Acid Plus. Hence, the nurses have used only cyclopentanol or homide or just a tropicamide to dilate. And when you can get a lovely dilatation, good for the safe phacoemulsification with Tropic Acid Plus, regardless of the allergy, because I did the safe phacoemulsification for the same patient, put the patient on topical steroids on the same day, which is a routine for all of us, and the patient was on topical steroids postoperatively, which is an antidote for allergy. So basically, this is the way I have converted many of the cases. I converted many of my small pupil cases. This is the first post of the picture into a routine case. And I always add half an ampoule, that is half cc of 1 ampoule preservative-free adrenaline into the infusion bottle. I no longer use intracameral midricaine. Some surgeons have used it for IFIS cases, but I don't use it. There have been intracameral fixed combination medications that are available in the Western world, and a few such medications, some Indian companies have also started making it. This particular medication was actually published, the results with this medication was published 2 years back in an article. And it showed that, you get a mydriasis within 30 seconds, maximum mydriasis. This mydriasis is stable, pupil doesn't come down. And only in one case, the pupil came down to by more than 3 millimeters in this particular group where the intraocular medication has been used, whereas in the topical group, it was about 20 cases. So definitely it makes sense if you are very sure about the quality of the product, and you're sure that you're not going to get passed with this product. It is an option worthwhile trying. My go-to device is the iris hook. Iris hooks are inexpensive. They are very easy to manipulate. You just need to create 4 or 5 paracentesis with 27 gauge needle for you to manipulate the iris hooks into the anterior chamber. And I'm not going to show you how to use these devices, but let me tell you why I find this is my favorite device. Because you can easily tackle ectopic pupils which are bound down because of uveitis. And then it gives a selective dilatation. For example, I do a lot of phaco-vitrectomies. Phaco in vitrectomized dyes where there is lens-iris diaphragm retropulsion syndrome because of reverse pupillary block. So I can just use an iris hook to elevate the pupillary margin from the lens capsule to equalize the pressure gradient between the anterior chamber and the posterior chamber. And the anterior chamber really does not become deep. I've seen a lot of videos where ring devices have been used in vitrectomized eyes or highly myopic eyes. Some of them have been myopic, aphakic. And when there is fluctuation in the anterior chamber depth and when the pupil size also fluctuates, there's always a possibility of the device dislocating into the posterior chamber and even into the posterior segment if you're dealing with an aphakic eye. Now, no such problem with an iris hook. You can place the iris hook very safely even when you're doing the capsulotomy, and I'll have a video to demonstrate this point, how to do it safely. If you're doing a toric IOL in a small pupil situation, you can remove the iris hook, so you don't require an anterior chamber formed with OVD, unlike the ring devices where for intraocular manipulations, you need to have OVD before you remove the device. So this is an added advantage. Now, in certain situations where unexpected zonulopathy, you find that the rhexis formation is a little difficult, you can use iris hooks to provide counter traction. Capsular hooks are ideal in this kind of situation, but iris hooks also can be used quite carefully, and I have been able to use get good results with iris hooks in this kind of situation. And then in certain situations where you have used a Ahmed segment, and these can be stabilized by using the iris hook to the eyelet of the segment. And after the whole surgery is over, the segment, the device can be sutured to the scleral wall. So these are the various advantages of our iris hook, why I use them. Now, this is the case that I was telling you about, and it was actually a post-vitrectomy eye, intumescent cataract, and I wanted to, the pupil was quite big to start with. After this was viscomydriasis, it was, as I told you, it was a myopic eye, it was a vitrectomized eye. So I wanted to make a two-stage rhexis, and the rhexis ran away to the periphery. So I ran into trouble with the phacoemulsification also, because I had eye face in this case. The nucleus was neither here nor there. It was not soft that you could aspirate it. It was not hard that you could crack it or chop it. So here I needed to use a pupillary dilatation. So injected OVD to create a safe zone between the pupil and the anterior lens capsule. So make sure that when you're hooking with the iris hook, don't take the rhexis margin. You have to be very careful and just take the pupillary margin. Same problem can happen even with the ring devices. But as this is just to demonstrate the versatility of the iris hooks. Now, there are potential problems like any devices, but most of these problems are because of faulty handling and is not really an issue. I have also used the Malugin ring, the second version, the BHEX ring, Bhattacharya's ring, and some of the other devices, Iris Beaver, BVI, Oasis Iris Expander, Visitec eye ring, and the Canabrava rings, etc. Recently, the Gupta ring, I think this ring has a long way to go. And now, which is the best device to use in small pupil situations is then objective study. Now, this was, I think, the largest study published from Moorfields in November 2020. It compared iris hooks with Malugin's ring and phenylephrine. The results were quite interesting. The Malugin ring showed an incidence of iris tear in 6 patients. It was not seen in iris hooks. It was seen in less numbers in iris hooks and other modalities. The Malugin ring was also associated with a high number of atonic pupil corneal edema and cystoid macular edema, so on and so forth. So basically, I think this is an important paper, and it tells us how the devices are to be used and what devices to be used. Before I wind up, I would just like to tell you my IFIS strategy. Now, if I'm dealing with a pupil, an IFIS candidate, the pupil is large to start with, but less than those critical diameters, 7.5 or 8 millimeters, or the index is less than 60%, then I just make a very construct incision properly, long incision. Hydrodissection is performed very gently and slowly. All the phaco parameters are lowered and use an appropriate OVD strategy. On the other hand, if I have a pupil which is very small to start with, or if I have an eye face in the fellow eye, in that case, right at the beginning itself, I'll go for a mechanical expansion device and not use the traditional techniques. So friends, in conclusion, you need to know the etiological classification of the small pupil for you to select the appropriate strategy. Pharmacological modulation works extremely well in most of the cases. And if you really have to modulate the pupillary size, try to use a sphincter sparing non-device option. And if that doesn't work, then use a device. And I'll be using a device straight away if, as I mentioned earlier, the pupil is extremely small with the presence of significant comorbidities. Thank you so much for your attention.
Thank you very much, Arup. It was very, very nice, wonderful. I will just make a very small, quick comment that we also must keep at the back of the mind wherever these devices are not available. We used to do stretch pupilloplasty maybe 2 decades back, or maybe more than that, 25 years back. So nothing is available. with 2 instruments to, we can stretch the pupil vertically and horizontally, very, very gently, maybe taking 10 to 15 seconds on each direction. And then that also can work in some cases. And just as a general piece of information.
But stretch pupilloplasty, the problem is, the stretch is little uncontrolled. So in certain cases, you have sphincter tears and postoperatively unnecessary.
Yes, I agree with that. That's why I said when nothing is available, this is one more thing to be kept at the back of the mind.
Yes.
But the key is to stretch in one meridian over a long period of 15 seconds. People tend to stretch fast, and that it causes a lot of trauma to the sphincter.
Yes.
Yeah.
Thank you, sir.
Thank you so much. Thank you.
Sir, we've had the pleasure of having Arup sir operate with us during the live BOA sessions. He's a fantastic surgeon, Arup Bhaiya.
Thank you, Ragini.
Thank you. Virendra Agarwal sir has joined us, I think, from the court-martial session.
Yeah.
Dr. Agarwal sir has joined us.
We welcome Dr. Virendra Agarwal.
Sorry for being late. Actually, I was enjoying court-martial. Then I saw the time. So it was already late.
Let's switch it off.
Sorry to keep you busy, Virendra Bhaiya.
No. But I am happy that I could listen Dr. Arup's talk. And I think take-home message should be that the people should get dilate. Whatever means you use before surgery will save you during the surgery. So that is the thing, that you must dilate the pupil for enough to prevent complications. So I think Dr. Ashok Shroff is ready. So let us have him.
Thank you very much, Manish, Ragini, Dr. Lahane sir, BO and the Maharashtra Ophthalmological Society, Kulin, my friend, and everybody on the screen here, as well as the audience. I would like to share my experience regarding the visco-free evaluation of anatomical and functional results. The safe phaco is the ultimate goal for any cataract surgeon, but the safe phaco includes the protection of endothelium, which can be achieved by effectively maintaining the anterior chamber where you don't get the surge. The phaco procedure has to be done at the pupillary plane, not very close to the cornea, and the proper IOL insertion in the back. However, you must avoid intraoperative complications. At present, to achieve all these, the different types of viscoelastics are available. But recently, of course, in the US, hydroinsertion of IOL is gaining popularity. When I had attended last ACRS, there were quite a few presentations that they would insert the IOL with the irrigation cannula onto the side port. Then I thought, why don't we have complete hydrophaco? The disadvantages of visco, so that we can avoid it, the complications like intraoperative phaco and shallowing, because the moment you can form the chamber, but the moment you are through the stage, particularly say like phaco or rhexis, and when you withdraw the instrument, the chamber becomes shallow. It can lead to the corneal endothelial damage, or it can lead to the posterior capsular damage if you are not careful. Postoperatively, if you have not cleaned it properly, then it can raise the pressure. It can lead to the inflammation or the TAS. And of course, there are little more operative time, and it's more expensive. So the aim of the study is to find out the changes in the corneal endothelium after visco-free phaco and to evaluate its efficacy in safety on anatomical and visual results. We have included 32 eyes, and more important is the corneal endothelial study. They were between 22,513 to 2,819, mean being 2,699 cells per square millimeter. The cataract grade was 3 to 4 because we did not want to have a very brown cataract, hard cataract, because of the initial study. The IOLs foldable were placed in 19 eyes and the rigid in 13 eyes. The anterior chamber is introduced and the tip is directed towards 6 o'clock. The sterile incisions are put. Even the main incision, when you withdraw, the chamber remains very, very firm and steady. Now here, the rhexis is being made with the other little different instrument where you can see that here it is snugly fit. If you use the forceps, or you can use the needle also, so that will save your anterior chamber from frequent collapsing. because if it is the wound becomes large or opened, this fluid can escape and the chamber becomes shallow. The hydrodissection is done, chamber remains very steady. Even if you withdraw the needles or anything, it remains steady. The steps are same otherwise. See, you can do the hydro and then rotate. The more important is to see the chamber stability on withdrawal of the instruments. Here, the phaco is being done, cracking done. You can see the lot of the visco is the BS is being escaped through the wound, but still chamber remains steady and stable. Here, while doing the phaco, you have to have irrigation on through the phaco probe. Once the nucleus is removed, you can remove the cortex by coaxial cannula. You can see that it's very easy, comfortable. See, the chamber remains stable. No need to introduce visco off and on. You can do the polishing. And now you can enlarge for the IOL. Here, you have to use little visco to load the lens in the cartridge. But you have noticed that the visco is being washed out immediately with this fluid current. The lens is placed in the bag and you can see that it is hydrated. Similarly, I think there is some problem with the video, but you can use even the rigid lens without any problem. The IOPS remain normal within the normal range. The visual results, of course, it goes without saying that the visual results are very good, 6x6 and 6x9. The amount, this is very important. The amount of BSs used was average 75 millimeter. This is separate than the irrigation you use during with the phaco probe or the IA probe, but the range was 50 millimeter to 90 millimeter. You can see the results, particularly the corneal endothelial cells count on specular. Preoperative, the mean was 2,699 cells per square millimeter, and post-op at 1 month it was 2,671 cells per square millimeter. So the loss was very hardly 28 cells. Means 1.03% compared to the previous one, the pre-operative. You can see the post-operative picture with the rigid IOL and the foldable IOL. It's very good. Even this picture has been taken just before, within few days. You can see the little congestion here, but excellent maintenance of the chamber, excellent clarity of the cornea. You can see the specular analysis of this patient, male 57, where we have used foldable IOL. The preoperative was 3,294 cells per square millimeter, and post-op it was 3,360. The cell was hardly 34 cells per square millimeter. You can see the beautiful pre and post corneal specular microscopy. All steps could be done easily and effectively with this procedure. AC could be maintained even during withdrawal of it is very important, withdrawal of the instruments. So did not inject visco every time. The minimum amount of visco, of course, is required to load the lens in the cartridge. No intraoperative or post-operative complications due to these procedures were noticed. Possible complications due to visco could be avoided. Endothelial cell loss is negligible and it's quite safe to the cornea. It's more economical and time saving. Of course, should be avoided when cataract is associated with other comorbidities like corneal opacity, glaucoma, zonular dialysis, deep-seated IOP. Why deep-seated? Because the fluid which comes out of the wound will cover would come over the entire cornea, and that will probably make your visibility poor. But ACM, this is very important. ACM should be used properly, and the tip should be directed posteriorly. To summarize, 32 eyes were subjected to this procedure. AC remained formed even on withdrawal of the instruments. Average 75 millimeters of BSS was used. There was no intraoperative complication. Corneal endothelial cell was negligible, and disadvantages of visco could be avoided. So what we have observed that the visco-free is a very safe procedure. Thank you for your kind attention. Thank you.
Sir, very nice presentation. Just one comment I wanted to make, sir. A very nice talk.
Please,
see, I just wanted your comment. You know, this month's issue of JCRS had an article on phaco with visco and phaco with only anterior chamber maintainer.
Okay.
And it showed that at 1 month, 3 months, 6 months period, the endothelial cell count, the coefficient of variation, hexagonality, central corneal thickness, all were statistically significantly lower, inferior in the AC maintainer group than the phaco group. This is a study from Turkey. I don't know how reliable their study is.
I don't think so, sir, because with these patients we have been following.
I mean, if you see the JCRS in May, this is an article. So I was quite surprised. I mean, how such...
Did they give any reason for that, sir? Did they discuss it?
Sir, I think Dr. Ashok Shroff, sir, you have done excellent surgery because you are an excellent surgeon. We started hydroimplantation of IOL way back around 2003. But what we have realized that implanting IOL is okay, but doing full surgery under antechamber maintainer or under hydro is a little difficult task for majority of us. The reason is that a viscoelastic actually maintains the antechamber throughout the surgery. One. Second, it protects the endothelium by its adhesive nature. And the most important thing, as you have shown, that the incision should be very strongly fit for all procedures. It is difficult all time to prevent prolapse under only using antechamber maintainer. So I think because of your excellence in the surgery, you could achieve very good results. And as Dr. Arup has said very rightly, that in majority of the hands, it will not achieve the result what you have achieved. But because you have achieved, we believe it. So I think for beginners, it should not be taken as a thing to do. But for the excellent surgeons like you, it can be a kind of surgery which is available.
No, sir. The one more thing, sir. This is not fit. This is not the ideal procedure for all types of cataract. This is not ideal. So you will have to have a very good opening of the intraocular fissure, little prominent eyeball, so that the chamber remains formed all the time. Because the deep-seated eyeball or the very brown cataract, complicated cataract, not advisable. Even in experienced hand, we should not try.
So what do you want to give as a take-home message? Should we continue with this or we should still wait?
Sir, please do it and find out yourself. Because these patients have been following this now more than 4 years. And they are
I think for the younger surgeons, I think it is better to use viscoelastics to start with. And one gets experience, I think, then he or she can choose herself or himself, you know. But in general, if you want to really generalize, the disadvantage of using phacoemulsification, I mean, using viscoelastics are very, very minimal.
Yeah.
Okay. Or you can try in the grade 1, grade 2 cataract with the without viscoelastic, and with the grade 4, 5 you try with the visco. You can sort out the cases.
Sir, I would like to request all these senior faculties that please start doing it at least in few cases, and when we meet next time during the conference, we can exchange our ideas and the observations. That would be my request.
So what is the bottle height you want to keep for antechamber maintainer?
Sorry?
What is the bottle height you are keeping for antechamber maintainer?
110
I think having excess fluid will also be a problem, and keeping low fluid will also be a problem.
It should be adequate. The height is about 110 centimeter.
110 centimeter usually not a height available in majority of the OTs after doing this AHU.
No, sir. I know. You have to have a separate stand.
So, Yeah, we were having it before. Now after AHU, it is not there. Yeah. So I think it's still the titration of the fluid coming in and preventing it to have a iris prolapse at the same time maintaining antechamber will be a difficult task. But I think somebody can try initially in very soft cataracts where phaco is not an issue, and then gradually build on experience. And with the experience, he can try on some other cases.
Yes.
So sorry for being late, and I invite the next speaker. I don't know who all have spoken, so I think I will take help from my co-chairman, particularly Dr. Pulin Kotharigar, sir.
I think Chitra is ready. Chitra, are you ready?
Yeah. Chitra and Partha was there in the old session. Okay, so she joined. Okay.
I think Dr. Chitra Ramamurthy is probably ready. So we'll request her to start her presentation.
Yeah, she is ready.
Yes. Chitra, as all of us know,
it is a great session.
Wonderful surgeon from Coimbatore. Chitra, nice to see you and nice to looking forward for your presentation.
Yeah, slides are visible.
We can see your slides, ma'am. Please go ahead.
Make it slideshow, please. Slideshow.
Just a minute.
Ashok sir, your mic can be muted.
So my view in the next few minutes is to talk about cataract surgery in small eyes. We know this is an area of great challenge because of the anatomical configuration of the eyes and also the proximity of structures. Small eye, we just a plain normal eye, or it could be a microphthalmic eye where the anterior chamber depth is normal but the axial length is smaller. Nanophthalmic where both the anterior chamber depth and the axial length is small, or a relative anterior microphthalmic eye where the anterior chamber depth is small but the axial length is normal. There are certain coexisting challenges.
Look, Chitra, your slides are not visible.
I think there's a network issue.
I think we have lost her.
She's still seen in the group. Ma'am, can you hear us?
The screen, but we can not audible. Chitra, you can unmute yourself.
Manjula, can you call her?
Ma'am, can you try switching off your camera maybe and see? You might be having network issues. If you can hear us, if you try switching off the camera and do a slide share, the sharing may be better. Yeah, we can see you.
Ma'am, we can see your computer, but we are not able to see you. And can you hear us? Chitra ma'am, if you are taking time, can we have another presentation meanwhile?
Yeah. No, you cannot hear me now?
We can hear you now.
Now.
No. No, I think by mistake I had pressed on the mute, I think. I'll go back to my presentation. You all can see the video. You can hear me?
Yes, ma'am.
Can you?
Now we can hear you, but we could not see this slide. Can you go to the previous slide?
Can you see now?
Yeah, it's visible.
Yes.
Very sorry. So there could be uveal effusion again if there is a sudden decompression in these eyes. More importantly, because this is a very small eye, the IOL parts is going to be high. Then, and also we could have a huge refractive surprise if our biometry is not on mark. And again, as I had earlier said, because in a short eye, we do not know whether the anterior chamber depth is normal or is it shallow. So there is a challenge in predicting the ELP. That is why in these very small eyes, it's very important to take the help of the newer generation formulas with their innumerable variables, which would get us to better estimate the effective lens position and go on. Towards this, the Barrett seems to be outperforming all the formulas because it not only takes care of the ACD, the lens factor, but it also takes into account the changes in the principal plane. So pre-operatively, of course, we need to decompress this eyes, massage. Is there a role of sclerostomy as a randomized controlled trials which show with or without prophylactic sclerostomy, these surgeries can be done, but then the way to go about it, yes, if you're going to do a sclerotomy, you need to expose the sclera at 20 millimeter from the limbus, and then you need to raise a 2/4 scleral flap. And once you have raised the scleral flap, you can take a 2/2 deep scleral block can be taken. And once you have made the small nick, you could even cauterize the tip so that it doesn't spontaneously close down. And then you go ahead and suture the overlying flap and go on. So intraoperatively, there are challenges. I have already said that it's a crowded anterior chamber. There could be atrophy of the dilated pupillar muscle and or posterior synechius. So there's going to be poor mydriasis. We should be wary of an iris prolapse. So you should be ready with all angles of support like hoops and rings. And then there is a question, would you do a limited anterior vitrectomy if it is a very small eye? I'll just run you through 2-3 videos. Now, this is a very shallow eye, a hyperope, it's +6 diopters. And you need to make limbal parallel incisions and inject cohesive viscoelastic to flatten the anterior surface of the lens capsule. It's a dense hard cataract. Make a little more anterior incision so that there is no iris prolapse. You could use a marker to ensure that the iris is a little larger because this is a dense cataract, but of course within 5.5 millimeters. Very gentle hydro. You see the iris is prolapsing and you keep decompressing the eye as you go on, and nicely rotate so that you release those few fibers which are not well cleaved by the hydrodissection. The next important thing is to look at the parameters. Now we need to realize that we need high flow parameters, but we need a stable anterior chamber because a lot of maneuvers are going to happen in this very small eye. And in the dense cataract, we need to also understand that the posterior plate is going to be so dense that it might not get separated at one go. So you might have to do multi-level chopping to ensure that you get down and you separate the plate. Otherwise, it's just one large chunk which has just been sort of saucerized, which is not the ideal way. And it is important that you try to do all these maneuvers within the capsular bag at all times. Keep injecting viscoelastic without overfilling the anterior chamber because you do not want iris prolapse in these small eyes. And the first piece is the main challenge. So again, you need to have a relook at the parameters, that you have a good IOP vacuum. And of course, the stable anterior chamber of the modern day machines ensures that the surgery goes on without even a flutter, which you're seeing in the iris. And you know, till these pieces are there in the capsular bag, it keeps the posterior capsule well away. So you're able to deal, but when it comes to the last piece, you really need to bring down your parameters. So these are some trips you need. Now, this is another case, which is a very shallow, and you see that it's just moderately dilated. So inject a tryptophan blue and then cohesive viscoelastic. Again, you wouldn't want to overfill. Now you can see that you're not able to insulate the iris hook in this particular case. So the tip here is to just inject viscoelastic underneath the rhexis so that it balloons up the space there. And then you will find that there's a greater ease in positioning your iris hooks as you're seeing. So you could go ahead and place all your 4 hooks as is conventionally done. Here I've actually tried to tighten it beforehand, which ideally should not be done because you should position all your 4 hooks and then do it. Ensure that you get a nice size rhexis. The advantage here, it's a soft cataract, but the soft cataract in a shallow eye can be a challenge. You need to do adequate hydro, but keep decompressing. The problem is when you are trying to take in your phaco probe between the 2 hooks, you can see that the eye is getting tense. Could cause dialysis. You need to ensure that you don't take your probe in and out. And again, another challenge of soft cataract is that chopping is a bit of a challenge. And also it can start cheese wiring. So you need to keep your vacuum and power at moderate level. And then it's all about just a regular phacoemulsification being done, being very conscious that you're operating in a shallow eye and being very particular about last fragment being taken. Most important message here is you take your cartridge and ensure that the IOL folds well into the capsular bag. Now, to obviate the problem which was there in the earlier case, you could make a sub-incision here and then place a hook as it has been shown. Now, this kind of the iris stenting which happened in the previous case would not happen here. And you can see you're able to make your incision and you can take your phaco probe with absolute ease. Now, I'm not going to show this video. I'm going to show this video wherein again the intralenticular pressure is high, the AC is very shallow. So you need to inject cohesive viscoelastic to flatten the anterior chamber. Now, the important thing is at all times we need to create a double rhexis, but here it becomes very, very important that the manuals could really cause this rhexis to run away. So you need to go in with a microforceps and hold the capsule and tear it and keep going back to the where it is attached to the rhexis margin. Keep injecting a little cohesive viscoelastic and then make your small round rhexis. It could be even smaller than this, and keep pulling the rhexis towards the center so that there is no chance of the runaway of the rhexis. Now all of this is being done in a closed chamber, and only now you're going to open up your main port incision, and then you would inject multi-quadrant hydros so that you are getting all the soft cortex out. You're making it an absolutely soft eye so that now there is no challenge of rhexis issues of a eye with a high intralenticular pressure. It is at this point of time now you could enlarge the rhexis because the earlier rhexis was just too small to do a phacoemulsification technique. And the surgery is pretty innocuous, like it's just a flocculent cataract and you cut it into small pieces and there is nothing much to convey here. So when it comes to residual errors, why do I talk about residual error in a small eye? Is because there could be a hyperopic surprise. So there could be a challenge if you have not used the best of the formulae. So there is this bioptics, which is handy, of course. And if your primary IOL power has been very high, you could readjust with a piggyback lens later on. Now, this was a particular case where immersion gave us two bizarre values in the two eyes. And on the Varion, it gave us a guidance that I could probably place a 40 diopter IOL, but in the left eye ended up with a +6 diopter of surprise. So what I would do here is to go by the Nichamin's nomogram. So for every +1 diopter, I would multiply by 1.5. So for a +6, I'm going to place a +9 diopter piggyback lens. So now the very essential thing here that these lenses need to be of a different material from the primary material, and Sulcoflex lens, which we have here, or the other lenses which are available in the market, which are designed that you need to have a large optic of at least 6.5 which makes sense. The haptics are quite undulating, so it sits well in the sulcus, and they have a posterior concave curvature, which will be fine, allow the adequate gap between the primary IOL in the bag, so there is less chances of intralenticular fibrosis. Now, this is an eye with a very small eye with a 16 diopter 0.5 axial length. So here a pars plana vitrectomy had to be done to just allow the eye to be just that bit soft, along with the preoperative measures which were taken. And the rhexis had to be done, very slow motion phacoemulsification, constantly being aware that the posterior capsule is right there to come in. And there was a corneal haze and edema, so you could use an endo illuminator to ensure that you remove the cortex. But because this was a 40-day IOL which was to be inserted, the incision had to be enlarged and the IOL had to be placed, and of course the wound had to be sutured. So, so how I would like to take it forward is that when it comes to a small eye, there has to be a great care in our biometry. Preoperatively, we need to ensure that you do everything to soften the eye. And intraoperative, absolute detail to attention is mandatory. We should have a post-op management strategy for residual errors, and doing all of it, cataract surgery in a small eye becomes quite uneventful and safe. Thank you very much.
Thank you, Dr. Chitra, for giving an overview, extensive, that how you can deal with the small eyes. The only word of caution I want to say is that the nanophthalmic eye, the anterior nanophthalmos or posterior nanophthalmos should be given importance while calculating the IOL power to avoid big surprises, because that will decide the effective positioning of the lens. And meanwhile, we can have a request from the next speaker to be ready. I think Dr. Partha is joined. And
Could
I just make one quick comment. I think this.
Sally from Neurotech, I'm not able to stop sharing. Can you do something from your end?
No, madam, you have to do yourself.
No, I'm not getting the cursor at all.
It will be at the bottom.
No, now I got it. No, I know how to do it.
Found the cursor.
Thank you, madam.
Chita,
Yeah,
this concept of piggyback lens is very good in whenever it is possible. It may not be possible in every small eyes, but I have one case report which I had done about 15-20 years back in the small eyes. Piggyback lens, and the patients are without glasses for when they have used very, very high hyperopic lenses before the surgery.
Piggyback lens is definite option, and nowadays we do have customized IOLs which also seem to answer, and we can definitely take care of the bulk of the IOL power, if not the whole of it.
Right. We need to pre-order them. That's only.
Yes, pre-order.
Yeah.
Thank you.
Thank you.
Wonderful.
Dr. Partha, are you ready?
Can we request Rajiv sir? Partha sir is having a little problem in sharing his screen. Dr. Rajiv Chaudhary sir, can you please start your presentation, sir?
And I think, sir, we'll request everyone now to be slightly brief because we are running very late.
Thank you, Agarwal sir. But sir, there is nothing after this session till 2:15 in this hall.
Okay. Then we'll enjoy the surgeries. Yeah.
Yes, sir. Good
Thank
afternoon,
you.
Chaudhary sir. He's a very senior surgeon, a mentor, a guide, and a friend. We've been to his hospital in Indore to operate, and he's one of the senior most surgeons from Indore and a very dear friend.
बाल सफेद नहीं हुए भाई. So good afternoon, friends. My topic is the PCR prevention and management. So we know that any rent is the posterior capsular rent, and there are so many predisposing factors in which we can assess that there is a problem and that we can get the posterior capsular rent. So we have to be in prevention. We should be careful in this type of cases: prominent eyebrow, deep set, which everybody of us know. There may be multiple reasons, anterior chamber depth, which we have seen so many videos today, iris and pupillary factor. There are the incidence of with the experienced surgeon, the incidence is less, with the beginners is comparatively higher. So our goal should be to avoid the posterior dislocation of the main goal should be the posterior dislocation of nucleus, avoid. Prevent any damage to the corneal endothelium, prevent enlargement of the tear, whatever has happened, with avoid to extension of it. And this can be done by early recognition of the rent. And minimize the size of vitrectomy and avoid traction. Removal of the leftover the cortex is also one of the issue. And maintain wood size and the proper positioning of the lens. So these are the most common time which we can encounter the posterior capsular rent while during the last piece, during IA, which is we feel that it is safest portion, but we get most of the time the PC rent at that time. During posterior capsular polishing, especially in the doubtful posterior polar cataract. So early recognition is very important. There are some few points which we can highlight that this give an indication that there might be an existing rent. Sudden deepening of anterior chamber with a momentary pupillary dilatation, transitory appearance of the clear red reflex, inability to rotate the mobile nucleus, reduce efficiency of nucleus sculpting, excessive tipping of one of the nucleus, and partial descent. This is, I will show you the video, PCR in hydrogen dissection. You can see that doing Rexis. Just hydrodissection has been done, and you just notice there is the deepening of the chamber. And there is a rent. Then when there is a followability is affected, you can assess that there is a central rent in this. When there is a difficulty in the rotation of the nucleus, you can assess that there is a difficulty, which means that after hydrodissection, there is a difficulty. And then many times we can get that there is a pre-existing rent. This is the case of there you can see that pre-existing rent is there. So here, how we will manage? We're straining up the capsule. doing the rhexis, the slightly mid-sized rhexis, we may have to go for the sulcus fixation. Hydrodissection will be gentle because there is a rent. There was not much of the nucleus, cortical aspiration. Repeated injection of viscoelastic is must, especially the viscot, so they keep the vitreous behind. Once you have removed this cortical, you can go for keeping the viscoelastic in between, and then put the tricot, triamcinolone, so that you can assess the status. You can do the vitrectomy for antechamber, or you can go it from the pars plana. Once a proper vitrectomy has been done, you can put the intraocular lens. We are used the 3-piece intraocular with the optic capture. The lens is gone in, and that's, we've done the lens in the place. When we can suspect, what we can do, we can use the red reflex when we have accidentally caught up the hold of the capsule. So you can catch, or you do the red reflex. Instead of moving your probe, you just use the red reflex, and you can assess that there might be a rent. There is the central rent. Instead of you are using the red reflex, many times you catch hold of this capsule. Instead of the moving probe, I am highlighting the importance of the keeping your IA probe stationary. When you hold, and many times it doesn't come with the reflex also. So you can use spatula to dislodge this. Keep your probe steady, so you should not enlarge. Try to separate it. So early recognition of is important, so you can promptly manage it and prevent the expansion of. So avoid sudden deepening. It is also a case posterior polar where you can see that avoid posterior management. There is a rent existing. You can see that, and NC should be filled with dispersive viscoelastic. Another thing which we can use in IOL scaffolding means, once you have noticed and there is a large chunk of the nucleus is there, there is a possibility if you do the vitrectomy or anything, this lens fragment will go down. So instead of this doing, we put the intraocular lens first. There is the central rent. We put the intraocular lens first, and then we can emulsify. Lens is placed in the bag, and later on we can emulsify this nucleus and do the anterior vitrectomy. I will just move for conversion to a SICS, a PCR suspected or discovered at an early stage, and there is significant amount of the residual nucleus. You can convert to the extracapsular. The option of doing the anterior vitrectomy, how it will help, it will maintain your visco out, keeping your, pull this vitreous back. Same thing we can do with the pars plana also, and probably this will keep separate and not pull the vitreous. Do not change the nucleus. If there is a partially descent, lift the nucleus into the more anterior plane and do the phacoemulsification there. So instead of pushing, you can do the phacoemulsification in the anterior plane and later on do the vitrectomy to remove the cortex and vitreous. Many times we get the PCR during the aspiration. You have successfully completed the cataract surgery, and inadvertently you can do the vitrectomy and then put the intraocular lens here. So there is a multiple setting. You keep maximum possible cut rate, lowest vacuum and flow rate, reduced retraction on the retina. The vitrectomy cutter should be held stationary during anti-vitrectomy and never pull. So to avoid the giveaway traction on the retina. And decision making the residual capsular, where to put the intraocular lens, whether to you go on to put sulcus, whether to interbake, and whether it's a total loss of the nucleus, you may go for the scleral fixated or glued IOL. So in conclusion, early recognition, prompt management of PCR and vitreous prolapse, you can give a 20/20 visual outcome. Thank you.
Thank you, sir.
Dr. Rajiv,
Thank you, sir.
for enlightening all the points by support of the video also, that what to do in all situations. So I think it is a very well covered up topic. And as we know, this session is very, very important, because in many of the cases for cataract, we presume that the cataract is just go and come out, and for all cases we have good results. But there are times when you have difficult situations, and this whole session is dedicated for those difficult situations. So I think this will be very good for attending and learning many things. I am also learning few things, because every speaker is giving good tips for managing the cases. So any comments from Dr. Ragini, Dr. Kulin Kothari, and other co-chairman people? I think it was supported by...
No, sir, no comments, sir, no comments. Beautiful presentations. And, you know, I have seen him operate so many years back at Navneet's place in Solapur. That's when I first got to know him. And I learned surgery from him that day. So I'm just honored and, you know, blessed to have you all as my teachers, friends, and family, and to keep learning, sir. Hi, Ajay Bhaiya. Hello. Good afternoon, Debashish.
Thank you, Ragini.
And it is worth visiting his hospital also. The way his movement of the patients and the doctor is, I think, very well organized. So
yes, sir. I think we have gone to Indore to his hospital to operate, and we've been there together. Yes, sir.
Yeah. Thank you, Dr.
And sir, the great hospitality of the Indore AIOC conference.
Yeah.
Thank you.
Jaipur
also.
So Jaipur AIOS together, and now that Ajay Bhaiya and Debashish sir are there, we will wait for the Calcutta hospitality.
No. We are missing Calcutta.
They are saving the best for last, so we have to wait for Calcutta.
Yeah, we have 2023 Calcutta and Mumbai together. Few sessions there, few sessions there. We can't wait till 25.
So whatever you all decide, all of you go home and...
Ragini, you have to complete the meeting before the ARC webinar.
Yes. Now, ma'am, you know, like she has a lovely SICS ARC webinar going on at 2:30. So, gentle reminder, and thank you so much, ma'am.
So we are having slides from Dr. Debashish, sir. Sir, we welcome you. And we are not able to hear you, sir.
Yeah, Virendra, can you hear me?
Yes, sir.
Yeah, now we can hear you.
We can hear you.
So I will be speaking on a similar line with Dr. Rajiv. So, share a few videos, focus on this hard cataract and the rexes that's been done in this case. I make a note of it that it is a smaller rexes compared to the hardness. Actually didn't look as hard as it later emerged to be. So you can well see that after a few chops, the surgeon is actually struggling with the hardness of the nucleus. And here we are with a huge subluxation. Now you have the entire bulky nucleus in a small rexis in the capsular bag. So you inject viscoelastic and then gently take out the probe. And then this one, the pars plana vitrectomy, which has become our preferred choice, especially when you have so much to do. Now, the anterior irrigation goes and you can watch the pars plana vitrectomy being done. And now, as you see, the eye softens out. everything softens out, and now you can put the Irish hooks, the capsular hooks in place. And now to make space for the CTR, I mean, you can keep the fragments around the area of dehiscence. You can observe a small PC rent already there. And but the good point of it is that when you're doing a pars plana vitrectomy and the vitreous is so, anterior vitreous is so well excavated that you can actually go in and put in, though it was a small rent, you could manage, and there's no vitreous in the anterior chamber. Everything is clean and well set. So pars plana vitrectomy definitely cuts where the vitreous needs to be cut. And it's like shaving your beard instead of trimming it with the scissors. So this is another case. We were discussing about injecting IOLs in fluid, and this is a complication which has tripped up because of that. The sudden shallowing of anterior chamber. Case was referred from outside. Now, in this situation, imagine, there's a total dialysis in the upper part and the rhexis is intact. But as we do the vitrectomy, see how well the space is created. And since the entire integrity of the capsulozonular apparatus was maintained, except in the upper part where the dehiscence was, you put in a CTR and wonderfully things are back to normal, and you can just slip the intraocular lens in the back. So the pars plana vitrectomy is a wonderful tool because of the area actually where you are doing the vitrectomy. This is to emphasize another clinical situation where there is a posterior polar cataract, and of course the low parameters and the maintenance of the anterior chamber, not withdrawing equipment, instruments. But during the dissection of the plaque from the posterior plate, I mean, that is where the rent occurs. And you can see the PCR now. Now the anterior, the visco has been plugged with viscoat, and now a vitrectomy is being done, anterior vitrectomy. But the limitation is sometimes, the fragments keep on, because when you're doing the vitrectomy, the fragments, as you will see, it looks probably clean, but a few fragments were still there. So as we go through the posterior route and we go in the area of the rent, see how the fragments have acted on the peripheral anterior hyaloid and the capsular bag, which eventually come out. And now you have a total vitrectomy and confirm it with triamcinolone and go ahead and give in your lens. So essentially, this was to emphasize as how important pars plana vitrectomy becomes. The only inhibition is to make a flapped valve scleral entry 3.5 millimeters behind. And that's the only inhibition that we people currently have. And so I'll go through the last case, which Rajiv was briefly mentioning. What do you do in a situation like this? So here, this is a traumatic cataract, and no, I think this case was of a post anti-VEGF injection where the patient had an hypomature cataract. And just look, we did the rhexis, we did nothing. It was the second, trench, and you can well see that the nucleus started shrinking down. Good that I had the second-hand instrument and I did a reasonably big rhexis, so I could hook the nucleus up. So, I mean, after this, for a SICS surgeon, it becomes a cakewalk. The only thing to remember that you have to load it well with viscoelastic so that we make the eye firm and tight to have a good scleral tunnel, a good external incision, a good corneal flap valve, so that we actually make a good SICS incision so that it's watertight, and later on we can actually proceed with the vitrectomy, the kind of vitrectomy that I had shown about. So I have discussed with you 4 different clinical situations in which we are often stranded, and I think with some of the remedial measures that we could follow during these steps. So thank you for your attention. Thank you very much.
Thank you, Dr. Devarshi sir, for highlighting good points whenever you are in trouble. And I think take home message, first thing is that use the vitractor whenever required, preferably through posterior route, and if it is not possible, then through anterior route. But I would like to say that posterior route is easier, not to be frightened of. It can be easily learned. Only thing you require a trocar cannula through which you can enter 3.5 millimeter away from the limbus, and the cutter goes behind, and you are doing a visible vitrectomy in which you are pulling the vitreous in its own place rather than pulling the vitreous from anterior side in the anterior chamber. So that is a one big advantage. If anytime you need to do the anterior root vitrectomy, then try to go behind the capsule and then only cut and aspirate. When you start doing the cutting and aspiration in the anterior chamber itself, you keep on asking the vitreous to come in the anterior chamber because there is a traction. So try to go through the rent in the posterior chamber and do vitrectomy in place and keep highest cut possible, minimum aspiration and minimum flow. That will help you. And as you said very rightly that whenever there is a jugular dehiscence, if you do a vitrectomy from behind, maintain the chamber, and then you can use the supportive measures of iris hook or capsular hooks, and then the case can be completed like a normal one. If the dehiscence is big, then you may require a Ahmed segment to support the capsular support, so the IOL should not get tilted. But I think it's very well managed and very good tips given by him. And I would like to have the comment from the other people who are on the panel to give the highlight things. And the take-home message is that don't frighten up. Whenever there is a complication, just cool down and use what all your armamentarium. And preferably every surgeon should use now vitrectomy, because vitrectomies are there with phaco machines, though they have a slightly lower cut rate than the proper vitrectomy machines, but still they are also good enough. And now majority of the phaco machines are coming almost to the 2,500 cuts, which is
23 page, yeah.
So I think I will have the opinion from Dr. Ragini, Dr. Kulin Kothari, and other people who are on the panel. And the speaker also can give their opinion. Dr. Ajay Paul, Dr. Chitra, Dr. Shroff, Dr. Rajiv Chaudhary, Dr. Malay Chaturvedi also joined. Dr. Rahane sir is there. I think we can have the word of wisdom from him.
I think Dr. Devarshi, as he has said, I mean, going through pars plana actually is a game changer in all cases. I mean, most of the cases. I mean, a lot of people, a lot of anterior segment surgeon would hesitate to do it, but then as he has shown, it's quite easy. If you can just inflate your or put a AC maintainer or infusion on, and then just go, I mean, go to a VR. So it's a few cases it takes, and then the things become easier. I think earlier we had in the court-martial session also how things can be brought under control. I think he has shown it very beautifully.
Now, the only thing is we need to have the eye to be a little hard enough, either AC maintainer or basically giving sufficient viscoelastic to fill the space before you actually go with the trocar to make your entry, the tunneled entry into the with the for the vitrectomy. And you have to do very limited anterior vitrectomy, because it's just being in the center and keeping your probe up. You just have, I mean, as Virendra was mentioning, that to do an anterior vitrectomy, you really need a lot of skill sets, because when you would do cut IA, when you would do IA cut, what would be your flow rates, I mean, where would you actually do the vitrectomy? Because if you hydrate the vitreous, it's going to swell up. It's only going to keep coming, you know, the more you do, the more it comes. So essentially, if you're doing and cutting, like you're shaving the beard, you're cutting where it matters. If you keep on trimming, you don't know when you will end up having a clean shave. So that's basically it.
Also, the posterior vitrectomy, it gives less traction on the retina as compared to the anterior vitrectomy. Probably anterior vitrectomy, you go on pulling and give more traction.
Essentially, Rajiv, I don't know so much about that, but what it does is you do very little vitrectomy. I mean, you just go there, I mean, spend almost a minute, and that is it. It does it in 1 minute. So that's the beauty of it. And you don't have to chase fragments. It, just happens. Like.
Very well said, Dr. Rajiv. You keep the cut rate highest and keep the suction lowest. That will also avoid traction on the retina. So there is one thing. And you always see that cutter is cutting. If it is not cutting, then you change the cutter, because sometimes we keep using the cutters which are already used and may not be cleaned properly, may not cut. So if you are seeing there is no cut, then you preferably change the cutter immediately, because otherwise it will have traction.
Especially with the 23 gauge, it occurs more frequently.
Yes.
Shroff sir is saying something.
Mute hai, sir. Mute hai. Mute hai. Dr. Shroff, up mute.
Yeah. Sorry. My funda very, because we do a lot of posterior segment surgery together. I mean, I do it. So my funda very clear. When there is a vitreous, if it is anterior to the iris, I go anteriorly through the limbus. If I have to go through the behind the pupil, behind the iris, I always go past plana. I always see. You must have seen and the difference between Dr. Vasavada's presentation. Earlier, he used to always go through the limbus. Now he has changed the strategy. He always go through the pars plana. When he has to go behind the iris. Because those, and a little vitrectomy, I tell you, this is what Dr. Agarwal and everybody has said. It is true. Less section, minimum vitrectomy. Even Debashish sir has said, it is very true. And when Dr. Agarwal has said very nicely, if there is no section, it will not cut, but it will pull the retina. So you have to be very careful. Thank you, sir.
Thank you.
So now we invite the next speaker. Cheta, you want to present, or let present Dr. Partha first?
Partha sir has 2 talks. I think he can present one if we are okay.
Good afternoon, Partha sir. We meet finally between running around all this.
The dynamic chairman.
Thank you, Debashish sir. Thank you so much.
So I go ahead as a public prosecutor. So public prosecutor, we will hang you here.
With pleasure. Always, Virender. So can you see my screen?
Yeah.
Okay.
Yes, sir, we can.
Yes, sir.
Thank you. So this is about microspherophakia and how microspherophakia has changed over the years. When we used to do microspherophakia 5 years, 10 years ago, and what we do now. And these eyes have to get that care that was important. So what would we do previously? So the most difficult thing would be this balloon-like bag, which would not puncture. And we used to use all these techniques. And ultimately, as you can see, we are going ahead and puncturing by a 26 gauge needle. And after that puncture, this capsular rhexis, it required artistry, it required patience, it required so many other things that the capsular rhexis itself would take nearly 5 to 10 minutes. And after that, very, very gingerly taking out the cortical matter and the nucleus matter and the lens in the bag. Always the bag being supported by the hooks or by the capsular tension rings, by the capsular hooks or the iris hooks as we are using in this case. And then, of course, the two Ahmed segments would go in. And as you can see that the Ahmed segments are good enough to support the entire bag because the sphere or the capsular sphere is a small one. And what we had later is this. This is where the fibrosis would take place. This is how a capsule would look. At times, it would look bad, but still, these very, very precious eyes did get back precious vision. And these smiles were so important for us. However, the changes have come in. And with these changes, what has happened is the technological advancement that has given us the femtosecond laser has actually done the job. And here with the femtosecond laser, what we do, the most important step is the capsulorhexis. The capsulorhexis becomes the most important step. And in this, as you can see, that it is the spherophakic lens. It is a small lens, and you can see nearly the whole sphere there. And this sphere has to be negotiated. The parameters have to be set right. What we are interested in is that 1.5 seconds of the assessment of where the capsulorhexis is done. And as you can see that the capsulorhexis is done, but here we are prudent and we go ahead with the next step where we will create the Hoffman's pocket. And then with the Hoffman's pocket created, you can see that the capsulorhexis is there, but it is somewhat like a postage stamp. But still, it does not require that amount of expertise and patience and time that we used to require when it was a manual capsulorhexis. So out with it, and the next part is the easy part. Very, very gentle hydrodissection. And once the hydrodissection, then we put in these iris hooks. Here, the capsular hooks don't work very well because the iris hooks have a small bend and that can be negotiated. Yes, of course, we have to be careful. It does not rip the capsule. And once that is done, the support is very important before the next step. And the next step is putting the intraocular lens in the bag. Here, my preference is with this particular lens, and this, the haptics of this particular lens crowds in over the optics, and it is so pliable that it stays put in place. But of course, the Ahmed segments have to go in. And once the Ahmed segments go in, they are the ones which is going to stabilize this bag. Because I've had an experience where the Ahmed segment I did not use, and the whole bag complex with the intraocular lens came up right into the anterior chamber, and I had to do a revision surgery to get it all back again. Because let us remember, the zonules in the spherophakic eye are just sparse. Not many zonules are there. So the tension on this bag that is holding the intraocular lens will not stay on for life. And that is the reason why the Ahmed segments are there. And this is in the dilated eye. And here we have spherophakia and its effects, then on your right, and now is what is in your left. Thank you very much. Thank you, everybody. Thank you, Moss, and thank you, BOA. Thank you very much.
Thank you, Dr. Partha, for showing an excellent surgery. I don't know how spherophakia goes to a good surgeon only. And it is good for them to have good luck to get operated by you. Excellent surgery shown for spherophakia. It is not a very common, but spherophakia, whenever it is there, is really difficult to manage. And the patients done early and effective surgery and excellent surgery will save their life. Because otherwise, the other complications of glaucoma and other problems are very, very common with spherophakia. And sometimes it is a treatment for glaucoma itself to do early surgery in the spherophakia, which is a very difficult surgery. Very well shown, excellent step. And the importance of maintaining the bag in the plane means you want to pull the bag in the posterior segment is also very, very important. Thank you very much, sir. I would like to ask one question for the IOL power calculation. Do you do any change or how accurately you are able to get? Because the anterior chamber is very shallow in these cases. The lens is slightly pushed anteriorly and the effective lens position may be not very accurate.
Quite true.
Because of the support you are putting and because of the otherwise also.
Absolutely. So Virender, these patients are otherwise also amblyoptic patients, but we try and achieve as much accuracy as possible. So we have a set of lenses, and once we place in the lens, then we have our optometrist quickly do on-site, on-the-table refraction, just to assess if we are not going too far wrong. So most of the times, whatever we have had in the armamentarium and the set of boxes are all available, the lenses are all available, and we have not erred much too much. And the maximum that we have erred is approximately 1.5 to 2 diopters on either side, which in these eyes have not been too much.
Any special trick you want to suggest for doing refraction in the open eye, that you want to fill the empty chamber, or you want to keep the cornea wet, these
Yes.
kind of things?
So it is only after tightening the sutures has the refraction to be done on the table, because the suture is responsible, the anchorage is responsible for the ELP. The position will possibly be staying only if the sutures are optimally tightened. If they are much too hardly tightened, then it might go down. So it's a real tricky situation, what you have suggested, and it's practically so. And filling up the viscoelastic in the anterior chamber again has to be just optimal. So with that in place, we get more or less not a very high deviation of the refractive error post-operatively.
Suggest like in school surgery, we do a suture adjustment possible, so we can keep a suture not very tight and cut off. We can keep them in the loop before reflection, and at the end of the reflection, we can remove, or we can do that suture next day for the final placement to save it.
Once the sutures are tied, I mean, you'll have to cut out the sutures and leave it in place. So with the sutures in place, the refraction is done. And then the final note is given when the optometrist says that, yes, this is more or less there.
And will you advise doing refraction before implanting the IOL? Because once implanted IOL in difficult situation, removing and re-implanting will be a slightly difficult task. You can do a refraction beforehand.
Yes, very difficult, very difficult. After again replacing such IOLs is very, very difficult. So we have to be judicious. Even if there is a small error, we might leave it behind. Just be thankful that we have been able to do the surgery well, but trying to do it as much as possible, as accurately as possible.
Very well, sir. Anybody else want to give comment or suggestions?
Just a comment, Partha, I think.
Thank you, everybody. Hi, Partha, thank you. Manish, thank you. Virendra sir, thank you. Ajay, thank you. Devasis, thank you. Rajiv, thank you.
Partha, just a comment or your comment on how to get those, I mean, those of femto where the rexis. I mean, this here, the lens is totally anterior chamber. Any adjustment you would suggest that how to do how much area you have to leave in case of these patients? I mean,
that is a very important practical question, because the earlier patients whom we did, and this one also was one of our earlier ones, you could see that it was just a postage stamp mark. And we had to, while removing it, they had to be joined. If you are tugging it a little too fast, you might have a rip. Because these capsules in the spherophakic eye are thicker capsules. Therefore, the penetration has to be better, the energy has to be more, and the time taken, as you saw, my time taken was just 1.5 seconds. In the later ones, we have taken up more time. They take approximately 2 to 2.5, and the energy dissipated is more, and the concentration of the spots are also, more. So you have not a free-floating capsulorhexis, but a more complete capsulorhexis than what we used to have initially.
Yeah, the anterior margin could be increased, maybe for the safety margin for anterior rexis, maybe around 300 microns. Normally we do 200 to 250 for a normal rexis. And especially spherophakia, they are not tilted. Unlike the subluxated, you could get one side and one side you don't get. So this would be quite central.
Yeah.
Very well said. And I think in this situation where you are applying the cone, which is not imparting so much of the pressure on the cornea, will also be very useful, because there is a very little depth between the endothelium and the anterior capsule. So you need a safety margin. That also is very important. And only doing capsulorhexis is good. You don't require to do any other part with the femto like
Exactly.
lens and nucleus.
Exactly.
So that is also
Quite true.
so. Dr. Chandra, are you there for second talk, or we continue with Dr. Pata for second talk?
Sir, Dr. Ajay has a talk, and maybe Pata sir can get a breather. Ajay sir can finish his talk, and then Pata sir can go for the next one.
Thank you, Dr. Manish and Dr. Agarwal. Thank you, Dr. Ragini and Rahane sir. I think I'll share my presentation. Can you see my slide?
Yes, and thank you everybody. You all are taking time to discuss because there is the session next is at 2:15. Thank you, Ajay Bhaiya.
Okay,
and thank you for giving me Chandrima in my life.
Thank you. So what I would continue is the flax in difficult situations. These are not challenging, but I would say that I do have no conflict of interest. Well, only the femto thing is, well, it makes my life easier in doing this hard cataract, small pupil, and the subluxated. And so it's actually the financial interest is, well, it keeps my stress level down and I can work better and give better result and get. So the debate is all there on flax, whether the similar cases can be done better with the normal phacoemulsification, or do we actually need flax to add that extra amount. But definitely I would say that these are the challenging cases which makes the real difference that I felt. Other than the automating surgical steps or enhancing precision, I think all our senior surgeons, we have achieved that. We could repeatedly do it, but these challenging cases, especially hard cataract, white cataracts, and PPCs and subluxated has made the difference. We know that the capsulotomies has changed over the period. In 2010, what we would get tears, etc., is not there today. As Dr. Partha was mentioning, we can titrate the time, you could titrate the size of the capsule and the distance between different energies. So we have better, actually we rarely have any runaway rhexis today as compared to what we had the earlier cases. And the pattern of capsulotomy has changed, and this has given a real advantage, especially in the hard nucleus, the soft and the quick PCs and the subluxated. The whole concept of change with the chops, cylinders, hybrid, and matrices. So let's come to this 6-minute video of different challenging or the advantage in these sort of cases. I'd first come with the harder cataracts. Now, this is something which has definitely changed for better, and the life has become much easier today. Look at this. This is what we are planning. We have got a normally in hard cataract, I do it instead of 5 or 5.2 or 5.25, I do a bigger rhexis as we do manually. So plan the rhexis as it is, and I generally use sextants. There's a 6 stents. That's what I used to do for my normal cataract, 6 pieces. So this is what I do. I also do matrices. So you can see this is what we are doing. Increase the repetition from normal 3 to 4 repetitions, and increase the spot, the spot sizes, as you can see. So you have got so nice, chopped up nuclear pieces, and definitely this brings the energy level down. And we know the studies have shown that it reduces by 30 to 40% the effective phaco time. And this is the matrices that I'm using 500 micron small cubes. And look at the number of easily how it has come. This would have been a tough job, especially the stress I would have done on the zonules in a normal phaco. But today, with availability of this technique, see, this hard cataracts become easier. The matrices makes it the energy used and the endothelial cell count or the corneal edema is definitely less, and definitely refraction stabilizes when we get very early visual rehabilitation. The white intumescent cataracts. Now, this is again by reducing the time, this is what we have learned. Now, this is one of these earlier cases where the fluid would leave, and you would still get some areas where there is adhesion. And this is one of those cases in the earlier cases. See, there would be some areas where, because the fluid is exchanged, egressed, and so the margins are just like postal stamp. So you can use easily just like small dots by using a side rhexis capsule. And the emulsification, as I've shown, even in white cataracts become easier. Most of the time you could end up in a harder cataracts inside when the fluid escapes, but the life becomes easier. As you can see, emulsification, and In case of small pupil, now what we do is there's a pupil maximizer. If you can get pupil even up to 4.5 millimeter, you can get the rhexis right up to 4 millimeter. And in these cases, the pupil might come down, but because you have split the nucleus so much that there's very little turbulence, you can go ahead and do the emulsification, keeping the pupillary size. Of course, I'm using high molecular viscoelastic in this and keep the pupil away from my phaco tip. But because of the lesser manipulation in these cases, and this is again a small pupil where the pupil had come down, I'm using my friend's BHEX, and see the BHEX gets me the right size once I have done. And this is a 4 millimeter capsulorhexis. And again, because of the femto splitting of the nucleus, I can get those the nuclear pieces out, and things become easier. And put the lens of my choice, and after putting the lens, I do take my lenses. And the soft cataract, especially in the refractive lens exchanges. Now this becomes very easy. As you can see, gone are the days when I had to go and eat up some material in the soft nuclei. I think it's one of the toughest, but because of the splitting and viscoseparation, I can get it down. And posterior polar cataract. Now this is what has changed the game. You can get a safety zone of 800 microns, and we know that after the advent of this technology, especially in catalyst where you have cubes, and in Lensex platform you have circular rings, and things have become much easier. And it has definitely been shown that the rate of posterior capsular rupture, which is there as high as 10 to 20% in PPCs, has come down to sub 5%, as has been shown. A lot of studies, including Dr. Vasado and Dr. Titial, have shown it that the PCR rate has definitely come down. And by using high molecular viscoelastic, this is the case where in the PPC we're using this. You can see the cortex is taken out, and there you've got the. So things become much easier. And in this case of PPCs, we know that the nucleus is soft. So if you have split it and made small matrices, even you can do the sextants, and you can still take out the nucleus. In case of radial cataract, now there was a fear that in these areas, when there is capsular small, the white marks that will not penetrate through it, but definitely it penetrates. At points you can have just the anterior capsule taken out, and there you can have, because of the softer nucleus and because you have split the nucleus, you can keep your bottle height down, or you can keep your IOP down. So the emulsification becomes easier, and especially in this case of RK, post-RK cases, where there is a chance of this opening up this nucleus and the opening up of the anterior the cornea. So this can be easily avoided. And the biggest advantage you have got is the subluxated cataract, as we have shown earlier in the cases of spherophakia, even this subluxated cataract. So you can get a very good round capsulorhexis. You can do visco dissection, as I'm doing, and I'm putting a CTR right there. The CTR goes in and gets my lens well centered. Once that is centered, I do use the capsular hooks, and this is a soft nucleus. I can get those the nuclear material by irrigation aspiration itself. I don't have to use much of the phaco energy, and as I get in, I can put the lens of my choice. This is hydrophobic IOL, and then get the CT segment with basically an iris hook instead of suture. I'm using this, and I've used in quite a few of cases where the hooks have been maintained, and that I can just tuck it in the sclera, just like in case of hooked the lenses. And arcuate incision. Now, this is something which has come really handy. We can get the astigmatism down right up to 1.5 millimeter. This is what I am routinely now using. And with the newer nomograms coming in, things would be much better control. Thank you. Thank you for your patience here. Can I stop sharing now?
Yes, sir. Thank you.
Okay. Yes.
Thank you, Dr. Jaipal, for showing the use of latest technology There is no debate that I want to enter into that you should use Phaco or Femto only. But Femto is definitely of use in difficult situations, and it can save your mental stress. It can make the things very predictable. The outcome can be very predictable. And in difficult situations, the technology should be used. That is my opinion. And very well shown in posterior polar cataracts. And in small pupils, sometimes it is very difficult to have a very appropriate size rhexis, but you have done it very well. I just want to have your opinion about that some people do, that they use pupillary expander before doing Femto. Do you advocate? Do you feel comfortable? And what do you think about it?
I haven't used it because I know I have the sterility is an issue, but then up to 4 millimeter, I definitely go with Femto. I tell the patient 4 millimeter, and with the PPLX, the maximizer here, I can just do the rhexis around 4 millimeter, just short of 4 millimeter, and take the patient immediately. Not wait. I mean, normally you do 2-3 the catalyst and then go back to OT, but this patient will take it immediately. Put some, if necessary, put some pupillary expander, and you can definitely do well with a 4 millimeter rhexis, and especially if the nucleus is chopped into 5 or 6 pieces, you know, there are less turbulence, so you can carry on with the surgery easily. But below 4 or 3.5, definitely not.
Thank you. I also agree because stability is one issue, but some of the people are using and they say that it is not making them a problem. But I still agree with you that
that is in a separate OT, is not in the OT, so I'd be very skeptical in using it.
At one time, we were a little scared about using in the RK incisions whether the capsular rhexis would be round and you know, it will be all proper and it will not tear out. So, but now I think with increasing the parameters a little, it is not much of a problem, and we usually get a good capsular rhexis even in a post RKI. Is it? What do you suggest, Virender, you or Ajay?
Yeah, I agree with you 100%. Let us increase the power a little bit and keep the sport distance slightly lower, and then you will achieve the rhexis in all patients.
Yeah.
And really, definitely, very, very important in difficult situations, you just don't pull up the rhexis because it may not be free floating. So keep on following the way you do rhexis by holding the capsule, and if at all there are some text, it will be torn easily and not have an extension of the rhexis. So this is very important. And he very well mentioned that by using the Femto in such patients, you can actually lower down the parameters because the half of the nucleus is managed by Femto itself. And that management will help you to keep the low parameter and manage a difficult case also. Sometimes even the harder cataract also can be done with a low power and low bottle height. So there is a big advantage of using the Femto. I think the time has come when Femto is going to stay and it is going to be of use in difficult situations. Though still because of the cost, primary cost involved and the posterior cost, it is a big challenge to use in all. But I think with time it will be of use, at least for difficult cases.
Absolutely.
And I request even those who are not using Femto, if they are doing difficult cases, try to keep slightly extra charges for difficult cases for your surgical skill and stress you are bearing.
Thank you. Thank you.
So Chitra has had a nice lunch.
So, I think ideal to comment on this.
2:30 my webinar starts. What to do? But you are also looking nice and fresh. And Ramurthy watched our court martial. He said it was good. So congratulations.
But I tell you, the phenomenal videos, my God, mind-boggling. What Somel showed and mind-boggling, my goodness.
Yes, amazing talent.
Amazing. And Ritika's concept was also so nice.
Yeah, everything was nice.
Especially with this study ophtha coming out, patients calling up and say, see my eyes and tell me, and especially this, you know, mucormycosis and all, they're sending photos and say, I'm showing you, man, you can't hardly make out what is there. But I can't come. It's very, very difficult.
I think Calcutta again cases are going up, no? Like South?
No, it is
Calcutta is going down, in fact.
going down. It's come down over last 1 week, 10 days. I mean,
It's gone up very badly for us, and so much of new court cases.
Mucoid cases are less. I mean, I don't know whether it's not diagnosed, but then very few people. I think 7 or 8 cases have been reported as of now in Bengal.
Okay.
But then it's very high there.
I think it is very less.
I think the lockdown.
We are in many cases.
Hmm?
Rajasthan, we are in many cases of mucor.
Yeah, I think Rajasthan has.
Yeah. Gujarat, Rajasthan,
Maharashtra.
Even Maharashtra, we have a lot of cases.
Maharashtra has a lot. Karnataka has a lot. Tamil Nadu, I don't know what's. I mean,
Tamil Nadu is got.
even the cases are going high, quite high.
And my daughter was saying in every prasad and all, young boys getting exaggerated in both eyes and all. Imagine an asymptomatic, some of them are not even aware of having had COVID. You know, it is a most frightful. The whole household collapses the way it is.
I think what Chitra saying is true. I'm very disturbed with Maharashtra also.
Yeah.
See what is happening. The people from ENT and other people are treating the cases, and they are directly removing the eye. See, there are 3,200 cases in Maharashtra, and up till now they have removed near about 33 eyes. Lastly, now I have given the guideline when to touch the eye. See, when you can prevent the eye, that eye may be blind because of thrombosis or something. But cosmetically, when you exaggerate, then that is very difficult to, I think, implant also, any cosmetic eye also. So now I have come with the guidelines that when you can touch the eye and when you are, it is a treatable, you should not touch the eye. Though we have made all the, you can say the mucormycosis treatment that may be 10 lakhs rupees in the private also, we have made free. And we have identified 131 hospitals. But really, I think this is not causing because of only steroid. But because in first wave also there was a steroid. After that also we are not getting mucormycosis. But the mutant, what is the mutant has happened? That is double mutant. That is a B1 -6172. So that is causing the pancreas beta cells damage. And because of that, the sugar is rising. And that is causing all these things. And it is in the only chronic patients who are there in the ICU for more than 14 days. And really this is worrisome for us, for ophthalmologists. I have seen bilaterally blind patient 9. One eye operated, other eye blind because of thrombosis, not treated properly because they are just scraping there. So that also now we have asked the senior person from ENT that how to scrape also. Because see what is happening by scraping, other eye is also getting thrombus. So now that also we have made a standard and we are now training all these people. See, but this is required. And as an ophthalmologist, I have also Santosh also, he was there. That again, if you want to add, I have sent my guidelines to him. If you want to add something, we will definitely guide these people so that eyes will not be removed when it is not necessary. So that is what is in the Maharashtra.
Yeah.
Thank you so much, sir, for sharing these details, sir.
Please go ahead, Manish. Go ahead, please.
Can we request Partha sir to please go ahead with his second talk presentation?
Sure.
Manish, do we have some questions also from audience?
So we come to this talk, the challenges of traumatic cataract and what it actually holds for us. So I'll run you through a few videos in which, we have these traumatic cataracts. And as you can see, that this one is one in which this is quite a deep-seated eye, and temporally and inferotemporally is a lot of subluxation that has already occurred. So what I do is I go in with the marking ring, which has to be centered in the center so that we have a good capsular axis, which is well centered. And as you can see that the capsular axis is tough. However, these subluxations do have good and strong zonules where they are not torn. So it is only the area of the subluxation where the zonules are really disfigured and torn and deficient, but the rest of the zonules are good. And thereby we need to rely on the effectivity of the forceps, of the microforceps, so as to do a good job for this. And placing in viscoelastic time and again, taking time so that the capsular axis is good and well centered. And here I have to agree that my good friend Ajay, he has devised these rhexis markers, which we use for every patient, and they are great help, not only for these cases, but also for our routine patients. Placing in the CTR as and when required is the next important step, so that the bag at least is secure to an extent. But however, the CTR might not be able to do its job. And here what I was feeling is, because of the subluxation, and it was much more than what I thought. So the CTR was going right vertically, and thereby we placed in these two hooks so as to have the CTR go in horizontally and thereby support the capsular bag. So once there, then the rest of the things are easy unless vitreous is coming into the anterior chamber. And we are blessed that the vitreous has not yet come into the anterior chamber, and we are able to take off the nucleus, which again is not a very hard one, and the nucleus comes off. So with the nucleus coming off, this is the time that we need to reassess the anterior chamber, because the CTR is actually getting laxed. And here what we have is I'm having difficulty because of the hooks there. And since it is now well supported, I take off the hooks and go ahead with the removal of the cortex, and the lens is then placed in. However, if the hooks need to be stayed there, can always be staying, and that definitely gives a good support. Here we have, obviously, as you can see, that this will not just work. And here is when the vitreous has come into the anterior chamber. And as soon as it is there, we need to remove the vitreous from the anterior chamber. Otherwise, the amount of subluxation of the capsular bag cannot be well assessed. Again, there was one mistake that I did, and that is not creating the Hoffman's pocket in the beginning. I thought maybe I would get away with the amount of subluxation without a device, without the segment, but this was definitely required, and thereby the Hoffman's pocket as now created is not very neat and elegant as it should have been. So we go ahead and place in the device and the segment, and one segment is good enough for this, because as we understand that the rest of the zonules will take care. However, if it is a very grossly dislocated lens, subluxated lens, then of course 2 segments might be used. And again, by the railroad technique, it needs to be assessed. So here again, that the bend of the needle while doing the railroad is important, so as to not remove the viscoelastic while it is going down. And as you can see, here is another small tip that we need to give, is placing the capsular bag a little below while taking in the needle from so that the capsular bag itself is not punctured while the needle or the 26 gauge needle is going inside. So after that, of course, the anchorage is important, and once the anchorage takes place, the lens and the capsular bag is well in view. However, again, since we are using just one anchorage, it is to be just optimal, so that the pull on the bag is not much and is just optimally there. So once it is optimally there, then of course things are better. And of course, the requisite of a triamcinolone assisted vitrectomy at the end of the surgery is what completes the surgery, and that is the end of the surgery. I have another short video which I will share with you, and this is again of the next part of a traumatic cataract. And here, of course, as we have termed it, trauma is definitely a fact of life. But these cataracts have to be assessed well. And this is one in which we had the cataract, which was very, very hard. It was nearly half popping into the anterior chamber. And we had to place viscoelastic initially. And then, of course, once the viscoelastic was there, we had to smear the amount of trypan blue over the capsule so as to stain the capsule well. In this case, the staining was very important. We used the capsular hooks for this case. And once the capsular hooks were well in place, then the next part of the procedure, of course, is the CTR, which goes in. And once the CTR goes in, then it stabilizes the bag and the capsule. So the hydrodissection again has to be very, very gentle. And as you can see that it is a very hard cataract and it's a brown nut, absolutely. And you can see that these ones have to be dealt very, very patiently. Otherwise, the rest of the zonules also might get ruptured and we might have a total dislocation. But we are lucky here. And most of the cataract has been removed. Now, the next part, of course, is placing in the intraocular lens, again, a single piece lens into the bag, retaining all the capsular hooks in place so that we have a well-centered capsular bag. And with the well-centered capsular bag, we definitely need to put in a CTR, CTS. Now, the CTS that we had actually did not actually drop to the floor. And what we had to do is we had a Cioni ring, which we had to break and place it into the particular place, and it went in. So these patients do achieve a good vision. Of course, there is a lot of high cylinder. And this case is the last case that I would be sharing with you. It has, as you can see, a grossly mutilated eye. There's so much of fibrosis. There's anterior synechia. The capsular bag has been torn, and there is synechia with the iris parts along with the wound of the corneal wound. And in these cases, trying to separate out the corneal wound from the synechia elements is not the correct thing. And here the vitrector is a very, very important tool and must be used judiciously as and when required. So as you can see, we are using the vitrector for most of the part, and you can see that the cortical matter as well as the lens capsule is very much adherent to the corneal scar. And but as we see, a gradual effect comes in that the amount of rupture that had occurred was actually fibrosed well. And these are the savings and these are the graces that is offered in these patients, that it is a fibrosed bag, and at times you need to actually open up the fibrosed bag with your scissors and get it as round as possible. Here we were able to place the lens, and then while placing after that, you can see that there is that tug of matter which is adherent so firmly to the cornea. And this we have to cut out with the scissors, and it leaves a fairly decently centered intraocular lens. And lastly, of course, removing any vitreous that has come in. So these are very, very challenging cases. This patient achieved 618 in 10. And as trauma is definitely a fact of life, but again, it is not a life sentence. Thank you very much for your patient hearing.
Very well said that trauma is not the sentence of life, and it is, we keep on seeing often and very well managed by you. Dr. Pata, I want your opinion about the spherical and aspherical lenses in cases of trauma. Because of the separation and sometimes the irregular astigmatism, you always prefer aspheric lenses or spherical lenses is a choice?
Yeah, so the aspheric lenses do not have a very great aspect in these traumatic eyes. These ones are usually have, the ones with especially corneal injury would have a huge amount of astigmatism. Now, correcting astigmatism and correcting a traumatized eye is definitely different. And the astigmatism definitely needs to be left alone initially, have the eye well settled, and then think about any other procedure that can be supplanted for a very high level of astigmatism. But first and foremost is getting the eye quiet, getting the cataract out, giving vision even with glasses, and then of course going in for the other procedures which can improve upon the vision.
Yeah, just a comment.
Any choice for single piece?
Yeah, Partha, I think that was a smart move, especially when you were doing a Rexis and then you were putting the CTR, and then you saw that CTR was not going, you put a hook. I mean, these are some things I think a take-home message. But then again, the pertinent question every time, CTR before phaco or after phaco, you have put it before. I also do it before doing anything. I want a vertical and horizontal first stabilization of the lens before I progress. But then that was a hard cataract. A lot of people would have said that putting a CTR in that hard cataract is a tough job, but then you have done an excellent job on that. That's what I would comment.
And another thing, about the toric lenses in these traumatized eye. Well, there is definitely a thought that if it is a traumatized eye and as not traumatic as this one that I just showed with the corneal scar, but even if there's a corneal scar and there's a very high degree of astigmatism, and should a toric lens be put? So basically it is to tell the patient that we are trying to debulk the astigmatism, not to correct it totally. So a toric lens can also be placed. However, it has to be an eye that is quiet, and the corneal astigmatism must have, whatever toll it would have taken, it should have been as stable as possible. So if it is a stable eye, and then a toric lens can be used with that understanding that it will reduce the amount of astigmatism from maybe 6, 7, 8, 9, 10 or whatever to as less as possible. So that in these cases, of course, toric lens is a possibility to be used.
Yeah, it can be a challenge because most of them are irregular astigmatism. So getting the right axis and putting, you could try various 10 instruments, and every time you get I had to ultimately decided to go for spherical because 3 instruments gives so variable result that it becomes, in some cases, when they say near to regular, then still we can try.
The other challenge probably could have been that, the capsular bag would have been so fibrous, or, you wouldn't have space to actually align the lens. At times, even a single piece lens, going further from what Virendra said about aspheric lenses being used, a multi-piece lens is a good option because you can actually manipulate the lenses in whichever position you would want to and take up the astigmatism. Of course, if it is used like 8, 9, 10, in that case, bioptics not going to help, but then you can do laser vision correction at a later date as possible. So do we break for lunch?
Yeah, I think we've had a very long session, and I would like to thank all the speakers and all the seniors, for hanging on. Thank you so much. The speakers in the random order: Dr. Chitra Ramamurthy, Dr. Ashok Shroff, Partha Sir, Dr. Rajiv Chaudhary, Dr. Debashish Bhattacharya, Dr. Ajay Paul, and Dr. Arup Chakrabarti. And special thanks to Dr. Virendra Agarwal, Dr. Kulin Kothari, Dr. Ravi Matani, and Dr. Praveen Patil for helping us conducting the session. Thank you so very much. I think we have earned this lunch. And before we go back to the academic feast once again, so we can take a break. So, Lahane sir or Ragini ma'am, are you there? I think they are muted. So we'll take a break. Thank you so much.
Everyone as a participant, speaker, and panel. Thank you.
Till we meet again in, I think, on Partha's show in the month of June. I think.
Absolutely, sir. We look forward to.
They are in full strength there. I think it should be, since it is a webinar, I think we should have more than what attendance is there in AIOS normal. We should have 8,000 to 10,000.
So on home turf, we'll see sir scoring more centuries.
Yeah.
Thank you so much once again.
So Anaga, court martial you. Why were you not there?
To be court martialed.
Next time I will be there.
And you have distanced yourself being an ARC member, I think, huh?
No, not at all, sir. Not at all, not at all.
You switched the side, to the defendant, not the prosecutor.
Lovely session, sir. Lovely session.
Thank you.
So nice to see all of you. And on behalf of BOA, thank you so much to everyone.
It's a pleasure. BOA has brought us all together. I have not seen Virender for so long, after such a long time, Virender. So a big hug to you. A big hug to you.
Thank you. Thank you, Dr. Manish.
We all are missing everyone.
Thank you so much, sir. Thank you so much.
Thank you. Bye.
Bye.
Good afternoon, everyone.
Hello.
Hope everybody has logged in. Hello, sir. Kashyap sir, Dr. Jeevan Ladi sir, how are you?
Yes, I'm fine. Thank you, ma'am.
Hello, Cyrus.
Hi.
Hi.
Hi, Cyrus.
Hello, sir. How are you?
Hello, Dr. Memona ma'am. Good afternoon.
Hi, everyone. Good afternoon, everyone.
Hello. Yeah, good afternoon, Dr. Rakesh. Can't hear you, ma'am.
Hello. I think we are on time. We can.
Yeah, should we start so that we don't waste any more time?
Yeah.
Yeah. I'll introduce Dr. Jeevan Ladi, sir.
My screen is seeing.
Yes. So I would invite Dr. Jeevan Ladi, sir. He is the ex-chairman scientific committee, MOS, ex-president, Maharashtra Ophthalmological Society, ex-president of Pune Ophthalmological Society, loaded with many awards and gold medals. It will be an honor to listen to him. And he's going to speak to us.
Phacoemulsification in
subluxated cataract. Yes.
Shall I?
Yes, please start.
Thanks, ma'am, for the kind introduction. So this is a subluxated cataract. And when we are having a subluxation less than 90, we can use a simple CTR. If it is more than 90 degree, you can use a Sionist rings with two fixation. So we are showing few cases. Now this is a trauma with a corneal scar, posterior synechias here, and subluxation, which is in this area. This area, almost more than 180 degrees is there. So we don't break this synechia not because it is acting some sort of a support. So we are not breaking this synechia in this region. And while taking the incision, be a little bit careful because there's a corneal scar in this region. I will not go into the detail of this. Basically, what we have to do is whenever we are doing any manipulation, it has to be set area. As you can see here, more than one is there. But in this area, some are still there. And so we may use a simple CTR for this patient. So this is now once the nucleus was wound, we broke the synechia in this region. You can see that some part of the iris is damaged. And after putting this lens, using a Sionist ring in this patient. We'll not go into the detail of this. Preferably, we put a 3-piece lenses in these cases because it gives additional support. This patient was posted for toric multifocal IL. marking was done, and somehow we felt that people dilating well. So we thought it might be there because of intuition cataract, but the people started coming down during the surgery. The main reason was the subluxation we can see in this area. The subluxation which did not allow people to die. We could finish the surgery well, and as you can see that it's only one quadrant which had subluxation. We are putting simple, can see a CTR, and the stabilization is quite good. This is a toric multifocal patient. So basically, in small people, if you are having additional holes, as you can see here, where the aligning the lens becomes more easier, especially during the surgery intra-op, that's very crucial. So we saw the alignment and it was quite good. Now, this is the subluxated cataract, and subluxation is more than 180 degree, as you can see here. This surgery was done in an era where the capsular fixation rings were not available. So we will be using iris retractors only for this patient. As you can see, even the incision was 2.8. We were not taking 2.2 incision at that time. Now here we have to contemplate before, during the surgery, that where your rhexis is going to be. As you can see here, this area is area of zonule. So we want to make a smaller rhexis, which is away, and contemplate that this is going to come. So capsular hooks were available at. We have put retractors now. Is the video seen? Kashyap sir?
Yes, yes, it is seen.
Patanaga?
Yes, yes, it is seen.
Okay. Now we are going ahead with the phacoemulsification. Okay. Now, okay, thank you. So we are doing the phacoemulsification, and you can see a bag now here. Now, cortical aspiration we are doing only into the area where the zonules are attached. And we are removing this cortex, because if you try to remove this cortex, the entire bag, so we are keeping this cortex for the end. The visco, whatever could come easily, we are taken out this cortex. Now we take 1.2 millimeter incision at the center of the subluxation, and this 1.2 millimeter incision, we make a small tunnel of say 0.25 millimeter using a crescent blade. So it creates some sort of a wedge here. In that way, the suture knot will go and it will not protrude out. So we are passing the needle now. We have released the retractors. So this is a prolink.
Never splurge on unwanted conflicts. Will camouflage into NPT and mistakes. Unknown weird form the greed attires. If you let loose your method of defiance. Differential knowledge of need and want. Save few time spent turning into
Dr. Jeevan sir, you are on mute, I think.
Ragini, mute. Ragini, you mute yourself.
Yeah. Have you stopped sharing, Dr. Jeevan sir? Are you through
I
with
think
your
Jeevan,
presentation?
we have Jeevan,
We cannot see the presentation.
we can't see your presentation, Jeevan. Yes, we can see now.
Yes, sir. Yes, sir.
Yes, please restart from where you had stopped.
So we put the now the bag is collapsed. We retract the bag with one instrument. You can take any instrument. In this case, we have taken a duster hook and put the lens inside. Now you pull from one side, the eyelet will come into position where it is to be. And it well and tie.
Sir, your voice is, I think he has some issues in connectivity. Maybe we'll let him join and we'll start with the second speaker. Dr. Kashyap, sir. Yeah, Dr. Cyrus is next on the line. Dr. Memuna, you were to invite him. Yes.
Yeah, so now we invite Dr. Cyrus Mehta to deliver his talk on anchor or ring, which is better in the subluxated cataracts. Dr. Cyrus Mehta is a well-known name in the ophthalmic circles. He is not only an patient anterior segment surgeon, but he also performs vitrectomies and squint surgeries. It is unusual interest besides ophthalmology, and that is bodybuilding. Dr. Cyrus Mehta, please.
Hi, everyone. Can you hear me?
Yes, yes, we can hear you.
So unfortunately, I'm not at home. I'm at my sister's house in Alibag. So I don't know how good the network is. I tried to get it to work as best I can. But
Yeah,
please
we can see
excuse
you.
if something happens. Okay. So let's start then. So my talk was on subluxated lenses and loose zonules, basically. So let's have a look. So the first case now, this was a case that came to me. This lady was lying in a hotel by the pool in Goa, actually, and a mango fell on the eye. So normally when anything falls on the eye, they go to the GP and the GP gives Ciplox. That is their go-to eye drop for everything. After 3-4 days, she realized it was getting worse. Then she came back to Bombay and on presentation, IOP was 50. Cornea was quite clear. She had a mid-dilated pupil and the human lens was luxating into the AC, shutting the angle. So I gave her a mannitol IV and an oral Diamox and to reduce the IOP because I didn't want to operate her with 50 IOP. And then we take up the case. Let's see how the video looks. So I named this video Mango Season. So this is how it was with you can see the human lens is halfway into the anterior chamber and everything is loose. So this is not like a total dialysis, but a lot of the zonules, 360 degrees are gone. So I kept a CTR segment standby. I kept a capsular tension ring 12 millimeters ready. And we try to do the case as best we can. Just do a hydrodissection, do everything a little bit slower. So this is not like a traditional cataract case. She was just like 55. So I didn't have capsular hooks in this case. We just run out of them. So I used pupil hooks. And pupil hooks will do the same job. Now remember, in a box of pupil hooks, you get 5 hooks, not 4 hooks. So you can use all 5 like this and hold the capsular bag in position. And then just do your regular phacoemulsification. So the pupil hooks do the job, in my experience, nearly as well as the capsular hooks. Capsular hooks are different. I'll show you in the next case. So just remove all the nuclear matter. And now you have to be a little careful when you do IA, so you don't pull the bag off the hooks. Because at this stage, if you pull the bag off or the rhexis tears, there's going to be trouble and everything will just become more difficult. So take a little extra time and gradually go to the fornix and pull it off. Peel off the cortex. And once this is done, I put in the CTR. This is a 12 millimeter CTR. So I wanted to see if it was holding the bag in place or not. So this is a preloaded CTR, which we get. I don't use the single piece CTRs which are not preloaded because they are a pain to put inside. This is much easier. This is just like injecting. Just inject it into the bag and you're done. And in goes the IOL. And basically the story is over. I realized the IOL sitting perfectly. The bag was perfectly in position. Rhexis was centered. So this case still comes back to me about 4 years later regularly. Her IOP settled down after some time. She didn't need a trap. And I put in some air at the end, like a safety measure. See that AC doesn't shallow by the next day. Let's have a look at the next case. So in a subluxated lens, we have two options. Should we use a ring segment or should we use a ASIA anchor, which is now in generation 2? Let's have a look at this video. So when do we use capsule hooks in subluxation and when do we drop anchor? Let's have a look. So this was a case of femtosecond laser cataract surgery with a sublux lens. And you can see it's a perfectly punched out rhexis. Now you use Helon or any sodium hyaluronate, create a little bit of space. I learned this technique from Ike Ahmed. I've not invented this or anything. This has got a very nice video of his on YouTube, which anyone can see. Now these are the capsule hooks that we use. So you put in 3 capsule hooks and hold the capsular bag. So the capsule hooks have got these paddles at the end. So you can really push them into the fornix. It holds the bag better than pupil hooks. But if you don't have capsule hooks, then pupil hooks will just have to do. Now you railroad the suture out of the eye at 2 places. So the double arm suture. So you tie it to the ring segment and put the 2 sutures out of the eye like this. And just put it into the capsular bag. Put a CTR also to stabilize the bag and inject the lens in. So this is very simple and straightforward. This is not any great big surgery and everyone does this. Now what happens if you have a poor rhexis with a small rim of capsule? And when you can't hold the capsular rim up with capsule hooks, what do you do then? So in this case, I used the Catalyst system, but wasn't perfectly set. And something went wrong. And instead of doing a capsulotomy, it's made some odd looking perforations in the cortex. So actually the capsule has been untouched, which is rather rare. That's why I recorded this. So trying to do a rhexis after that isn't very pretty. And the rhexis has run away, as you can see. And I'm pulling it back in, giving it a hard pull. But now I've got hardly any rim of rhexis. So how am I going to hold the capsular bag up? So in this case, mark 3 millimeters and use a device like an anchor. So you take your Tenno double arm Prolene, pass it through the hole of the anchor like this, and just tie it. So it's simple and straightforward. So you have tied the anchor by the suture. So you have the anchor and a suture. You just railroad the suture out of the eye again, which again is a rather simple procedure. And in this case, I put the anchor in the capsular bag to give it some kind of measure of stability before doing IA. Can you all hear me?
Yes, we can hear you. Yes, yes.
So basically lock the suture in place like this. I don't know if you can hear the narration of the video over my voice or not. And put a second locking bite. So you just pass it through. So you don't need all that flap and glue and all this other stuff, which looks good in videos and you can write 50 papers on it, but you don't really need it. The sclera you can just suture directly. Nothing will happen. Retina surgeons have been suturing the sclera for 40 years and nobody had glue and nobody made any flaps. So inject the IOL inside into the capsular bag and that ends the situation. So you can manage this kind of situation very easily and this is the end of it. So this was my little talk today. I hope I have not gone over or eaten up any extra time.
No, thank you. Thank you, Dr. Saras. It was a nice presentation and different ways to handle the subluxations. There are many, many ways discussed in these 2 previous lectures. Thank you so much, Saras.
Thank you, sir. Thanks, Anaga.
Thanks.
May I ask Dr. Jeevan?
Stop
Are you there?
sharing, Cyrus. Yeah.
Yes.
Dr. Jeevan?
Yes, yes, yes.
And Dr. Kumar is there? Dr. Kumar, doctor?
Yes, sir. He is in one session. He'll come back. He has 2 talks simultaneously. Good afternoon, Dr. Kashyap, sir. Thank you so much for being with us.
Good afternoon, Dr. Ragini ma'am.
Good afternoon, Dr. Anaga. Good afternoon, Dr. Malay Bhaiya, Dr. Bahadur ma'am.
Good afternoon, ma'am.
Good afternoon, Dr. Rakesh Bhaiya. We meet finally after trying to meet for the last 2-3 years. Good afternoon, Tushar. Thank you, sir. Thank you, Kashyap, sir, for managing this session so well. And Annaga is the able start. Thank you so much.
Thank you, madam.
With
Thank you.
Bahadur, madam, and
Good
Mohana, and
Good
everybody
afternoon.
together. Thank you so much.
We can see you are so busy.
Nahi, sir. Thank you, Malay. Good afternoon.
Yeah, good afternoon. Much for the invitation, and it's a fantastic program which you're doing.
Malay Bhaiya, you are family. We meet always and hope we can now meet in person.
Absolutely, absolutely. We look forward to that.
Dr. Himanshu, are you there? Dr. Himanshu Mehta?
I think Kumar and Himanshu
Maybe we'll go on to.
they're having lunch together.
Okay. And Dr. Tushar?
Tusha is there. Dr. Tusha is there, yes.
So I'll request Dr. Anaga to please introduce him. And
Pleasure to introduce Dr. Tusha Om Prakash. He's the director of Dr. Om Prakash Group of Eye Hospitals in Punjab, presently working as a cataract and refractive surgeon at Dr. Om Prakash Eye Institute, published various articles in international journals and contributed in various chapters in textbooks, won numerous awards at national and international platforms. Eager to hear from you, Dr. Tusha.
Thank you so much, ma'am, for the kind. I'll just start sharing it. Can you see my screen?
Very much.
Yes, yes, we can.
Good afternoon, everybody. First of all, I would like to thank Dr. Lahane sir and Dr. Ragini ma'am for giving me this opportunity. Today, I'll be talking on the decoding dilemma in overly soft cataracts with rapid non-fragmentation technique. So there have been increasing soft cataract surgery number due to the recent refractive lens surgeries, demanding patient lifestyle, increased diagnosis about dip in contrast sensitivity, increased surgeons' confidence, and of course, commercial causes. But there have been issues in overly soft cataracts, like it is not easy to crack or divide because of the viscid cohesive material, cheese wiring through the nucleus while chopping. If cracking or separation is possible, then it is often unequal. There is difficult to hold as it gets aspirated because of cohesive nuclear or epinuclear mass, and often it is difficult to rotate with an increased chance of PCR. There are numerous techniques which have been described in the literature, but they have their own shortcomings, like it requires special maneuvers, requires difficult maneuvering, requires customized instrumentations, high fluidics, and surge preventing softwares. So coming to our technique of rapid en masse removal of soft cataract, the prerequisites are the age should be less than 50 years. It should be a clear lens, posterior subcapsular cataract without nuclear sclerosis. Can be a developmental cataract with the preferred LOX grading. A good sized 5 mm to 5.5 mm CCC is essential. No hydrodelineation is done, only cortical cleaving hydrodissection is done. So coming to the technique, so we have to remember the acronym RAPID, rapid. So coming to the R means rotation of the nucleus. So multiple point hydrodissection is done just to make sure that the cortex is separated from the capsule. It's being rotated with a Sinskey hook or a blunt chopper. It is often placed just inside the capsular margin superficially, and the nucleus is tried to be rotated either clockwise or anti-clockwise, just to make sure that the cortical capsular adhesions are separated. Coming to the A is the alignment of the phaco-tip. It is always done opposite to the side port incision. And coming to the P is placement of the phaco-tip at the nuclear rim. Then comes I is impaling into the nuclear rim. And coming to the D is devouring or emulsification of the nucleus. So this is a graphical representation which shows that first is rotation of the nucleus, A, alignment of the tip, that is sideways towards the side port incision, P is placement, then impaling and devouring of the nucleus. Now I'm going to show you and explain you in detail in these number of cases. So if you see here, it is a very soft cataract, a young adult. Often rotation is done with the help of Sinskey hook or a blunt chopper, clockwise, anti-clockwise manner. Then aspiration of the nucleus is done in full aspiration vacuum mode. You can see here, there's no CDE used. So coming to the next case, a good essential 5 to 5.5 millimeter rexis is important in this. Multiple point hydrodissection is done. Okay, R, rotation, then alignment, A, alignment of the tip sideways. This is another case where if you can see, hydrodissection is done, then rotation of the nucleus. Sometimes it doesn't rotate, so you have to try either clockwise, anti-clockwise, and then alignment of the tip, which is done sideways towards the side port, impaling, and then devouring of the nucleus. This is another case where rotation of the nucleus is done, then alignment of the tip, placement at the nuclear rim. Sometimes you can see there is an occlusion break, so you always re-impale to the site next to the aspirated nucleus. Phaco power in milliseconds can be used just to embed into the nucleus, and then impaling is done. Impaling is done in such a manner, coordinated way. With the help of the instrument, it is taken out into the at the plane of iris. Aspiration is done at the plane of iris and then eaten. Coming to another case, unlike Rausling technique, high vacuum parameters are not required. It is done in normal fluidics and vacuum parameters. So it is done in the safe zone. The phaco tip is kept in the safe zone and the nucleus is eaten. So the advantages of the rapid technique is there's no cheese wiring as there's no fragmentation, en masse removal of the soft cataract, there's no hydrodelineation required. It is done in the safe zone area, prevents iatrogenic trauma to the posterior capsule as the nucleus is taken out from the bag away from the PC at the level of iris or anterior capsule and then eaten. It prevents any endothelial loss because it is way away from the endothelium also. There is no special instrumentation or surge preventing softwares required. It decreases surgical time, CDE, and estimated fluid use. It is a multiplanar technique that prevents capsular bag as well as the iris and endothelium. It is easy to learn and adapt. This easy to perform non-fragmentation technique has a short learning curve, a fair degree of reproducibility, a high safety profile, and can be performed by surgeons of all levels of expertise. So if you compare this rapid technique with other non-fragmentation techniques, a capsule rexis of 5 millimeters is very important. No hydrodelineation is done. Sculpting is not required. It is done at a multi-plane phacoemulsification. No special tips or instruments are required. There is no requirement of surgical surge preventing softwares, and no high fluidics are used. So this technique has already been published in the Journal of Clinical Ophthalmology, and it was regarded as one of the top techniques by ASCRS also. Thank you so much.
Excellent talk, Dr. Tushar.
Thank you, ma'am.
Great.
Thank you so much.
Just one question I had for you.
Yes.
So in a very soft cataract, when you do a hydrodelineation, you actually reduce the size of the endonucleus, and one tip can actually be prolapsed into the anterior chamber just above the iris. It makes it easy for it to be emulsified. So how would you rate that compared to your technique?
So ma'am, basically here, first of all, we are not doing hydrodelineation. We are just doing hydrodissection. Often when you do hydrodelineation and when you take out the nucleus, sometimes it leads to the iris touch, and sometimes there is constriction of the pupil also. So we are not doing any hydrodelineation here.
Yes.
Yes, ma'am. And the whole en masse is taken out as a whole. So it reduces time. It is very easy. And I think the rotation of the nucleus is very important at the first place, because when we are making sure that the nucleus, the cortical part of the nucleus is adequately separated from the capsule, and then we just take it out as a whole.
Yeah. Right. We welcome Dr. Himanshu Mehta, sir. Good afternoon, sir.
Hi, good afternoon, Anaga. Dr. Kashyap, good afternoon to you.
Hi, sir. How are you?
You're only in the surgical cap. You just come out of the OT, you know. You just
I like to hide my hairs now. So Dr. Himanshu is here. He needs no introduction. A terrific, a senior, knowledgeable, and a VIP ophthalmologist. I hope everybody knows what is VIP ophthalmologist. He knows his priority. He does not mince or chew his words. He always is a pleasure to hear from him. Sir, please go ahead with your topic, that is white cataract enigma.
Yes, sir. Thank you very much for a wonderful explanation and wonderful talk by Tushya over there. And pleasure to hear him speaking every time.
Thank you, sir.
And some good tips he always comes out with. And Dr. Kashyap, after a long time, we are seeing you there, and we always miss you in the conference. We have a great time with you there.
Right, sir. Thank you.
Anaga, always the active person and always around with everything, every time, and with newer ideas. My talk is on the white cataract enigma. It is an enigma because the moment you see a white cataract, well, in the younger patient, white cataract is a little easier to do after the rhexis. In the elder ones, there is a brown-black, shallow AC, white cataract, whatever. You know, every which way you are cornered out by nature and you don't know what to do. The pupil may be stuck at times. There could be iritis, synechias. You could have multiple problems with respect to the white cataract. So what is it and how can we deal with? We have understood that way better. I remember the time before Trypan Blue was available. I'm sure Dr. Kashyap, you remember that we had to put a side port light and switch off the microscope light to see the anterior capsule. You know, it is, I mean, the younger generation cannot imagine a life without Trypan Blue where you cannot distinctly see your anterior capsule. So that's how it was. So it's important that you grade and you're clear in your mind what you're heading towards. The whitish green, yellow, the amber, and the brown and the black. You have all shades of white. You know, there is no white color as usual in life. There are all shades of gray. It's how we perceive in life. So here, there is the stability of the rhexis, how dense it is, whether it's soft, the anterior chamber status, because the most important thing is the anterior chamber and the PC pressure, the posterior pressure from behind, plaques on the capsule, which can come in way of your problem and create more issues with you because there could be a fibrotic plaque underneath the anterior capsule and with adhered to the anterior capsule also. So which are the things that we'll have to look at? The most important is you have to have your assessment, how deep, how soft, how gentle, how tough you have to be with respect to the pressure. You can't be building up a lot of pressure on the anterior capsule, otherwise it will rupture and create the Argentinian flag. You can't be too shallow also. You have to have a closed chamber, and the AC plaque has to be dealt with because that can come in way of your rhexis. Of course, femtolaser helps you in everything because it's a closed chamber, entirely closed chamber, and in a few fraction of a second, the whole rhexis takes place within no time. So it helps you not to lose any fluid. It helps you not to get an Argentinian flag often. But if there is a plaque, what happens? I'll show you further. So check these things which will help you. So look at whether there's a plaque, what kind of a cataract you're looking at, and you can judge how good or bad you could be. Giving mannitol, if it is permitted, definitely helps to reduce the pressure in the eye. Yeah, no question about it. There is absolutely no question that you have to stay in your anterior capsule. Rhexis, to start with, is something very, very important because that can make you win the game or lose the game. The whole game lies in how well you start your rhexis, not how well you complete your rhexis, but how well you decompress the anterior chamber. In the sense, the lens is extremely pregnant with fluid, so you cannot touch it, otherwise it will just burst. So you have to be careful to decompress the lens, not from the center where there is maximum pressure. What you need to do is bend a 26 number needle, go through your side port and gently enter mid periphery, make a small nick, go in and aspirate the fluid. Now as you aspirate the fluid, you will see that the capsule slackens and the whole tenseness of the anterior capsule reduces. Again, I'm repeating, just showing you how simple it is to get in slowly, gently. Take your time, there is no hurry because this is the step which will save you for the full cataract. And of course, following that, rest all becomes a lot more easier for you to complete your cataract. And the bigger the rhexis, the better here because you might have a big cataract underneath. So you better have a bigger rhexis than a smaller rhexis. Just repeating that same story that every time it is possible to be consistent in your results and how you can have problems, but slowly enter, take a small nick in one shot, keep your syringe ready to aspirate and be ready to move out further, and then you can carry on with your Rexis. Here again, one more case that I wanted to show you, but what I want to show is again and again, you could be in whichever angle you could be sitting at 9 o'clock, 12 o'clock, nasal, temporal, whichever way. You could be under topical anesthesia, the eye is moving, but you just have to get in there under high mag. You can see the cortex and the fluid moving into your needle. And as you see that, you realize that Rexis automatically becomes mobile. It's not very tense anymore. And once you've seen that the flap is floating well, you know that you reduce the pressure within the intracapsular zone, and you can go ahead and do it. There's one more thing you do, which very well described by Dr. Kapoor from Delhi. Here, he's telling us that you can go in. If you find that it's a smaller one, he definitely does a T-shaped junction. So he cuts with the vanas on both sides. So it allows you to extend the Rexis in both directions, not just one direction. So you can always help yourself in case if your Rexis is going haywire. You can go ahead, look at that with vanas. You could just take a small nick with vanas and you can go ahead with your Rexis forceps. Yeah, that's it. I'm just taking a T-shaped perpendicular incision. Now it becomes a lot more easier for you to go ahead with your Rexis. Yeah, that's how you can go ahead. And if this goes haywire, you have the other Rexis also. The other ear is also, dog ear is ready for you. Now, this is how the whole process becomes a lot more easier. I'll not waste your time now. Here is a femto case. The pupil went down. If you have IFIS, you have terribly shallow anterior chamber with a lot of pressure from behind. The cornea is compensated and you have to start your case well. Well, this is where a femto really helps you, that you can go ahead, you're sure of your Rexis which are there. And sorry, the video is playing on one side, but essentially once you've got the whole game in your hand, the Rexis is properly done. Rest all becomes a lot more easier. However, one of the things that I wanted to show you when I spoke to you was about the plaque. I've got the Rexis going, but as you see, as I'm removing, here there was a plaque directly underneath, and as a result of which the Rexis extended to the periphery. So despite you being careful, you have to be extremely careful that you do not, I'll show you again, it's coming from the side, and towards the end I suddenly find that this area was the one which extended behind in a blink of an eye. So at every stage, be very careful with your Rexis and Rexis. Rest all cataract would be removed any which way. It's not very difficult. And of course, as I said, a closed chamber with no leakage of fluid, so that the fluidics is perfectly fine. You get a perfectly circular opening. And once you've got your Rexis, a white cataract is like any other cataract. Not much to worry about. Thank you so much, sir.
Thanks, Dr. Himanshu. Lovely. Good presentation and very well explained. Thank you so much.
Thank you, sir.
Good presentation, sir. So, Dr. Kumar is not yet joined, right?
Okay. Yeah.
Dr. Kashyap, sir, would you?
I don't mind. Yeah.
Next? I'll introduce you, sir. So we'll be eager to listen to Dr.
Jivan, hi Jivan.
Yeah, okay. Go ahead.
Yeah.
Hi, how are you?
Somebody was saying.
Yeah. Go ahead.
Okay. So eager to listen to Dr. BP Kashyap, sir. He's a cataract and VR surgeon, the first ophthalmologist who is also an NABH assessor. He's the ex-secretary of Bihar and Jharkhand Ophthalmological Society. An aggressive surgeon, works in corneal grafting and eye banking. Has many awards in national and regional societies to his credit. An excellent surgeon and an excellent person. Waiting to hear from you, sir. He'll be speaking to us on cataract with trabeculectomy his way.
With Dr. Kashyap, generally it's his way or my highway. You know how it is.
Yeah. So
we see to it that we do not make any tear in the conjunctiva. We go very close to the limbus and cut the conjunctiva, this Fornis-based conjunctival flap. This followed by very mild cautery or diathermy just to stop the bleed. We make a triangular flap, that is, width is approximately 3 millimeters and the height is 3 millimeters and the depth is 2/3 of the sclera. Make the site incision a little deeper and then we put the mitomycin C. The cotton buds soaked in mitomycin C. Mind you, we insert it in the connectile pocket and we keep on changing it, because if you keep it for some time, the concentration of the mitomycin C does not remain the same. So after a while, again put the next bud soaked in mitomycin C. And we try and insert the bud as much as possible, that is, deeper into the connectile pocket. By this maneuver, you lose a lot of mitomycin C, so you keep on changing the bud. We proceed with the triangular scleral flap of 2/3 thickness till we reach the blue zone. And then we insert the crescent in the substance of cornea. In case of any doubt, we remove it and do it again. We do not enter the anterior chamber at this time. We put the mitomycin C soaked bud underneath this scleral flap also. Before we do the rhexis, we will be removing this bud. So now there is a routine cataract operation. Rhexis is done without the help of trypan blue. This is a very hard nucleus and hence we made the rhexis on the bigger size, that is approximately 6 millimeters. Normally we make 5.2 millimeter rhexis size. As you all do, we make a side port and then do hydro dissection. Tilt the nucleus, rotate the nucleus, and they proceed with the phacoemulsification. This is very hard nucleus, so we are doing a debulking in the center and then do a direct chop. You can see the brown edge of the nucleus. The other trick is when you are eating up the last bit of the nucleus, I remove my Sinskey hook from the side port. And before I remove this, I put the viscoelastic inside the anterior chamber. The lens is injected. Now the anterior chamber is filled up with the viscoelastic again, and then we enter into the anterior chamber by the keratome. Trabeculectomy is done by trap punch, followed by the peripheral buttonhole iridectomy. And we irrigate it so that the hole is patent and there is no layer of any kind of a pigment layer. And we try to stitch the tip of the triangle as early as possible because we have seen expulsive hemorrhage happening through this small hole. And then conjunctiva is stitched and we do not take any part of sclera. Then the irrigation aspiration is done to remove all the viscoelastic, and we remove any debris from the iridectomy hole side, and we hydrate the corneal wound, and by this time there is a bleb formation. So it is just to repeat the in other case that we by the time we reach the blue zone, we put the flap on the crescent knife and insert inside so that you make a very smooth incision in the cornea, very smooth tunnel in the cornea. Now we put the mitomycin C in the conjunctival pocket and under the scleral flap also. Pull the flap up, and after the cataract operation we do the irrigation aspiration. By the time you can see the bleb is already formed. If the bleb is not formed, we see that there's some problem, and in the end we always inject air into the anterior chamber because we have seen people, because of foreign body sensation, rubbing the eyes and AC become collapsed. So these are a few points I want to highlight. Thank you very much.
Excellent talk, sir. Lovely video. Great presentation. So you're on mute, sir. Please unmute.
Yeah, thank you. Thanks a lot.
Great presentation. Lots of pearls. And next speaker is Dr. Rakesh Shakya. Mohana ma'am, would you like to introduce it? Yes.
So steroids is the buzzword after the second wave, and even in uveitis we use a lot of steroids, but which could lead to cataracts. But the surgical approach is a little. The surgical approach is slightly different from the conventional surgical approach. So let us hear from the experienced surgeon, Dr. Rakesh Shakya. He's a consultant, glaucoma and cataract services, Sadguru Netra Chikitsalaya, Chitrakoot, MP. He's member of Scientific Committee MPSOS, and he has performed about 1 lakh cataract surgeries and other surgeries too. And he has performed live surgeries. Over to you, Dr. Rakesh.
Hello. My video is coming?
Yeah.
Yes.
Hello.
Yeah, you are audible and visible as well. Please go ahead.
My video is running, but I'm not. Hello.
On that.
Video is not running.
Just a minute. Just a minute. Now it's running?
No.
I'm just sharing the video, my.
screen is frozen. We are not able to see the video.
Actually, I'm not unable to. Sorry.
You can stop share and start share again.
Now I want to share again. Now it's running.
Yes.
Now I can talk.
Yes, please. Please go ahead.
My video is running.
Yes, sir. Yeah.
Yes. So this is the first case. Actually, they are the very less UBIT case. They only the postage Sainika is present. So we remove the postage Sainika with the help of iris repository and put the VX ring in this case. So these are the ring is the 6.5 mm and then expand the people up to 5.5 mm. And with the help of the two iris hooks, or we can use the Coghlan hook to insert these ring. And then you can adequately expand the people very easily. Now we make a capsule X slightly bigger and then hydrodissection done in this case, and the cataract was very soft, so just aspirate it and then put the lens in the bag after removal of the cortex. So this was the post-trap case. And then after that, we remove the VX ring and then aspirate the visco and then hydrate the side port. Another is the slightly difficult case. If the pupillary mammal is slightly thicker and postage Sainika is there, and then deepen the chamber with the help of visco, and then we make a 4-port for the iris hooks, and then with the help of the iris reporter, we slightly dislodge the membrane and then peel off with the help of Utrata forceps. And then put the iris hook and just expand the pupil up to 5.5 mm. And then with the help of Utrata forceps, you can make a rhexis easily. And cataract was not much hard in this case. And then we use the stop and chuck technique. This is the vertical chop. So easily emulsify the nucleus and put the lens after removal of the cataract, cortical matter. So this is the another case is the slightly very difficult. So I make a one hole in the iris because there and put the visco and deepen the chamber. After that deepen the chamber becomes slightly deep, and then we make a hole in the epilenticular membrane with the help of and then with the help of the detector I cut the pupillary membrane and then capsule. And this is the peeling of the iris membrane. This is the and then so the nucleus was very soft, is easily aspirated with the help of bimanual aspiration. After that, I make a slightly remove the another membrane is the only the pupil, and then with the help of Bonner's seizure we cut the capsule to make a slightly circular, and then with the help of bimanual IA, then retract the iris and put the lens. So after that, we make a surgical iridectomy with the help of detector, and then after completion, we put so when the condition gets very tough. My video is running.
Yes, Rakesh, your video is running.
Hi, boys.
Yes, we are able to hear you. There's a little lag though, that's all.
This I can. So this was the very thick membrane. With the help of the Bonner shear, we cut it and then try to peel off, but the membrane was very thick. So actually try to cut with the help of the retractor, and then so after remove this membrane with the help of iris sculptor, we just release the synegia. And after the BX ring is implanted, let's expand the pupil. We can slightly zoom it and then you can see the properly. And with the help of the cystitome, we make a axis with the help of Crathers forceps. So just leave it and put the visco and expand the bag and then put the CTR. And then lens aspirated with the bimanual and the job become very easy. But when you implant the lens was very bulky. So it is refused to go in the bag. So I try to remove the lens again and then try to remove the BX ring also. But the ring become engaged with the lens. So it is very difficult. And then put the lens again, and then when I remove this rings, I see the vitreous was prolapsed. And then I cut the vitreous by the help of the retractor, and then again cut the lens in the half part and then remove it. And then put the less lens. When I inserted the interpitial, advantageously the air was gone. So the iris actually the push towards the upside due to the air, and the vitreous also prolapsed. So I just remove the air with the help of iris. And the transplant is also come out, and the vitreous also come out, and the iris prolapse was there. So I cut the vitreous again, and then repose the iris and leave the case. So after 1 month, the pupillary capture was clear and vision was 660. So I take the case again and then remove the lenticular synechias. These are the additions. I remove it and rotate the lens. And also remove this inflammatory material. Thank you, sir.
Yes, great presentation. That was a very difficult case that you managed, but managed very well, sir.
Actually, the complicated case actually require the different approach to management and different therapy pre and post operative period, and additional manipulation is required. So in this case, the pre-operative is very important. So you can divide the case in the two parts, is very slightly less difficult or more difficult. When the membrane is very thicker or very very adhesive to the iris. So you have to first check the inflammation and slightly postpone the surgery up to the 3 months. So I should be quiet up to the 3 months before the surgery. Then we plan the surgery. Thank you, sir.
A lot of times these patients also have raised IOP as a secondary complication of uveitis. So how would you manage these patients before you take them up?
So when I put the triamcinolone injection, I always put the hello. So when I put the triamcinolone, I always give the Diamox early postoperative period. If they are the early postoperative, either IOP is mainly due to the inflammation or due to the viscoelastic or debris. But after the 7 days or after the 2 weeks, when the IOP is slightly higher, then manage accordingly.
Sir, I meant even pre-op, when the patient has a lot of posterior synechia, sometimes they go into iris bombay and secondary glaucoma.
So the initially, if the posterior synechia is there when the IOP is more than 40, we always go for the trap first, then do the surgery. Then surgery is postponed. Then manage accordingly.
Do you atropinize the patients before surgery?
Hello.
Can you hear me?
No.
Hello.
Hello. Her question was,
Am I audible?
Yes, ma'am. Yes.
Yeah.
Her question was, do
I
you
want to ask you
atropinize
whether
the
you
patient?
atropinize patient before surgery.
I'm not properly audible, ma'am. Sorry.
Her question was, do you atropinize the patient before surgery?
Yes, ma'am. Actually, initially,
Sometimes when you break the posterior synechia,
no, initially, ma'am, inflammation should be cleared before 3 months of surgery. So the patient always put on the steroid and the atropine. So this is the
most of the times, if you go ahead.
So this is the
sometimes if you
require some oral steroid also, some actually atropine. So the follow-up is required. Then we'll decide the surgery in between.
Even if the quiet eye is atropinized before surgery, and if there's only posterior synechia, not any membrane, then when you break the synechia, the pupil tends to dilate on its own. You sometimes don't require any pupil dilators.
Yes.
Achha, one more question. Could you please tell me why did you say that the lens was bulky? It was not, like to go inside. What made you think that the lens was bulky? Was it what was the dioptric power of the lens, and what was the condition?
Actually, the lens actually the slightly plate type of lens. So this was actually bulky. Sometimes the patient choose the lens. This is not our side when the patient take some package, and so the lens was very bulky when I saw during the surgery. So this actually refused to go in the bag. So by this reason I remove it and then put the less bulky lens.
Should move to the next paper, ma'am.
Yes. Dr. Kumar has, I think, not yet joined. So let's invite Dr. Malay Chaturvedi, sir. He is the immediate past secretary of the UPSOS NOS and a very active managing committee member of the AIOS. He is presented and conducted and operated in live surgical shows in various conferences. He's an excellent human being. Waiting to hear from him.
Thank you, Dr. Naga. Yeah, thank you, Dr. Naga. We had a lot of interaction with you previously. I hope I'm audible.
Yes, you are.
Okay. So the question is, at a stage when everybody can do phacosurgery, what is the relevance of this topic, code to crack nucleus? It actually takes us through a thought process over which we have evolved over a period of last couple of decades, and how we have gone into the jargons of technology and ultimately nudged down to the basic facts. So that is the relevance. And over a period of time when I was operating, I just narrowed down to certain points, and I thought it would be very useful to share with you. And therefore, I chose this topic, code to crack nucleus. The purpose of planning a nucleotopy is to go and understand the basic forces which are responsible, which will lead to a predictable crack and a reproducible crack. So is there anything which we can nudge down, which will produce a crack every time, in every hand, in every type of cataract? Now, when I have presented this earlier in a different format, and I changed the format in this presentation. Actually, the cracks are produced in mind. If you know what you are going to achieve, then you will achieve that in the surgery. So what is happening, that we know that there is a main port, there is a side port, it is present in an angle, and a crack will produce in between. So a bit of three-dimensional thinking is required before we are actually planning a crack. So here the point is that we should understand where we will put our main port and where we will put the side port, how these two instruments will be angled, and then where we expect the crack to happen, so that if we know what is going to happen, most probably it will happen in your surgery. Now, when I was looking into various literature, this photograph took my attention. This photograph is showing you the lines of pre-existing crack. Your crack is likely to develop somewhere near to these pre-existing lines, and therefore I have taken up this photograph. Now, the question is whether this lamellar pattern exists in mature cataracts or not. So I have downloaded certain photographs, and these are the photographs taken from an angle from the eye of a pathologist. So this is a mature cataract, and you see in various grades of maturity that linear pattern or the lamellar pattern persists even in cases which are Brunnesen cataracts. This is a beautiful photograph which is actually showing you line of hydration. And we must remember that the water moves on the path of least resistance. So if we are putting our instruments in this area, that means we will be putting in the right area, and that is how we will generate a crack. So it is basically a science. It's also a bit of arts. There are a variety of phaco tips available. When I went to my OT and I saw that I have so many phaco tips, so all tips have produced crack. That means any tip would have produced a crack. There are so many phaco machines. There are so many techniques, and all of them have produced crack. That means any one of them would have produced crack. So choppers, somebody will say that your chopper should be so sharp that you should tear your abdomen. The other will say you use a Sinskey hook and you will generate a crack. So both the things, a wide spectrum, have been able to produce a nuclear crack. So that means the trick is neither in the machine, nor in the chopper, nor in the technique, but trick is somewhere else. It is again, we come down to the same photograph, the lamellar pattern we understand, and we have to understand the force which is known as lateral separation. Now, everybody knows that lateral separation is responsible to produce crack. But 25 years back, when Paul Koch launched his first book, which I read in my senior residency period, he talked about lateral separation. After that, so much have inflowed. Every surgeon has come out with his own technique, and we actually forgot this word lateral separation. In another meeting, when I was discussing this, there were few key consultants who understood and who agreed that it is actually the lateral separation that produces a crack. Now, here is an innovation. What happens when we do lateral separation? Then it produces a horizontal line. But if we pronate our hand, the same crack goes deeper. So in order to give a Y component, we need to pronate. Now here I will try to show you how pronation of the hand takes your crack deeper. Let me see if I can show video. It's a couple of minute video. If it runs, it will explain everything. So here, you see, you watch my right hand and the phaco tip is moving slowly. These are the three cracks. These are three cracks which we are showing. And you can see the aspiration probe. It is actually moving and the crack is going deeper. And there's not much of movement. And you really don't have to do a lamellar section, or you don't have to stress too much. This is another case with pre-existing pterygium. And here again you see embed, embed, separate, and just pronate. So when you pronate, the crack goes deeper, and surprisingly many times it cut the posterior lamellae also. Here again, a different grade of cataract. Just embed, embed, separate, and pronate, and the crack goes deeper. So when we pull, actually, we don't create any separation. But when we separate and then pronate, and without much of movement, in variety of degree of difficulties, you can actually pronate. You can actually take your cracks deeper. So basically what I understood out of all the discussion is that if we understand the lamellar pattern of the lens, if we know that that pattern persists despite maturity, and if we know that it's the basically lateral separation which cracks the nucleus, we should be able to produce cracks more number of times in a more predictable way. And if we pronate, that's my innovation, the crack will go posteriorly. Thank you very much for giving me the time. Three-dimensional thinking, realizing lamellar pattern, understanding lateral separation, and stating the beauty of pronation. Thank you very much.
Thank you, Dr. Malay Bhaiya. Thank you so much.
Yeah, thank you, ma'am. Thank you. Yeah, thank you, Anaga. You have been so nicely conducting the whole session. And really, BOA has come up so well. It is really creating new milestones.
Malay
Participating
Bhaiya,
is, yes, ma'am.
sorry to interrupt, but you know, BOA has come up because you people make the effort to come, to travel, to spend time, this time to come and talk. So we cannot make a conference a success. It is the scientific people and you all who make it a success. We are all here only, but you come, you spend, everyone gives input to different techniques, different things, and carry home messages, which is so important. Thank you so much.
Yeah, actually, it is real pleasure to participate in such an activity, and you always give me a chance. So thank you very much for keeping me in.
No, sir. Who am I? We are one family. We have decided this many years back, and we have to be like one family always.
Absolutely, really. Thank
It
you
is
very
with the
much.
guidance of Lani sir and Ragini ma'am that year after year we have been able to
Evolve.
discuss and share such lovely experiences. Ragini ma'am has been the strength behind this BOA conference.
Absolutely.
I cannot take credit alone, Anaga. You are the staff working hard, putting us on the AIOS map, and you rock.
And I can
Madam,
tell,
on behalf of all the panelists, I must thank you very much for giving us this opportunity. You are the main pillar. You are the boss.
Yes.
yes. And I can tell you that the Western ophthalmology, this Mumbai ophthalmology, is so full of energy and so different. Interacting with this class of consultant is really a very learning experience, very much learning experience.
Thank you so much, Malay Bhaiya. We try to maintain this family atmosphere because I think all over India, whenever something happens, we'll come to realize that we are one family of ophthalmologists.
Absolutely.
Thank you so much. And thank you so much, Kashyap sir. He being so busy running a big hospital, he took the session over, charted out everything in his meticulous way. Thank you, Kashyap sir, for this. And thank you, everybody. Thank you so much.
Anything for you, madam, and anything for Dr. Lahane, sir.
Kashyap sir, thank you very much.
Anything for you, sir. Anything for you.
Rakesh, thank you. Thank you, Malay.
Thank you, sir. Thank you, sir.
Thank you very much.
Really.
Everyone, thank you, Naren. Thank you, Memuna, Bahadur ma'am. Thank you.
Thank you so much.
Himanshu. Thank you, Himanshu. Then the Mohana Mujumdar is also there. Thank you.
Thank you, sir. Thank you.
There. I think I was there in the ARC symposium. So Anaga, thank you very much for conducting nicely. Thank you. Thank you very much.
Sir, Rakesh Bhaiya is there.
Rakesh is also there. I forgot. Rakesh is also there. Naren, I
Dr.
spoke.
Naren Shetty sir is there.
Yes,
Dr. Naren
Rakesh,
Shetty sir, thank you.
Rakesh is also there.
Hi, ma'am. Hi, sir.
Hello, hi,
Naren,
Naren
thank you.
Bhaiya. Hi,
Naren,
Jeevan
Thank you
Bhaiya.
for having me over, sir. Thank you.
Thank you for being with us. It's a big honor for us. I know how busy everybody is. You must not say thank you to us for calling you. We are the ones who have to say thank you.
Not
For
at all.
us, it has been a big honor to have you all. And हम लोग पीछा नहीं छोड़ने वाले. BOA वाले बहुत ऐसा पकड़ के रखते हैं.
Absolutely.
Thank you, ma'am. Thank you.
Absolutely. It will be a pleasure to
Thank
stay
you,
in touch
Bahadur
with
ma'am.
you.
Thank you.
Thank
Himanshu
you.
bhai.
Thank you, Ragini.
Sushya. Thank you,
We
Mohana
finished in
ma'am.
time. I
Bye.
think only one speaker is left, but I may not be able to join, looks like.
I saw him in the session.
Please go ahead.
Where he
Please
is.
go ahead.
Anaga, if you have time, carry on the discussion with a few questions.
Yeah,
Yes,
sure.
exactly. That was what I wanted to ask because it's now 3:35. I'm not sure about the next session. So
3:45.
They will sit on your head. Don't worry. They will come and bang on your head. So you have
3:45.
till they come. Don't worry.
yeah, so maybe
With
we
your
should hand over.
speakers, with your speakers being so fantastic and
Correct.
Kashyap sir and you have finished the session and you have time for discussion.
It's not because the help of the
Naren
Dr.
Shetty
Anaga.
and Dr.
She's
Kashyap
so
and
nice.
everybody here, and Dr. Rakesh. We have to ask.
Yes, so one question I had for Dr. Jeevan Ladi sir regarding the implantation of the ECR. What is your choice? Would you implant a CTR through the main incision or through the side port? This is the first part of the question. Second part is, would you like to use a second instrument to guide and compress the CTR as you're dialing it into the capsular bag?
Preferably, we try to put it through the main incision. We try to put through the main incision. Can you hear me?
Yeah, there is a slight crack
Go
in your
closer
voice.
to the microphone. Jeevan, go closer to the microphone.
Just hold your mic closer to you, please.
Okay. Can you hear me?
Yes, now it's better.
Yeah, we prefer to put it through the main incision and then go opposite side of the subluxation and start putting the ring inside. And at the most crucial question, I think what you asked was that at the end part, that how do you finish it? Now, how do you put the end part? You go below the rhexis margin down to the mid-bag level and flap it down so that it will not come back again and spring back outside the capsular rhexis into the sulcus. These are the two things which are preferably we try to do to keep the, make sure that the ring goes in the back.
Dr. Naren Shetty sir had something to say, please, sir.
Yes, ma'am. So what normally I really prefer to implant the CTR through the side port, and I normally do it under irrigation, always towards the part where the subluxation is. And one simple tip, and it's the easiest way to implant, is using microforceps. So if you use the microforceps, once you have implanted the CTR, I mean the The trailing part of the CTR, you just hold it with the microforceps, go through the side port, and then make sure you release it only when you're right in the center and deep. So this way you're rest assured that the CTR is in the bag for sure.
Yes, and one more thing I thought, with your left hand, if you can stabilize and support the CTR with a Y-shaped forcep or Y-shaped hook, so then that would help, and compress it and put it into the, so that it doesn't slip into the sulcus. And one question I had to all the panelists: suppose as you are putting the last part into the capsular bag, suppose it slips and goes into the sulcus, what would you do? Dr. Himanshu Mehta, sir?
Good question. I know it's like tapli kaisa marne ka wo apne last mein boli. That's what I was trying to say.
Very difficult. Huh?
So,
Call somebody.
Yeah, that's going to be a tough part, because now you are in a catch-22. So you don't know where it is. You are blind. It's hidden way beyond the iris, and you are really in a tough situation. So you really want to avoid that situation. You could tear the capsule. You could just create more bleeding out there by trying to track it. Well, difficult. So one of the things to be done is to tie a thread at the beginning before you start injecting it. Tie a thread so that you can always retract it back. That is one of your safety margins that you can do. In the needle of the eye, in the eye of the needle, you can just take a thread, keep it there. It's always there for you to retract it whenever you want. This is the best safety margin that you can keep.
Naga, when it happens, when you see that edge, suppose it is lying into the sulcus, so you can say 3/4 of the ring is there in the bag. Now you go to the edge with a lesser hook or a T-dialer. So where it is changing, where you can see that margin, you slip it through that and you go on to the edge, push it towards the center, and you will see the edge of the ring. And then at that time, you can take a Y hook, or you can take a Sinskey hook and see to that it flaps back.
Yeah, so I
It's
had
very
a case like
simple to do.
So basically, you can probably also use a bimanual technique. Take two Sinskey hooks, slightly longer ones, and there will be one point where it actually crosses from inside to outside, and you can see the edge where it has
Correct.
actually gone outside. So
Correct.
you just retract the iris and then
Correct.
go to that point, and using two instruments, using good viscoelastic, then slowly with a double-handed bimanual technique, slowly you can bring it back. So I've had a case where I brought it back into the bag. That was one way of managing. Anybody has any other tips? Yes, sir, Dr. Rakesh?
But then if the capsule is okay, if the rhexis is fine, only then you can put the
Yes,
CTR.
yes, absolutely. If there is a tear in the rhexis,
You're
then
gone.
you cannot.
You're gone then.
Yes. Dr. Rakesh
Ma'am,
had something to say.
I always take two instruments. In the left hand, I always take the Coughlin hook, so we can guide the CTR into the bag.
Yes.
And other hand, we take the Sinskey hook. So there the chance of CTR gone to the sulcus is very less. And another technique, sir is also suggested that you can put the one thread in the eyelid. So it's the good technique.
Right.
Yes, Dr. Naren Shetty wants to say something.
Yes, sir, please, sir.
If I can, the small tip is, definitely if experienced surgeons like you all are operating, I think it's much easier to remove. If the whole CTR, sometimes you can go to the sulcus itself, So that time I feel if the surgeon is not experienced, just let it be where it is. Don't worry, don't try to fish hook that, that will cause more damage. Forget about that CTR, put one more CTR into the bag. So that way, you're not manipulating further and damaging the zonules. But if at all, I think if one is in the sulcus and one is in the bag, I think the two handshake technique with the microforceps, that's my preference.
Handshake is always very nice. Now Dr. Krishna Prasad is here. Now he has to be caught. He cannot keep quiet. You have to say something, Krishna.
We actually belong to the next session, sir.
Hello, good evening,
You are
sir.
allowed to-
Waiting
We're
for you to
trespassing
take
into this
over.
session.
Hi, Dr. KP.
Okay, hi. I think I cannot agree more for what Naren said. When you have one CTR in the sulcus, just leave it there. Okay, I'll put another one. Because we have found that many a times they do remain silent, and I think it's not worth fishing it out. I think that's probably the take-home message.
Right.
No, the question was, Krishna, 3/4 of it is in the bag, last 1/5.
Okay, then what Naren said.
Yes,
You're always ready to shake hands.
Yes.
Great. Thank you so much, everyone, for a lovely
Thank you.
session.
Thank you, ma'am.
Thank you,
Thank you,
Dr.
Dr.
Kashyap
Anaga.
Bye,
sir,
everybody.
Dr.
Thank
Bye.
you,
Thank you.
Sir,
Thank you.
Ragini
Thank
ma'am,
you.
Krishna Bhaiya.
Lani sir.
Thank you.
Anaga has finished way before you could throw her out. No, please, this is.
Hi, Krishna Prasad Bhaiya. Thank you,
you, Anaga.
especially
Thank you, everyone.
Dr. Ladi sir. We
Thank you.
kept him busy. He didn't even have time for lunch. I'm so sorry, Dr. Jeevan Bhaiya.
No. It's my pleasure, ma'am. It's my pleasure.
Thank you, everybody. Thank you so much. Thank you, Krishna Prasad Bhaiya. Thank you.
Hello, ma'am.
Thank you, Anjana ma'am.
Thank you.
Thank you.
Thank you, everybody.
Thank you,
Dr.
everyone.
Rakesh.
Bye.
Thank you.
Bye,
Let's
everyone.
go.
Bye,
Shetty, sir.
Ragini ma'am. Thank you so much.
Thank you, everyone.
Take care, and we'll go on to the next session. Thank you very
Yeah,
much.
thank you.
Take
Good
touch.
evening, Dr. Krishna Prasad sir, Dr. Nitin Dedia sir. Thank you so much.
Good evening. Good afternoon. Good afternoon.
Okay.
Hi.
Good
Can you hear
afternoon,
me?
Dr. Nitin Bhai. Good afternoon,
Hi.
Dr.
Good afternoon,
Varman sir.
Ragini. How are you?
I'm very good, sir. How are you? Good afternoon, Varman sir. Good afternoon, everybody.
afternoon.
Thank
Good afternoon.
Thank
Good
you.
afternoon.
Nitin, isn't it your birthday today?
Arey, you caught me, huh?
Many happy returns.
That's true.
Nitin Bhai,
Many
happy
returns.
birthday.
Thank
Happy birthday,
you.
sir.
Thank you
Varman
so
Bhaiya,
much.
Varman sir, thank you. Thank
Good
you. This
afternoon.
is sorry I didn't get a chance to.
No,
Thank you so
no
much.
problem. No problem. You're too
Happy
busy,
birthday, Nitin Bhai.
Ragini.
Happy birthday.
Thank you so much. Thank
Actually,
No,
if
no,
this were to
no.
be a physical conference, we would have dragged him to a party after the session. They can always send us the link for a Swiggy or Zomato, no problem.
Definitely, definitely. All thanks to the lockdown, we are all hooked on to Swiggy and Zomato now.
So, hi everyone. I welcome all speakers and panelists for the session of the cataract in a special situation. So as to be able to justice to all the speaker and talk, the introduction will be 1 or 2 line only. And it is, let's the amazing presentation speaks on it. It is my request that all speaker remains on time. I thank team BOA, Lane sir, Ragini madam, and giving me opportunity to moderate this session. The first talk is by Dr. Nitin Dedia. Nitin Dedia sir is our past BOA president and eminent cataract and a refractive surgeon, known to for his fine, skillful surgery. He will present on challenges in pediatric cataract surgery, sir. Please, sir.
Thank you, Divya. Thank you for the
birthday, sir.
lovely short. Thank you. So, good afternoon, everyone. And my topic is on challenges in. Can you hear me and can you see the screen
Yes,
now?
sir. Very much we can see.
Yes, yes. So I'm going to talk about pediatric cataracts and how they pose a challenge in day-to-day practice. So some of the differences what we see between adult cataracts and pediatric cataracts is basically because there's a difference in the anatomy of the child's eye and the lens. The lens is quite different, and the capsule is also very, very elastic. The child's eye is very small, very delicate. So the way we do the procedure also becomes much more delicate than in the adult. There is always a possibility of systemic disorders. There are anesthesia, fitness, and risks involved. And the cooperativeness of the child is always at a test. Also, there's deprivational amblyopia very high, especially in unilateral cataracts. And the owl power calculation also poses a challenge. And we are always trying to prevent and manage the PCO problem. So the current literature recommendations for timing of cataract surgery is if there is a dense unilateral cataract, then it should be done within the first 6 weeks of life. Dense bilateral congenital cataract within 10 weeks, because there's incidence of poor visual outcome if you go beyond 10 weeks of age. And also if there is absence of preoperative nystagmus, then it is a better predictor of a good visual acuity than the age at which we do the surgery. And the critical period we all know is for fixation reflex to develop is between 4 weeks to 4 months of age. So the surgical techniques involves a couple of different modalities, that is lens aspiration through a limbal route with the use of a phaco needle or Simcoe cannula, and a vitrectomy handpiece is always important to have in hand. or you could do a lens aspiration with anterior vitrectomy or a lensectomy, where if you're doing a lensectomy, then limbal or pars plana route is preferred. The peripheral rim of the capsule is left for IOL implantation, so that there is no PCO formation also. But however, there could be a vitreous incarceration in the wound. The risk of RD is always there if you do not do a proper vitrectomy. The incision, normally it could be either scleral tunnel, limbal, or clear corneal. I prefer a scleral tunnel in children because it poses a significant reduction in the postoperative inflammation compared to limbal section, but it is difficult to perform due to a low scleral rigidity. Or you could go a little limbal, that is also preferred, but it's always important to suture this incision, however small it may be, and even the side port, especially when you are operating on infants. The location of incision, again, superior is preferred since it's under the lid, and there's a temporary risk in viewing because of the possibility of trauma and long lifespan post-operatively. And low scleral rigidity always promotes leakage, and children are more likely to self-traumatize than the other population. Continuous curvilinear capsulorhexis is the gold standard and is a critical step. And the challenge here is, again, it's very thin, elastic capsule. So you always need to be towards the center whenever you are pulling on this capsule after you have made the initial nick. And how do you manage is you use, in all cases, trypan blue has become very handy. Use of high viscosity viscoelastics and use of a capsulorhexis forceps also helps. And we need to regrasp the capsule very frequently. Also, a small rhexis is preferred about 5 millimeter so that you don't run into the periphery. The other option is to do a vitrector rhexis, means you use a vitrectomy probe to do the rhexis, or you could, and it could be an alternative approach in children less than 6 years of age. Also, you could use a radiofrequency diathermy capsulotomy, but it also has some disadvantages because the rim becomes very taut and sometimes it can initiate a tear in certain areas where your diathermy is not proper or complete. Posterior capsulorhexis also can be done, and it is important to do it with a vitrector, and you select your cases and then do it. You could either use a vitrectomy probe or a cystitome along with the rhexis forceps, and you could also use a dye for doing the posterior capsulorhexis. So this you could combine it either with or without a anterior vitrectomy, and you can, normally we prefer doing a vitrectomy so as to prevent the incidence of secondary membrane formation. The cutoff age for doing a PCCC and an anterior vitrectomy is especially less than 7 years of age, you should do it. More than 7 years of age, these children can tolerate a YAG capsulotomy tear. So this is a video I'm going to show of a child who is 4 months old. And here you can see that it's almost like a mature cataract. Here we are going a little bit, we are not making a scleral tunnel, but we are going limbal. We're using, I normally prefer using a diamond knife. And
video is seen.
The video we can't see properly.
You can't see the video? Okay,
Yes.
1 minute.
You can play it from the file itself, sir.
Play it from. Here.
Yes.
Now you can see?
Now it is clear.
Yes, yes.
Okay. So we've done the rhexis here. We've done the side ports. We've not done the rhexis, sorry, but we've just done the side ports first. And we've stained the capsule, made an initial nick here.
Too fast forward.
Yeah. And here you can see that I've started now. It's a little difficult, the initial, after you make the initial nick, And then I use the capsulorhexis forceps. Here again, you have to be towards the center of the capsule, and we complete the rhexis. Here we have completed the rhexis, and then as I'm trying to remove the cortex, I find that I have still not, that was just the initial membrane. So once again, I have to go, and many times these capsules are double layered. And so here we have a second layer of the anterior capsule, what we see, and we make a nick. And once again, we perform the same rhexis once again. So you may see these kind of surprises in children. And yeah, because it is a little small, we made a nick again, and then we complete the rhexis. Then we use the vitrector, and after removing all the cortex, you can see how thick the capsule is all around. And then now I do a PC-tomy with the same nick with a needle, and then use a vitrectomy probe to do the posterior vitrectomy, anterior vitrectomy. So, and then because the child is only 4 months old, we complete the procedure, leave it as it is, and leave him a phakic. Yeah. So.
Thank you, sir.
Okay. I think my time is up.
Yes, sir.
Okay.
Sir, our next speaker is Dr. Rajesh Sinha, sir. He is a professor of ophthalmology in Rajendra Prasad Center, AIIMS. He has various publications, more than 80 chapters in a textbook, and written 3 textbooks also. Please, sir, over to you. We can't hear you, sir. Sir, please unmute. Yeah.
I'm really thankful to BOA and MOS for having me here. And I'll be talking about cataract surgery in oil-filled eyes. I have no financial interest. Now, cataract surgery is increasing. As far as cataract formation is concerned, it is increasing because there is more and more number of retina surgeons that are coming up. They are getting trained. More vitreoretinal surgeries are being done. So cataract secondary to vitreoretinal surgery as such is increasing. So that's why the surgery requirement is also increasing. Now, there are various factors that are responsible for it. One, of course, is the intraocular gas or silicone oil, or there is direct instrument touch, or there can be progression of senile cataract. Diabetics undergoing VR surgery, they have a high risk of early cataract. And then, of course, combination of factors that can lead to it. And there are various challenges. This is not a simple procedure. It's not like a routine cataract. There are various challenges. There's high risk of complications because of the, some residual effect of the previous surgery. There is increased chance of post-op inflammation. Then there can be emulsified oil in anterior chamber. There can be presence of PC plaque for which you require a removal, or if it's not possible, then you have to do something else in order to provide a visual rehabilitation. Then there can be presence of a PC defect as well because of the direct instrument touch. And the prolonged surgery, it has been noted that there is zonular weakness in most of these cases, and that results in a lot of problems, like there is infusion deviation because of that. Fluid migrates posteriorly through these weakened zonules, and it increases the volume of the vitreous compartment, shallowing the anterior chamber. Then you try to increase the anterior chamber pressure by raising the bottle height, or by any other method, you increase the anterior chamber pressure, and then the fluid further migrates and further makes it shallow. You start having iris prolapse, etc. So all these challenges are there. You can have fluctuating anterior chamber depth because the vitreous support is gone. But if there is silicone oil behind, then that can push the capsule as well. So all these issues are there in challenges are there in case of operative vitreoretinal surgery. So that is why you have to do a very thorough preparation, very thorough pre-op preparation in these cases. You have to figure out the posterior capsule status. Then you can do it by OCT, by ultrasound, all those things. then you can delay the surgery if the cataract formation was rapid. Now, suppose somebody has undergone a vitreoretinal surgery and the patient developed cataract and it progressed to total cataract very fast within 10 to 15 days. This means that there was a direct damage to the capsule and fluid has migrated into the cataract, into the lens, and that has resulted in a rapid formation of cataract. So then in that case, it's better to delay the surgery, because that damage to the posterior capsule, you allow to fibrose the margin of that damage, so that once you are doing the cataract procedure, then that damage doesn't enlarge and the risk of nucleus drop is there if that happens. So you have to be careful, you have to plan accordingly. Then while doing the surgery, you should use chondroitin sulfate related viscoelastic, which can not only coat the endothelium, because endothelium as such is damaged because of the previous surgery, and further it also coats these zonules. So what happens that these viscoat or the chondroitin sulfate material, it coats the little that is there in the areas of zonular weakness. So it is really helpful. And of course, you should use a low bottle height instead of a very high bottle height, and or the IOP setting if it's not related directly to the bottle height. There can be dynamic settings which can be done in order to maintain a lower IOP and while performing the procedure. So this is one such case wherein you can see the oil is there, you can see the reflection. So you can just go ahead and complete the procedure, do the chopping technique. And once you have done it, then you see that there's a small posterior capsular plaque here. Now this plaque, I'm trying to get a cleavage, but there's no cleavage as such. So I've left it like that because it's paracentral. And most of my cases wherein I do cataract procedure in post VRs, I put endocapsular ring because there is some amount of zonal adhesions in majority of these cases. And that is why it's better to support these zonules by endocapsular ring. It's not going to harm anything. And this plaque, which is there in the periphery, in the post-op period, we will just see that if it's coming in the visual axis, if the patient is getting visual affected, then we may remove it by YAG, because it's not preferable to do a PCC here in an oil-filled eye, otherwise it will become completely messy. Now, if you have a plaque, something like this, wherein you have a nice plaque, which is wherein you have a nice cleavage plane, you can create with the help of a Sinskey hook. Then in that case, it's better to remove the plaque. So you just create the cleavage plane, hold it with the capsular access forceps, and then you can remove this completely and clear the visual axis. And once the visual axis is cleared, you can put the IOL in the bag. Sometimes what happens that you have a plaque which is quite dense, as you can see here, but there is oil. So it is again not advisable to do a PCC here. The posterior capsule opening can be created once the patient is planned for a silicone oil removal. And at that time, the opening can be created with the help of a cutter as well. Now, if you have a pre-existing posterior capsular defect, as you can see here, now this patient had a direct damage by the instrument, and that caused a posterior capsular defect. But as you can see here, it did not cause a total cataract. Why? Because the meniscus of silicone oil was blocking. There was no fluid in the vitreous chamber, and there was oil only, and the meniscus was just blocking and supporting the posterior capsule. And that is why in such cases, you can wait for some time so that the margins can get fibrosed, and then after that, you complete the procedure. Now, once, as you can see here, the margins are quite fibrous. So this patient, we waited for 3 months and then we completed the procedure. And then in such a case, you may put a single piece IOL, but I preferred a multi-piece IOL with an optic capture. Why? Because this optic capture will block this defect nicely. And as you can see here, when you're doing the procedure, sometimes there is some tendency of oil to come into the anterior chamber. So that will go away. Now, if you have a silicone oil in anterior chamber, it's better to remove this. You all keep doing it. So we wash it completely, and then we can go ahead and complete the procedure. Now, femtosecond laser can also be performed in these situations. And this is just a routine case wherein it's an oil-filled eye operated VR. So femtosecond laser has been done. However, in some scenarios, you can see I'm putting the endocapsular ring as the capsule is quite taut. What I was talking is that in some scenario, you can have fluid in the anterior chamber, not fluid, sorry, silicone oil bubbles in the anterior chamber, and it will cause shadow on the lens. So this area will not be cut. And when you do femtosecond, I'm just skipping the video just because of paucity of time.
So we are, yeah, short of time.
But you'll just cut this part of the capsule. So it's better not to do a femtosecond laser in such cases. And we don't advocate, but in case you have to do it, you have to, you can remove it completely in an OR and then go ahead and perform a femtosecond laser. In such a scenario, when you inject viscoelastic after removal of the silicone oil, you have to increase the power of the femtosecond laser. We just performed a comparative study comparing the routine phaco versus flax, and we found out, I'll just go to the summary of that. We found out that the endothelial damage and the phaco power requirement was significantly less in the flax group. And one thing I just want to highlight here is, since it's a closed chamber, I'll just take half a minute. Since it's a closed chamber, when you're doing a flax, what we found out that in 40% of cases wherein there was no oil in anterior chamber, while performing the capsulorhexis, some droplets came into anterior chamber, which can happen in some of these cases wherein oil is filled. But when you're doing a flax while performing these procedures, the capsulorhexis, etc., there was no patient wherein oil came into anterior chamber. And of course, the IOL power calculation is a challenge. So if you're doing an ultrasound, you multiply it with a multiplication factor of 0.71. But if you are doing an IOL master or an optical method, then that is more accurate. So in conclusion, there are three major issues. One is, of course, you can have a weak zonule that can have a lot of problems. You can have defect in capsule, or you can have a plaque. So all these have to be managed in cases of operated vitreoretinal surgery. It requires a good preoperative planning and an accurate IOL power calculation and a careful and meticulous intraoperative manipulation. Thank you very much for your patience.
Sir. Thank you very much, sir. It was a great presentation. So
Thank you, Rajesh.
Thank you.
Thank you, Rajesh Sinha, sir, for presenting such a fruitful presentation and showing how to proceed in a difficult situation. Thank you, sir.
Our next speaker is Dr. Ritika Sachdev. As she comes from a very famous lineage and is an accomplished cataract and a refractive surgeon, just like her dad. She will present on us on a phaco in a photolaser in a posterior polar cataract.
Thank you so much for the opportunity and the introduction. Am I audible and is my screen visible?
Yes, very much.
I'll be sharing our experience using the femtosecond laser platform for tackling challenging cases like the posterior polar cataract. Just taking you through a video of these cases. Now, we all know these cases are rather challenging because we are dealing with a deficiency in the posterior capsule, which can give way and cause an increased risk of nucleus drop and vitreous prolapse. The femto platform that we are routinely using is the Catalyst. And an interesting feature of this is a perioperative OCT. When you latch on to the eye with the patient interface, you get an OCT with a view of all the structures of the anterior segment. You see here the purple line really is depicting the posterior capsule. So you trace the continuity of this purple line and you can get a very operative assessment of whether you have a discontinuity in the posterior capsule or a continuous posterior capsule. And this correlates very well to the chance of getting an intraoperative PC dehiscence. You see here that this is, of course, a very visible PC dehiscence. This is the intraoperative OCT that has come up. There is a large area where you see a defect and the epinucleus sheet is buttressing it. So the pre-segmented nucleus is easy to remove. Then you have the epinucleus sheet. It is very important to maintain this thick epinucleus sheet by creating a larger posterior offset when you're doing the femto and avoiding hydrodissection. Now, once this is off, in order to avoid vitreous herniating up, you see the vitreous space here is intact because we filled this up with viscoelastic and not allowed the bag to really collapse. Of course, we've got the paradise, but somehow it's not over till it's over. We've made a wrong judgment error putting in a single piece IOL. A single piece IOL with such a large tear will not be stable in the bag, and it is not ideal to put it in the sulcus because of the larger haptics, making an increased chance of uveitis and glaucoma and inflammation. The lens seems to be dangling, and though we started right, we didn't seem to end right. Of course, there is always a chance to course correct. A 3-piece IOL is the ideal IOL in such a case. So we explant this IOL. Explantation requires you to make a nick right to the center and then cartwheel out the IOL. A 3-piece IOL is now going to be placed. We don't want to compromise anything, so we put in the hooks to make sure that we are putting this 3-piece IOL in the sulcus. Once the 3-piece IOL is in the sulcus, it's a very stable IOL, and we'll then close the incision. And we've had an uneventful outcome with very good post-operative vision. This is another case where again you see here the integral guidance software creates the purple line, and I'll just move back to show you the discontinuity that is obvious. What we have seen is that this discontinuity correlates very well to a chance of getting a PC problem. This discontinuity correlates very well to an intraoperative chance of having a deficient PC. Now, the Rexis is done. We don't need to do hydrodissection because hydrodelineation, because a pneumodelineation has already been done. Simply just eat the segments which have already been pre-segmented. So no maneuver, so you're not transmitting any fluid turbulence or mechanical stress till you are actually removing the epinuclear sheet. So this is a case again where we've used the perioperative OCT as well as the intraoperative enhancements and the maneuvers that the femto allows you to perform. This is a stable IOL. Many months later, we published this article in JCRS where we've seen that there is a high predictive value of 100%. That means if you see an intact PC on the OCT, you will most likely not get a PC rupture. And in 2/3 of the cases where we saw discontinuity on the anterior segment OCT with the catalyst, there was indeed a posterior capsular rupture. There are other modalities like the intraoperative OCT or even the IOL master, which now comes with the shim plug associated OCT, that you can use to assess the integrity of the posterior capsule. I'll just take you over a short video. This is more of a rewind, just to show you that the femto technology and the technique that we use has evolved. This is a case of femto that we did on the Lensex. And this is the first prototype of the Lensex. At that time, the OCT you can see is very grainy, and you're not able to discern the structures as well. As the machines advanced with the software PI, etc. coming in, the OCT also became better. The pattern here that we've used is a grid pattern. Normally, it's better to get segments or cylinders. So we've learned along the way. And because we've not done the procedure as well as we should have, just going back and showing you, there is one classical thing we've done. Here, we've used fluid. With a grid pattern, you don't know exactly where the fluid is going, and sometimes you, by mistake, hydrodissect instead of delineate. Now we don't do anything with fluid once the pneumodissection is done. So because this is an initial case, we have to learn to use the technique and the technology. So what we have here is we have a heminucleus which is left behind, and the PC rip is already there. Now we want to levitate this heminucleus into the anterior chamber. But because this has a lot of grids that have already been made because of the nucleotomy of the femtosecond laser, it cheese wires. But however, we do manage to use liberal viscoelastics, 2 instruments, and using the bimanual maneuvers, we levitate it up. It doesn't come in one piece, it comes in 2 to 3 pieces. And now we use the technique which Dr. Amar Agarwal has popularized, the IOL scaffold. These cataracts, fortunately, are usually soft, and even if emulsified in the anterior chamber under a good cover of viscode or viscodispersive viscoelastic with endothelial protection, the results are very good. So herein, we put the 3-piece IOL again as a scaffold, and after removing the bits of the heminucleus and the cortex, we will then be dialing this IOL into the sulcus to again regain paradise. So all in all, I like to say that we've learned the technique and technology of femtocataract, that as of today, it is a great advantage. The preoperative OCT has a very high predictive value of telling you whether you are likely to be faced with a posterior capsular deficiency or not. The intraoperative pneumo-delineated and segmented nucleus is rather easy to handle with minimal maneuvers. You also have a perfect CCC because many a times you may need to use the sulcus for IOL implantation. Such cases where you don't have the opportunity to implant a toric IOL in the bag can be treated with astigmatic corrections with the femto platform using corneal incisions. So thank you for your attention.
Yeah. It was a great presentation, Ritika.
Thank
So now our next speaker is Dr. Sheetal Bar. Is she here? Dr. Sheetal? I think if she will join later. Can we go ahead with the Naren sir?
Naren sir.
Yeah. So Naren sir, Naren Shetty sir is head of department cataract and refractive lens services and vice chairman of Narayana Netralaya, Bangalore, and he has presented many papers. He's a great surgeon and a researcher. So we will love to hear you what's on phacoemulsification, sir.
Thank you so much for the introduction. Thank you. I think on this onset, I would like to thank BOA and MOS for giving me this opportunity. Today, I'll be talking about the latest and the best in phaco technology. So going through from the very beginning, the evolution of fluidics in phaco, if you see, it has come a long way from the gravity-based to hyperpressurized to active fluidics, and active fluidics coupled with the active-centric handpiece. Now, let's look at the gravity-based system. When there is no flow and you have the bottle at a particular height, you have a corresponding IOP like listed below. But when the flow gets activated, this is where the problem starts. This is where whenever there is increased flow, there is decreased IOP. And this is one of the reasons why when a surgeon is operating on a gravity-based system and they're used to operating in high flow and high vacuum, they tend to operate at a very high bottle height to compensate the lower IOP. Now, when we look at the IOP during an occlusion cycle, in the unobstructed stage, the IOP is maintained at one particular level. And when there is partial occlusion, there is a linear increase, and then it maintains at the same level at the full occlusion. And then there is a sudden dip when there's an occlusion break. And then again, it raises back. This is where the surge happens. And then again, the flow is maintained. Now, coming to the era of active fluidics, basically what happens here is the fluid, the bag is placed in between two motorized plates. Now, this constantly is trying to measure the irrigation line, the aspiration line, and also the flow. This way, it always maintains a good amount of IOP throughout the surgery. Now, here's a graph where you can see when you're comparing active fluidic and a gravity-based system, there's a continuous variation in IOP in a gravity-based system as compared to an active fluidic system where it's beautifully a straight line which has been maintained throughout the surgery. This is the a graph depicting the same where you're comparing the gravity and the active fluidic system. Basically, what it does is it compensates for the varying flow or varying flow rate, and also it reduces the chance of IOP fluctuation. Now, it also has a technology which is called as a occlusion, quick valve technology. Basically, what is there is whenever there's a surge, there is a sudden gush of fluid which goes through the aspiration port. And this, what it does is it creates a real-time occlusion break surge reduction. Now, coming to the next, the main thing is this is the latest which is released, which is the active-centric handpiece. Now, initially there was a sensor which was placed in the cassette, as you can see in this blinking image. And now what they did is, as you all know, the more the distance of the sensor from the eye, the lesser the, it'll take a longer time to respond for the machine to respond to the surge. So what they realized this particular mistake, and they brought the sensor from the cassette to the handpiece itself. So this, because of this, there is a much quicker response. In fact, it is just instantaneously, it reads there's a surge and then quickly responds to compensate it. So with the help of the active-centric handpiece, there's an excellent responsiveness, superior surge reduction, and also stability from start to finish. Here's a graph depicting the same when you're using the active-centric handpiece. There's superior surge reduction after occlusion break. It also has a sensor which automatically recognizes the pupil eye level. This is one really benefit, because after every surgery, you don't have to continuously, adjust the eye level and the indicator in the machine. And it also compensates for the average incision leakage. And it doesn't matter what vacuum you're operating in, be it high, low, the machine does all the maintaining of the anterior chamber. And just to round out the thing, basically we have the Ozil technology, which reduces the energy output, reduce fluid, and also accelerates the cataract removal. Now, how did all of this actually help me? I usually operate at very high settings. That is, my flow is always constant at 700 and the flow is constant at 60. But I used to operate at 60 IOP. But once I started using the active-centric handpiece and the Fluidics, my IOP, I operate at 20 itself. So this has creates a significant impact in terms of patient comfort. And in fact, some few patients have told me when I operate the second eye, doctor, you did something different. I was more comfortable this time. The next thing is, because most of my work is done by the vacuum and the aspiration, my CD count also reduced, and that way protecting the eye also. Now, this is just a scenario where I'm operating at, again, 20 IOP. It's a very small pupil, hard cataract. And as you can see, there is absolutely no, flopping of the iris. I usually don't use my second hand piece when I'm doing my quadrant removal, but just to show in the video that even though there's so much leak which is happening in the side port, still the chamber is beautifully maintained, because the machine compensates for all the leak what is happening and still maintains the chamber throughout the surgery. One key thing is, whenever you're trying to operate in such small pupils, always keep the irrigation ports horizontal, that time horizontal and also above the pupil. So this way what happens is it creates a beautiful fluidics within the chamber, and there is no flopping of the iris and iris prolapse and other complications. So so once that is done, I think this is how at the end of the case, cornea is clear, everything is beautiful, PC also is nice and clear. So here's even in such bad cases, or the cataract is almost black, when you use such high-end machines, the machine does most of the job. You just have to just hold the machine and the job is done. So even several studies have shown that the total ultrasonic time and surgical time with active-centric handpiece is lesser as compared to the routine surgeries. And to summarize, they have brought the sensor closer to the eye by having the sensor in the active-centric handpiece itself. This way, it can respond instantaneously to the changes in the anterior chamber and alerts the active fluidic system and also the quick valve system, so as to compensate the surge and maintain the stability of the chamber throughout the surgery. So it really has revolutionized the way we do our surgeries, and it has increased the comfort, the confidence of the surgeon, and also the speed of the surgery at what he does. And also it makes it much more comfortable. The patients are much more comfortable, and more importantly, it improves the overall safety. So I'd like to end by saying, when we look at machines which help only in diagnosing or help in research or even just for teaching, you might have to think twice before investing. But the devices like this, which has a significant impact in surgical outcomes, which makes it more safer, more comfortable for the patient, improves overall experience for both the doctor and the patient, we don't need to think twice before investing. Thank you so much. Thank you for your time.
Very well said, sir. I think Sheetal is here. Sheetal, are you here? Hello. Okay. Sheetal, are you here? Can we go for
Can you hear me?
Yes. So we'll take. Okay. Hi. I think you finished your emergency. Hopefully you're settled your emergency.
I hope I was not late.
Yeah, you were late, but fine. We have just.
I'm so sorry. I just got time to log in.
So let me start. Dr. Sheetal is a senior consultant at Netradama Eye Hospital, Bangalore. She has received prestigious Young Director Award at ACRS. She is editorial board on Journal of Refractive and Surgery and case reports, and she is a good teacher She teaches quite a bit SMILES and LASIK surgeries, which I know. So please, madam, can we start your presentation first?
Sure. Thank you so much. And I would again want to thank Lahane sir, Ragini ma'am, and Dr. Swapnesh for this wonderful opportunity. I will be talking about the utility of MyLoop for hard cataracts. So as phacoemulsification surgeons, we all have come across some of these complications of hard cataracts, such as wound burns, zonular dialysis, PCR, nucleus drop, and postoperative corneal edema, which can take a much longer time to resolve. When we talk about managing such cases, the surgical approach is extremely important, and the way we dismantle the nucleus, how we break or cut the nucleus is very important. So when we use routine instruments such as phaco, probe, and chopper, it increases the chances of more complications. We use invariably higher amounts of energy, and we use more of the lateral force, which increases stress on the zonules and can increase the chances of capsular complications. So to improve safety in hard cataracts, previously some of the surgeons have introduced some devices which could be used to cut the cataract using zero energy. These were mechanical devices such as a snare, which was introduced in 1983 by Keener. This was a wire loop stainless steel snare, which had to be used inside the anterior chamber after the nucleus was prolapsed, and then this loop was to be positioned around the nucleus to cut the cataract. A similar type of instrument was also published by Dr. Debashish in IGO in 2009. However, these instruments were designed to be used through sclerocorneal tunnels, which means for SICS. They were not really suitable to be used with phaco, and also they were to be used within the anterior chamber after prolapsing the nucleus, which could increase the chances of endothelial cell loss. So for phaco, Professor Akahoshi introduced this device called pre-chop. Most of us are aware of this. So this kind of pre-chopper was supposed to be placed inside the nuclear matter, and then the blades could be opened to separate the nucleus. So this instrument had an advantage that it was a zero energy manual and mechanical device. However, it also had some limitations such as steep learning curve, and it was not so efficient in very dense cataracts because the posterior plate still was could not be completely separated. The femto laser technology has improved safety. It has led to reduced need of phaco energy in the hard cataracts. However, limitations still exist. It's an expensive alternative, and again is not 100% efficient in very hard nucleus because the laser radiation is not able to penetrate into the depth of into the deeper layers of the nucleus, and thus the posterior plate still remains intact, and this can further sometimes lead to complications. So it was only recently when Professor Sean Yanklov, who is working as a professor at New York Eye and Ear Infirmary, he introduced this device called MyLoop, which is a micro-interventional microfilament loop-like device. This device has a loop and it also has an actuator. So this idea originated over wine and cheese when he observed that it was much easier to cut the cheese using a wire rather than using a knife. So if we see the specifications of this instrument, it is a micro thin filament loop-like instrument, and its thickness is only 300 microns. So it's really, really thin, and it is made of a material called nitinol, which is an alloy of nickel and titanium. Its properties are super elastic, and it has excellent shape memory, which means that the loop can fold from a fully expanded radius of 10.5 millimeters. So when it is fully expanded, its radius is 10.5 millimeters, and when it is contracted, it can become as small as 1.5 millimeters. So from 10.5 to 1.5, but it does not change its shape. Basically, only the size changes and it does not get deformed, and it maintains its integrity throughout its use. So these are the properties of MyLoop, and this is how it works. So there is a sliding actuator. The surgeon needs to advance the actuator, and as it is advanced, you can see this loop opens in the shape of capsular bag and the nucleus. And when the loop is retracted, the actuator is retracted, the loop closes. Now let's look at some real-time surgeries wherein the loop has been used, the MyLoop. This is a case of a 70-year-old male patient who had a near black cataract and was planned for toric IOL under topical anesthesia. So very important that before introduction of MyLoop, the hydrodissection has to be complete. So once you ensure the hydro is completed, the loop is introduced first in the coronal plane, and then it is looped around the equator and brought in the vertical plane. And then a second instrument is used from the side port to stabilize the nucleus first. Then the actuator is withdrawn towards the surgeon, and the loop cuts the nucleus into two halves. If you want to take another pass, you can do that. And for such hard cataracts, we advise to make at least 4 pieces. You can make 6 pieces also. So second time the loop can be passed, and you can see you have to first stabilize the nucleus before withdrawing the loop. And now you can see that there are 4 completely separated quadrants which can then be easily emulsified. The surgery becomes very easy and safe. And this particular patient had a very good outcome with a toric IOL. The total energy used in this particular case, the CDE was 23.12, which otherwise without the use of MyLoop could be at least 30 to 40% more. And this is the picture of the cornea 3 days post-op, showing a very clear cornea. This video is just to show that if you make a very large CCC, like in this particular case, so when you're cutting the cataract, the fragments can actually prolapse out of the bag suddenly and can touch the endothelium, which is something we don't want. So the size of the rhexis also is very important. You should not make a very large rhexis or a very small rhexis also, because with small rhexis also, when you are withdrawing the loop out of the eye, there is a risk that it can catch the margin of the rhexis and can cause a tear. This is a case where MyLoop was used in a 68-year-old female, hard cataract with mid-dilating pupil, shallow AC and post-PI. So here I'm using a Malugin ring first to expand the nucleus. Then after rhexis and hydrodissection, I'm introducing the loop. And you can see that you can easily use the MyLoop in presence of a pupil expansion device, which does not interfere in its functioning. So this case also went on well and there was no complication encountered.
Can we have a little faster?
Yes, just. So this was a case where the video doesn't play, but it was a subluxated cataract around 3 clock hours. And here also with the use of MyLoop and a CTR at the end of the surgery, we were able to achieve good outcome. Also, sometimes in SICS, if the case is something like this, where you end up having a relatively small rhexis and you don't want to enlarge the rhexis, you can actually use MyLoop safely. So MyLoop allows for a single-handed atraumatic zero-energy centripetal nucleus disassembly while ensuring full thickness microsegmentation of the nucleus, and it cuts the nucleus independent of its density or grade. So it is possible to be used in a variety of complex cases like pseudoexfoliation, small pupils, and mild subluxation, as I showed. And also with SICS, you can also reduce the incision size. It causes minimal stress on the zonules because the force is centripetal, and it also allows for a more complete cortical sweep and cortical polish, and also potentially protects the endothelium because the deployment is occurring within the capsular bag and not in the AC. However, you must be cautious, and posterior polar cataracts, in my opinion, are complete contraindication for the use of MyLoop, and also cases where you have anterior capsular tears. So to conclude, in our experience, MyLoop, we find it a safe, effective device to manage very hard cases of cataract. And then our post-operative complication rates and intraoperative complication rates have reduced. We see much more clearer corneas in the immediate post-op period. And this device makes an average surgeon brave and a brave surgeon more efficient, is how I want to conclude my presentation. Thank you so much for your kind attention.
So,
Thank you, ma'am.
Next speaker is Krishna Prasad sir, but Krishna Prasad sir is, can we have Dr. Gaurav Luthra? Sir wants to present in the last. Sir, Gaurav sir, both are not here. So, can we move on to next speaker? Arun sir.
Dr. Prasad.
Do you want me to start?
Yes, please.
Yes, sir.
Okay, thank you. Let me share my screen. Yes, there we are.
Yes, sir.
Okay, we've been listening to a whole lot of high-flown techniques and technologies. I'll take you back to ground level with absolute phaco basics. So we need to have a good incision, a good CCC, do a great hydro, and then do a good chop to get the best results in phacoemulsification. We'll go to the first step. The incision should be absolutely perfect. It should be as square as possible. Ideally, it should be temporal and around 2.2 millimeters. So every time you want to get the best results, make a mark. So designed a marker, which makes a mark at the limbus and an internal mark on the cornea at about 1.2 millimeters. So that gives you a beautiful mark where you can achieve a perfect near square incision 10 times out of 10. That's perfect. So that's one way to get it right. The CCC should be central, ideally sized, and between 5 to 5.5 millimeters. Again, I would say use a marker. These are available off the shelf now. You can use a marker of 5 or 5.5. And this mark, though it's barely visible on the screen, believe me, as you go ahead with the surgery, you can see it quite well. I do advocate using a soft shell technique for all surgeries, which makes the endothelium far more happy than you would if you don't use a soft shell technique. You can see the outline of the mark. You can use the outline of the mark made on the cornea as a template to make a perfectly centered, a beautiful, perfectly sized rhexis every time. Then we come to hydro. This is very important. Unless your hydro is good, you really can't rotate your nucleus. So often we try the hydro, you get half of hydro dissection and half hydro delineation. You'll get a lot of cortex left behind and the nucleus doesn't rotate. What are the steps that make sure that you get it 9 times or 10 times out of 10? Leak out a little visco before you do the hydro. You want the nucleus to float up or the chamber not to be as deep so that you create space for the fluid to go behind when you inject the fluid. Lift the rhexis margin, do not disturb the cortex, a steady injection of BSS, and after that, decompress the nucleus again. Here we have this video of that. Leak out viscoelastic, most important. Go under, lift up, move around, and perfect. Every time you will get one without any difficulty whatsoever. You can repeat it again, but usually it is not necessary that you repeat it. You do it just once is more than enough. Another video here. Lift up the rhexis margin, Do not disturb the cortex. Absolutely pristine cortex. Inject, steady flow. Particularly, please remember you have to decompress the anterior chamber when you attempt any hydro. So then we come to the chop, which is considered the most difficult. Everybody wants to do a stop and chop or a 4-quadrant, which is much easier. But believe me, a straight Nakahara chop or the karate chop is very efficient, whether the cataract is soft or hard, whether the pupil is small or large, it works in every one of the situations. One has to get this technique perfected to get the best results. What are the steps that will get you a good chop? You first clear the cortex completely in the rexus area. Then mentally divide the rexus area into inferior 1/3, middle 1/3, and the superior 1/3, surgical superior. Make a small punch into the nucleus in the superior 1/3 of the rexus area. You should go on about 1 millimeter into the nucleus. Then bury deep, vertically in, where your burying is going to occur around the middle 1/3. Penetrate with a chopper with the lower 1/3 of the rexus area. Now move both instruments to each other with a small burst of phaco, and when both instruments almost meet in the center, separate to a horizontal separation, where the separation occurs evenly right through the nucleus. The nucleus does not bend over, but cracks through and through. Here's a video. The rexus is done, hydro done. Clear that completely. Upper 1/3, punch. When the chopper goes in, you bury it in the middle. Lower 1/3 chopper goes in. Both instruments move towards each other. Small burst of phaco. You get a perfect through and through chop every time. It goes down, propagates right down to the absolute inferior part. We'll just speed this up for. This is a much softer cataract. Most of us think you can't do a chop in a soft cataract. Yes, you can. All you need to do is put your energy on, phaco energy on linear, use minimal energy, do the same movement. So it doesn't mean that you can do a chop only in a firm or hard cataract. This would work even in a hard cataract. This is a super hard cataract. Look at the efficiency that you would get here. Same, exactly the same steps. Clear out all the cortex. A punch in the superior 1/3. Hold in the middle. Chop. Small burst of phaco, and lo and behold, you get a picture perfect chop. However hard it is, if your hold is good and your leverage is good, your chop is going to come every time. And believe me, things happen really fast here. So it's a complete surgery. This is a marker that's being done using the caliper, marker 1.2. Mark your rexus. Get a perfect incision. Using the template on the cornea, get a perfect rexus. Hydro, they said, in the right plane. Decompress, repeat if you need to. Exactly the same steps. Clear the cortex completely in the rexus area. Make sure that you expose the nucleus. A punch the superior part. Hold. Chop. You see the chop propagating through and through. The separation is completely horizontal with no stress on the zonules whatsoever. We'll speed this up. So the lens implantation, and then you're through. Thank you.
Thank you, sir. Excellent presentation, sir. Excellent.
Thank you so much, Dr. Varman, sir. Thank you for showing us a ABC of phaco and enumerating each and every steps in detail. And definitely it is helpful, particularly for those who are the new phaco surgeon. Thank you. Thank you, sir.
Our next speaker is Krishna Prasad, sir. He is the head of Department Glaucoma and Pediatric Ophthalmology in MM Joshi Group of Hospital, Karnataka. Sir is a Udupi. He's a very active AIOS and ARC and scientific committee member, and he will talk to us on third visualization in a cataract surgery. Sir, please.
Thank you very much, and both the BOA and the MOS and my good friends, Dr. Ragini Madam and Dr. Lahane sir. So we have seen that the technology and the technique so far have been exhibited by the stalwarts. Now, can we see things better? What is the future of visualization and cataract surgery? So this is a common place that we try to, cantilever necks and look into the analog microscopes, but this is the way I operate my cataracts. Okay, so there are no financial disclosures in this. It's always said that the sophistication in one's own art is a sophisticated pleasure. But however, in surgery, it's a basic obligation. So you need to update yourself. You need to get sophisticated. So the way that we see our cataract, the way we use our microscope, the way we digitally enhance the viewing, the big idea from Alcon is what is called as the Ingenuity system, the digitally assisted cataract surgery. That basically came for a vitreoretinal surgery, and the collateral benefit is that it can be used for cataract surgery. Let us now see the system. This is the whole system. So just I want to take you through the, so this is the most important part where you have a 3D high dynamic range camera, which captures it. To put it simply, here you are taking a picture of the eye and you're digitally enhancing it. So you require a high dynamic range camera, and that is displayed onto a screen. The screen is a 3D 4K OLED display where you can actually see all the details in such great detail. And of course, the heart of the whole machine is you have a high-speed graphic processor. This is the heart of the whole event. So, and obviously you have to see it with polarized glasses. So it's like basically using the photoshopping in the layman terms for seeing things better. So we always talk about enhanced depth of field in various microscopes. If I see this, whatever things are in front or visible clearly, things at the back are blurred. Instead, if you could see like this, you could see the cornea, iris, and the lens plane, everything clearly. It would actually add so much of comfort. At the same time, you like photographs overexposed and underexposed, which basically trying to take away the details of the thing. Instead, if you have a photograph like this, where every detail is very clearly discernible. Okay. At the same time, now we had earlier 640 by 480 basic pixelated small TV screens, which became bigger, enhanced definition, and it became high HD, high definition. Now we have something like this, where it is a home theater system, where every small pixelation brings you so much of clarity. So what about magnification? When we magnify, do we lose the sight? For example, in this picture, if you start zooming it out, we lose the picture. For example, if I zoom it out like this, you are supposed to be seeing it like this. Similarly, if you want to see the bark of a tree, and if you want to zoom it, it should be seen like this. So high pixelation, digital enhancement, and also the acuity. Whenever you focus onto the eye, when you zoom it up, you just see the cornea, you don't see anything around. Whereas if you have a larger field, it's far more. At the same time, as I told you, in simply put a photoshopping, you can take the picture, you can change the picture the way you want. But the most important thing is the ergonomics. I think most of us are going to be the victims of the neck and the back problems very soon. There was a movie called MSD, The Untold Story. The MSD for us is the musculoskeletal disorders, which is an occupational hazard. So we have so many such things. These are common, especially people who are vertically challenged. They sit at the edge of the screen, edge of the stool, or our residents have to bend down to look through the observer eyepiece to operate. So basically the neck and the back takes the brunt, whereas surgeries like this, you are actually leading on to the lumbar lordosis well maintained. You are actually leading on to you can replace it with even a sofa and sit aram say and do your surgery. So the extended depth of focus, I think this is where, if you compare an analog microscope, like you take something like a Zeiss, Lumira 700, not less. So the Ingenuity system provides around 26 to 48% more magnification, and the depth of field is around 5 times more. And the final depth resolution is far better, up to 42%. So let me just show you a small video. Like if you keep these two things, this is under Lumira 700. I'm zooming it up. These are blurred. This is clear. Now, if I zoom it up, this becomes clear and this is blurred. So this is what happens to an analog microscope. Whereas this is under a Ingenuity system, both are at different levels. This is at a different, this bottle is thicker. So even you zoom it, still the details won't go away. That is the whole idea of the depth of focus not changing. And you can always change the way you want. You can change the white balance, just like if you are interested in photography, how you can change the whole overall effect. You can have multiple effects for your different kinds of surgery. So the most important thing is all these machines talk to each other. You can collaborate with their vitrectomy system, your phaco system, and everything, whatever, like we have an IOCT, intraoperative OCT, which can come onto the screen, and the vitreoretinal surgeries, without changing their direction of viewing, they can see all it in one place. Just a small clip of how these things are done. You can see the amount of the field that you're seeing. You can still zoom it up. You can zoom it up to a great extent. You can have, the entire 64-inch screen having only the cornea. So this is where it is fitted onto a Lumira 700 Zeiss microscope. So the advantage here is the ergonomics. At the same time, you can have various digital manipulations of the system to see things better. Even though it actually carries a greater advantage in vitreoretinal surgeries, especially they're working on the retinal surface and ILM and things like that, but in cataract surgery also. But only thing is you need to slightly unlearn few of the things. The hand-eye coordination, which you have learned in a hard way during your PG time, it doesn't take really much time. An expert cataract surgeon would start right away. It probably just requires few surgeries, maybe 5 surgeries. You'll be an expert in doing this surgery under Ingenuity. The advantage of Ingenuity is the corneal opacity. You have corneal scars, you have such cases, you can actually see a lot better than you are actually seeing through a opaque cornea, a relative, we call it as a window of hope. So we did a study just to see what is the surgical experience of the surgical outcome, in which the Ingenuity was far superior on various counts. And to summarize, we have an expanded surgical view. Okay, it's a very immersive environment. In the OT, you really are completely absorbed in it. And there's a lot of surgical collaboration because everybody is seeing what you're operating. The surgeon does not see anything different. Everybody sees it, your anesthetist, your fellows, your assistant, everybody sees the same thing. So you have a better coordination and a workflow. Very importantly, just not for cataract. We do a lot of adnexal orbital surgeries. It's an excellent tool to basically teach or to do an orbital surgery. And obviously, where you have a teaching facility, this is one of the greatest surgical teaching tools. But what importantly, last, is there a lag? This question has been answered already by the thing. The lag is less than 60 microseconds, and anything below that is not picked up by a visual system. So right now, we can definitely say that the lag that people see in the present machines is no longer exists. And what is very important is we need to move with time, and that is where the justice for our patients can be done with changing technology as well as the technique. Thank you very much for your patient hearing.
So it was a great presentation, sir. And now the next speaker is Dr. Nagendra Prasad. You see, sir, here. Nagendra Prasad, sir.
Or Dr. Gaurav.
Dr. Gaurav. So you can discuss something till they come. I think Dr. Gaurav is presenting in somewhere else. Dr. Nagendra is not logged in already.
Yes.
So Naren Shetty, sir, will talk about this 3D visualization. What you think about it, sir? And
definitely, I am completely for. I totally agree what Krishna Prasad sir was talking about. Absolutely no lag. Sometimes you actually, when you're operating, you even forget that actually you're looking at a screen and operating. And there is hands down no competition in terms of teaching tool, nothing like it. The fellows who have learned from since the time we have got the 3D system, the fellows who have trained under the 3D system and who have trained before, they have picked up the depth perception so much more faster, and it was so much more easier because every case, they also don't stress their neck seen through the side viewing every time. They can just simply see the screen, and like it's something beautiful. I mean, if you've not seen it, you have to try it once. It's something amazing.
Didier sir, anything on it, sir?
Yeah, so we are using the RTO 800, and it works very well for cataract surgery as well as for the retina surgery. And one thing I've seen that it definitely makes your posture more stable and more comfortable, and also especially helps in doing toric implant, because with the Callisto incorporated with the 3D, it helps to do the toric implant alignment very well. That is what I have observed in all my toric patients, that my results with both the phakic implants as well as with the normal torics, trifocal torics, it works very well and gives excellent results. So I think Dr. Krishna Prasad, what is your take on the torics?
Yes, sir, definitely. I use the Callisto along with the Lumira 700. I think for a 3D and Callisto combination is one of the excellent things that I also have found out. I think that is one added advantage. And about normally people ask about the cost. It is not what does it change to the patient. Okay, so will the surgical outcome be any different for the patient? Well, with the kind of surgeons that we have here in this panel, it is not going to change. Even with a simplest of the microscope, analog microscope, we will be able to deliver the same result. At the same time, just because the surgeon can do such a job, it is cruel to punish him with such a microscope for the rest of his life. So surgeons also need to be, just like we do so much for the patients, it is a small favor done to ourselves. It is basically, saving our back and neck. So ergonomics is probably something beyond compare.
Yeah, that's a very good teaching tool also, especially for the fellows and the residents. I think it helps them a lot too.
Sir, one question for Nitin sir. You had mentioned that PCC at the time of surgery only. At what age will you prefer to put the IOL in childhood or pediatric care?
Yeah, so because of the shortage of time, I couldn't show that slide, but normally up to 2 years, we are avoiding putting the IOL. So normally after 2 years, we leave it aphakic for 2 years, and then normally after about 20 to 24 months, we take the patient up for a secondary implant. And even after that, up to the age of 8 years, there is a special nomogram we are following, which has been incorporated or which has been given by the AO, and we follow the residual refraction correction for these children. So you have to adjust the IOL power so that when the child becomes, say, around 8 or 10 years old, you do not have a very big refractive surprise by a very high myopia. So, but normally you should avoid it till the age of 2 years.
And will you prefer multifocal or monofocal only?
Especially in children,
I would avoid the amblyopia particularly.
Yeah, so if it is up to 2 years, definitely not. And maybe after 4 or 5 years, when you feel that the refraction is stable, or you should rather wait up to 7 years to do a multifocal. That is what is my take on it.
Nitin and this one Arjitre.
Yes, sir.
What Nitin is saying is about the multifocal IOL in the pediatric cases. See, definitely, I think today, unless and until there is a total growth of the eyeball, we should not go for the multifocal IOLs. But few people are advocating the multifocal IOL, but that is in the research mode.
Yeah.
See, multifocality in the children up till now is not an accepted procedure. Secondly, implantation of the IOL, it was 24 months before. After that, we can implant, but now it has come down. and when the length of the eyeball is more than 17 millimeter, at that time we can implant the this one intraocular lens. At that time, it may not be, you can say, the age of the patient may be 1 year, or you can say 1 year, 2 months, 3 months. But important thing is the length of the eyeball, and if that length is 17 millimeter, that time we can definitely implant the eyeball. Secondly, after the doing that surgery, what is happening? They are not using the spectacles, and better to go for the contact lenses and train the mother so that this contact lens will help them till we are going for the secondary eyeball.
Thank you,
We
sir.
are also teaching the mother how to how to implant the lens, so
I think
that
Gaurav
it
sir
helps.
is on the line. Sir, can we have 5 minutes only? Can we start? Gaurav sir?
Sure, I can cover it in 5 minutes. Yes, thanks.
So
I'm
the
sorry.
Dr. Gaurav.
Gaurav,
Good evening, Lani sir.
take your time.
Sure, sir.
Another session, last session is there, so don't worry. You
No,
take
sir.
your time,
Sure,
and you have a presentation. Don't worry. Krishna Prasad, I was hearing you. That was an excellent presentation.
Thank you.
Like you always used to say that you have to take more time for the last patient. You have more time for the last doctor.
Thanks.
So Dr. Gaurav Luthra is an eminent cataract and a refractive surgeon from Dehradun, and is known for his excellent video presentation. He will talk us about chamber stability during the cataract surgery. Please, sir.
Thank you, everyone. And BOA has done an amazing job. I will be speaking on how to minimize chamber.
Another thing I want to tell him, he is my guru. He taught me how to use the Apple phone.
नहीं sir, हम आपसे सीखते हैं. We are learning everything from you. Thank you so much, sir. And I'll be speaking on how to minimize chamber fluctuations without spending a fortune on a very expensive machine. So we all understand that chamber stability depends on many things. It depends on the pharmacodynamics with the newer machines having pressured infusions and quick response fluidics, so that you can preempt any kind of sudden surge. And the surge can be managed by, the surge usually happens with high vacuum settings and also with fluid losses from the ports. And we now have excellent new machines which are available, which gives excellent chamber stability. And however, we can also approach the same problem by minimizing unaccounted fluid losses from the chamber. And complications, of course, can happen when you have fluctuations in the chamber and the chamber stability is not good. Of course, the most dreaded complication of the PCR, and you can have zonular dehiscence with your instruments catching the capsular bag. And of course, endothelial damage, iris prolapse, corneal edema. So lots of problems can happen if you don't have a stable chamber in one of the ways that you can achieve it. This is a typical example where you can have a surge and that last piece, and then suddenly, before you know it, there's that surge for a moment and you get a PCR. So here we managed to get a circular PCR, a perfect PCR, I like to call it, no flap, nothing. So we could get away in this case, but you can see here in slow motion that as soon as there was this last piece and you had the surge and you had the PCR happening there, it happens in a flash of a second. So I think we've all worked towards trying to achieve a situation where you don't have these surges. The machines have come a long way. And here's another example where during aspiration of that final bit, I managed to just catch the PC. Now you can see here that why this actually happens is because there's so much fluid loss happening continuously. You may be using any kind of pressured fluidics, but if you don't have a stable chamber because of losses of fluid from your incisions, so what can we do? Here we managed to convert this into a primary posterior capsular opening. So we managed to, here in this case, we converted this into a round small rhexis by catching hold of the flap. But in other situations, you may not have time to do that. So what can we do? Now, one big thing which I think we have to stop doing is using these kind of blades for our side port incisions. There is absolutely no control. If you push in it a little bit, you'll have a small incision. If you push it in all the way, you'll have almost a 2 millimeter incision. So there is absolutely no control. We have to have calibrated blades which make the exact same size each time, and they have to be matched to your chopper, to your aspiration, everything, so that the fluid losses through your side ports are stopped, because the main port is actually having calibrated phaco hand pieces which will not allow unnecessary fluid loss. So let's go on and see what we can do. Here is a old video which I wanted to share with you, where you can see that I'm trying to do a surgery with there's almost no unnecessary fluid loss happening from here, but you can see the huge amount of fluid escaping. I've actually designed this new chopper to work so that, you know, it kind of blocks out the incision. But in spite of using this chopper, which is wider at the base than at the tip, we still have a lot of fluid escaping because I've used an MVR, 20 gauge MVR or 21 gauge MVR. And this will never allow, in spite of the best machines, for you to have a stable chamber. So I think the message is clear that you need to do something about it. Now, of course, when it comes to your bimanuals, you can still have a better situation, but you can still see that some fluid is continuously escaping from both the ports. So that's why you will obviously have the tendency for a surge to happen, post-occlusion surge, and you may end up causing a break. So what we did was we started using calibrated knives. We experimented with 20, 21, 22 gauge. Now here is I think this is a 23 gauge which we were working with. For the side port here, we've used a 23 gauge, and for this other port, which is for the chopper, we've used a 21 gauge. And of course, the incision there. And let's see what happens when we are, now you can see that the fluid loss is much less. You know, we don't have as much fluid escaping, so the chamber stability increases, and your amount of fluid required for the surgery also goes down drastically. We can now finish cases in 30 to 40 ml fluid completely, because there are almost no losses happening from our side ports or even from our main port, which needs to have the right sleeve, which should neither be too tight nor should be too loose. Both of them can be disastrous for the cataract surgery. But as you can see here, that the fluid losses have been already minimized, and we can actually have a very, very stable chamber with least fluctuations. And even with an ordinary machine, you will have a situation very similar to a high-end machine, which is taking care of all this fluid loss and fluctuations in the chamber with good fluidics. So you can see that I'm almost struggling to get my side port, and these are matched bimanual ports, which we have helped design with Epsilon. These are matched to either 22 gauge or to 21 gauge. You can buy either of them, and they're sandblasted at the tip, and they both can be calibrated to your incisions. Now, this is the last video where I wanted to show another small innovation. We've done a 23 gauge side port there and here as well. And during the surgery, I'm going to use a chopper which is matched. This chopper is also designed by Epsilon. Again, no financial interest, but they work very hard to design these instruments to be calibrated to our side port size and the chopper size and the bimanual. So we are now using a 23 gauge side port incision for doing for the chopper, which is again going to ensure that there's almost no leak. But once we have completed the cataract removal, I will have to enlarge this incision to 22 gauge. So for that, I will use a small enlargement. You can see here that at this point, I will make a small enlargement. I think the same video is showing again. I'm so sorry. This one, I'll just show you to the point where then I'll finish. Here we have finished removing the cataract. And once the cataract is removed with the chopper out, I will enlarge that incision to a 22 gauge. So the right one is already calibrated. This one I'm going to enlarge. And now I have the right gauge for my bimanual. So you can actually play around with these incisions to give you a non-leaky, perfectly sealing wound. And this helps us achieve a very, very stable chamber without, as I said, spending a fortune. So I think it's of utmost for safety and the predictability of the surgery. A lot depends on your perfect incisions, which are matched to your instruments, and chamber stability totally depends on that. And the right incisions can make or break a perfect surgery. So calibrating the side ports can be a great way to minimize chamber fluctuations and replicate the fluidics of high-end machines. And thank you so much for giving me time, sir, and everybody. And I'm grateful to BOA for allowing me to speak. Thank you.
Thank you, sir.
So I think Dr. Nagendra sir is not there, but his topic was cataract surgery in previous arcade eye. So can a panelist will talk a salient take-home points which we would like to tell us? Naren sir, what we should take care of post-arcade eye biometry, how you will take the IOL power in post-arcade eye,
yeah,
and what are the points?
Yeah, I think the most important thing before you start is, which most of us keep forgetting, is counseling the patient. We have to, make him realize the reality and the complications that can happen, because he'll still expect, a 6x6 vision after the surgery. He's forgotten what his vision was before cataract. And so we have to really explain all the the chances of how things can go, be it from simplest thing like a calculation to you might require glasses, and this one opening, all the things you need to sit down with the patient and explain these things, and you need to document the number of cuts that are being placed. If there are too many cuts too close by, I mean, you can't do anything. But if it is further enough, then you can actually place your incisions in between the arteries, so that you prevent the opening. And always, keep your sutures ready, so that anytime it does open up, you can always suture it and then continue. Try to not to operate at very high IOPs, and make sure your bottle height is good and low, and be as delicate as possible. Try to, one tip when you're doing your quadrant removal, don't use your second hand piece. Once you finish your chopping, you remove, because usually when you're trying to do your phaco, your attention goes to your right hand because you're holding your phaco tip, and you start forgetting the left hand. And that's when, sometimes you might create a little excess pressure, and that slowly will open up the incisions, and then you have a lot of leak and you have other issues. But actually, usually if you are delicate with your instruments, actually RK surgery will just be like any other cataract surgery. You can just get away
any
with
particular point for the choosing of the IOL
Yeah.
choosing which
I think-
IOL and
I-
which formula?
Yeah, I think monofocal is good enough. And I think with all these RKs and this, I think online calculators do an excellent job. I think we just have to simply go ahead with it. Give a target about -1.75 or -2 also is okay. Always target for a little more myopic, and they do a pretty excellent job. But the crucial part is also the incision. Make sure, try to make it as limble as possible. Try not to make it too cornea, and that might lead to a lot of more chances of the incisions that open up.
The real challenge is the astigmatism. That is what we need to take care of. And I think whatever said and done, you use the IOL master. You have to also use, if you have a topography, or if you have one or two other machines like the manual keratometry, you reconfirm the exact axis and the amount of astigmatism if you are going to choose a toric lens, because these patients behave very erratically when you are doing a toric implant, and they have huge amount of cylindrical power also. So to correct that also is a big challenge. So if you have 2 or 3 different equipment, and then take the one which you feel is the best, or which is coinciding or comparable, then you can even go in for a toric lens for these RK patients. And as Naren said very rightly, that whenever you are choosing your incision site, it is better to choose between the 2 RK incision cuts. And sometimes if there are too many cuts, then you may have to reduce the size of your incision, or if you are encroaching upon the cut, then you may have to take even a side suture after you have completed the phacoemulsification.
Thank you, sir.
So one point is the hyperopic shift. That is something the patient will never be happy immediate post-op, because as he said, the shift, especially in the 16 incision RK, would be around 2 to 2.5. It can be highly erratic, depends on the surgical time, how much is the depth of incisions in the beginning. There are many RKs where things have not really worked, the incisions are not very deep. So in such RKs, we actually get away with the lesser hyperopic shift. If the RK is properly done as per the book, like really 90% depth and more than 16 incisions, then you have at least around 2 to 3 diopters of hyperopic shift, which goes up to 3 months. So this is a situation where things are beyond your control. There is a lot of variability, and making the patient at least by 2 diopter myopic would be a better bet.
Thank you, sir.
Thank you, sir. With this, we are ending our session, and we'll shift over to the second session. Sir, anything? Lane, sir, anything?
Thank you, Devagan. Thank you, Krishna Prasad. Thank you, Nitin. Thank you, Arun Kumar. Thank you, Prakash. Prakash has joined. Naren, thank you. I think the RK surgery is what you were discussing about this online. Only the online formula you will have to use. No other formula fits in. Secondly, after that also the results may be correct, may
Variable.
not be correct.
Yeah.
Another thing is a toric. Don't use toric because we don't know what is going to happen. And it is always better to the, you can say the this one, that you must use the lens where that is a unifocal lens, not at all multifocal lenses. And what you have told is in between. So it is always better to go in between. Otherwise, we can always increase the astigmatism. So this RK is a, I have operated the people who are done the pediatric kids, 62 pediatric kids in whom the RK was done. And I will tell you the so much of the problem to operate, so much of the problem to implant, and why the RK was done, I don't know, but I have operated the cases, good result in few cases. I can't say कि सब में अच्छा हुआ, but it is very difficult.
It's awesome.
Thank you, sir.
Now I welcome Deshpande sir and his team. And Prakash, Viral is also there, and everybody for that. And thank you Manoj and Krishna Prasad.
Yes, sir.
Thank you very much.
Thank you, sir.
Thank you very much, sir.
Thank you, Lana, sir. Thank you.
Thank you, sir.
Thank you. Thank you. Thank you.
I will be taking over the session now. First of all, the session, Kakade sir is not joined, I think.
Dr. Kakade sir and Dr. Boramani sir also not there. Boramani
Is not joined yet. The Kakade, Santosh Kakade, who is a member of Consumer Forum, Mumbai State Commission, is also has to give the keynote address. Whenever he joins, I will call him and he will give the keynote address. Till that, because Dr. Kulkarni and Dr. Marathe is having some overlapping programs, I will request Anil Kulkarni to start his lecture.
Yes. Okay.
It is okay, Marathe sir?
Yes, sir. Yes, sir. No issue. तुम्ही मला सांगाल तेव्हा सरांच्या नंतर मी बोलतो कुलकर्णी सरांच्या नंतर.
काकडे सर जर नाही आले तर मग तुम्ही करून घ्या.
Is my screen visible, sir?
Yes, yes,
Yes,
yes.
sir.
Okay, so we just wanted to have some sort of discussion as the wave is now thankfully coming towards the baseline, and we will have to start the work, including the cataract surgeries, which are the bread and butter of our colleagues. So what can be the few things which we will have to be slightly aware of, that just I wanted to discuss. Unfortunately, no financial interest. See, what would be the criteria now to take the cataract surgery, which is supposed to be a planned surgery, and whether to subject the patient to some additional risk? So the criteria could be that there has to be some significant visual symptoms. There can be an impairment of activities for daily living, and obviously to facilitate the management of ocular comorbidities like diabetic retinopathy or glaucoma, where we will require that the cataract needs to be removed. Now, basically, this has to be a shared decision making in this scenario of post-COVID. If the patient is willing for cataract surgery or asking for it, we need to tell him about the surgical risk and benefits. At the same time, we have to give him an option of withdrawal because everybody is afraid of our risk of COVID infection. Now, what is being recommended at present, and these recommendations, as you know, are going on changing every month or every few days, but at present, we would require a negative RT-PCR test, which is done maximum prior to 72 hours of surgical time. At the same time, if the patient is not willing, then let us discuss the beneficial effect of cataract surgery on his quality of life as well as his ocular health. As I said, the comorbidities can be shared in that case. And a legal requirement, like supposing he wants to drive the vehicles, he will not be allowed because his vision is less. And we have to actually also convince him about the low risk of contracting COVID in eye hospital. Now, why it is low? Because we need to counsel him that we are going to reduce the crowding and very less attendance. So maximum 1 attendant per person. We will have to maintain the physical distancing. Wearing of mask as soon as the patient enters the hospital door till he leaves, the mask has to be there, whether it's a outpatient department or it is a inpatient department or a surgical one, and a COVID testing.
Okay. So
now,
any problem?
To avoid this risk, we can have either a telephonic or video consultation and one-stop service. That means whenever the patient comes, that there should be only one visit prior to surgery, which should include all the relevant tests which are supposed to be done at our place, using of personal protective equipments and updating the infection control practices. Everybody is now aware that our budget of infection control has almost become double or even 2.5 times because of these additional expenses. Now the European Commission has earlier given guidelines, which are routine guidelines, nothing to do with directly COVID. Now what they suggest is that you have to give information which is tailored to the person's needs, depending on what he's suffering from, depending on what is his profession or business, everything. An informed consent obviously cannot be stressed more. And there should be a full discussion about ophthalmological and general medical issues before the surgery is planned. Because remember all the time that this is a planned surgery, which can be postponed in case we have a slightest doubt that it is not in the patient's interest. And information about individual risk also of the complications. For example, if the patient is high myope, we must discuss with him about a possibility of retinal detachment so as to slightly persuade him not to undergo surgery quickly. Now, the NICE guidelines always say that these are the routine things, like you should have a proper biometry, keratometry, pre-existing astigmatism also need to be seen, and a selection of IOL, which is obviously is a totally different subject, not being covered here just now. The surgical safety checklist is important. Please prepare a complete checklist of what we are going to see prior to surgery and during surgery and whether it is being followed. It includes even the recognition of the patient also. Now, physical fitness from a MD medicine doctor is virtually a must, and a qualified standby anesthetist is always desirable. There has to be an availability of oxygen cylinder as well as resuscitation equipments, which includes either Boyle's apparatus or at least an ambu bag in every theater. Now, what are the new strategies which we are now following? One is to minimize the hospital visits. Another is an online consultation. Third is the topical anesthesia, so that we are not touching or creating more problems by giving peribulbar. On-table mydriasis is something which can be thought of rather than asking the patient to come earlier and stay in the hospital for more than 1.5 hours for the pupil to get dilated. And a use of povidone iodine, which is of course is being used widely in our specialty, but this is something which has got a major effect in preventing infections. So the key to proper success also includes that there has to be a HEPA filters which are present in our operation theater, plus using of 3-layered mask and transparent tape of upper edge to nose. And this is to be done not only by the doctor, but for the patient also. Use of personal protective equipment, including covering of the entire body with the sterile clothes for the staff, as well as for the doctor. And now this is the situation where we can think about a sequential bilateral cataract surgery, because that will reduce the patient's visits and the exposure, as well as undergoing RT-PCR every time the patient has a problem. A recovery also is always seen, which will be simultaneous. But the cataract surgery needs to be postponed if the patient had a history of myocardial infarction within these 6 months. If his hypertension is more than 200 by 110, or he had a history of acute CVA in the last 3 months, because as you are aware that the COVID is also producing changes into the vascular circulation. It can also be postponed if you have a positive RT-PCR in the last 4 weeks. That means you need to minimum wait for 4 weeks. If there was a symptomatic COVID, then obviously you have to wait for at least 6 weeks. And if the patient was admitted in the hospital for COVID complications, then 8 to 10 weeks is the minimum period before we can advise him for a cataract surgery. So to summarize, we will normally, these are the things which are told by all medical legal papers, that we have to do OPD papers for 2 years and IPD papers for 3 years. I just gave you as an example. But what is important is that all our medical liability is related to standard of care. And as long as we meet such standard, we have nothing to afraid about the medical legal problems. So to summarize, we follow all the NICE guidelines as routine. We discuss with patients. There can be a written questionnaire for the patients to be answering so that they are comfortable in taking a decision. A surgical safety checklist needs to be prepared and followed very scrupulously. Use of personal protective equipments is a must for patient as well as for the staff and the doctors. Social distancing obviously needs to be maintained. Testing for COVID will be changing as per the government and AIOS guidelines. At present, we have already summarized how they should be there, and avoiding crowding, that means keeping less number of surgeries on a day so that we do not have more patients and more relatives coming up, or deferring those surgeries at a later date probably could be an answer for our post-COVID cataract surgery. Thank you for your patient listening.
Thank you, Dr. Kulkarni, for giving a nice talk. I will request Dr. Prakash Marathe to give his talk because he is also busy to go somewhere else. So he can continue his talk. I will request the team which is behind this to help Judge Kakade to get logged in, please. So whosoever team is there.
I think he's there inside. He's logged in now.
Also. Okay.
Good evening, everybody. I am thankful to organizers of BOA MS conference, Dr. Lahane sir, Ragini ma'am, Dr. Preetham Samant, Swapnesh, and all the team of BOA as well as MOS. I am thankful to our chairman, Dr. A. Deshpande sir, who is a medical legal expert who has been doing wonderful job over the years at AIOS, MOS, and at various levels. My teacher, Dr. Kulkarni sir, my colleague, Dr. Santosh Kakade, who is known to me at my IMA Pune days. He's from Pune, and our colleague, Dr. Jagannath Boramani and Dr. Viral Shah, and all dear colleagues. I think it is the wonderful opportunity given to all of us to share our views on medical legal aspects, which are very important in today's scenario. To know the scientific knowledge is different. But about the scientific knowledge, there are some complications, there are some problems. And suppose you are facing these problems, how to tackle these problems? Am I audible and is my screen
Yes, you are
seen
audible.
properly? Yeah.
Yes. Can you help Judge Kakade to get logged in?
Prakash, your screen needs to be expanded.
Yes, sir, I'll do that.
Because can you help? Yes.
Yeah. So, dear friends, the topic given to me is how to tackle a case of endophthalmitis from legal point of view. Dear friends, most of us are ophthalmologists, general ophthalmologists, and even super specialist ophthalmologists. But then this terminology, nobody wants to listen here in his or her consulting room, because so many problems are created by this particular entity. Most of us, unfortunately, have faced this situation in the past, but don't feel that you are not going to face this situation in future. Suppose this situation comes, how to tackle it? I remember old days, our senior colleagues must have experienced this, that endophthalmitis they have tackled in a very nice way because of very good patient-doctor relationship. What patient-doctor relationship they had in past, probably patients and their relatives used to get convinced by their explanation about the disease. And I think that was resolving the issue. But in today's scenario, when the press and media is handling most of the things 24/7, and so much of pressure from various elements, maybe say politicians and government and so many things, probably this issue most of the times might be taken to various aspects. Those are related to medical legal point of view. So to know ophthalmology, so know endophthalmitis clinically, signs and symptoms and treatment is not enough. You must know the medical legal aspects about this particular issue. Dear friends, what I told in the past, doctors and hospitals used to handle this at their own level. And luckily, this issue was going to be handled by them at their level. They were fortunate enough. But there were unfortunate instances, and probably you shouldn't presume that you'll be able to tackle that at your own level. Most of the times when there are complications and patients and relatives are not convinced from you, probably they take that particular issue to various levels. I think this particular list, most of you must be knowing. Just to enumerate, nowadays, our senior judge is also there, Dr. Santosh Kakade sir. Apart from various courts, to go in consumer forum is that way comparatively easy for patients and relatives. That particular forum is available at district level, state level, national level. Unfortunately, the compensations day by day are also going very high. And to tackle such particular notice, when one gets it, unfortunately, from consumer forum, you yourself probably is not sufficient to face that particular situation. Even I will say, suppose you appoint the lawyer, even lawyer is not in a position to defend your case. Why am I saying so? Because there are various medical terminologies, which probably court and other lawyers, they do not understand, they do not know. And if you are appointing the medical legal expert, who is doctor as well as lawyer, probably can explain, can defend your case at various courts. So be in touch with your colleagues like Dr. Deshpande sir and various medical legal experts, because they know how to tackle that particular issue. Suppose the case goes in civil court, it takes years together. That way it is a very lengthy procedure. The unfortunate scenario is if the patient goes in criminal court. In today's era, probably the most affected thing in our country is the interference by the politicians. Most of the times they feel that they are the leaders in the society, the representative of the general public, and they try to take the law in their hands. They come to the doctors and hospitals, they try to negotiate so many things. And unfortunately, the doctors and hospitals is the animal, probably, timid animal, cannot defend that thing. And interference by the politicians is the worst thing. You should also be prepared how to tackle this, not to have that particular pressure upon you about the politicians. Then what I told just now about the media trial, newspapers and various channels, probably they feel that that particular issue, when they bring on the television or in the newspapers, before it goes to the court, before it goes to the police, before it goes to consumer forum, probably they want to give some opinion, some judgment from their side. That is the unfortunate thing, not only about doctors' cases, but media trial is the unfortunate thing what most of us are observing in today's scenario. What they have been doing, exploiting money, asking for money, and then blackmailing. Once you give some amount, probably you are bothered, you ask about money more and more at various instances. So don't accept that thing. Some cases, they are going to the expert opinion, and most of the times this expert opinion is taken from government doctors. In government hospital, probably it is the expert committee which is giving the opinion of that particular case. If your case is quite clean enough, probably expert committee gives opinion in your favor. But police department, most of the times, misinterprets that expert committee report. And they try to pressurize the hospital and doctor, saying that probably you are at fault. So that report is very important. Police, most of the times, they're having so many cases, but just now I have told doctor's case and hospital case is very easy for them to resolve in their own way. They try to pressurize hospital and doctors probably. And there also, you have to be very much patient in handling that particular pressure. In today's scenario, the worst thing we have been observing, that is the violence. And probably that thing you have to handle in a nice way. To go at various levels medico-legally, the important thing is about medical records. You must your medical records in a nice way, which eye you have operated, right eye, left eye, on which particular date, which IOL you have used, which visco you have used, what was the batch number, whether that particular case paper is handed over to patient and relatives, and you do not have anything with you. No, you must have all the records with you. That is very important, because in the court of law, these are the medical records which are going to save you. Another important thing which looks very, very simple, that is the consent. So if you do not take the consent, I think nobody can save you. And that too, you have to ask for informed consent. Nowadays, only written consent is not enough. There are CCTVs available at various hospitals and consulting rooms. You can have that recording of your consent and communication to the patients and the relatives. In this particular scenario of endophthalmitis, I think the worst thing, which is the end result in some of the cases, is loss of vision. And if the complication goes on after endophthalmitis to panophthalmitis, probably loss of eye. And these things are taken seriously from patients and relatives and from general public point of view. What you have to do whenever you are operating the patients, unfortunately, our ophthalmology paternity has been telling to patients, it is an operation only for 5 minutes. There are no complications. You will just go home while driving the vehicle and you will see everything without the spectacles. Probably it is the trouble starting from that period, that particular moment of time. Because you are assuring more, you are promising more, and probably you are delivering, suppose 99 or 98%, still the patients, they feel that they have been cheated. So promise less and deliver more. That is the thing you must keep in your mind. So that's what I have said. No hi-fi assurances. Ophthalmology is a science. Surgery is, after all, surgery. There are complications known. Endophthalmitis complication is written in the science, in the books of ophthalmology. You shouldn't be hesitant in telling about endophthalmitis to patients. Because if you don't tell that particular entity in discussion some of the times, probably patients, they feel that this is the unfortunate incidence which has occurred only in their cases. So then they try to take you for the ride. While operating the patients, there are AIOS guidelines. Foolproof AIOS guidelines, how to operate cataract, how to operate IOL, how to operate phaco, SICS, everything. Suppose you are step by step doing that particular thing, taking patient and relatives into confidence, probably they also know what doctor has done. And our doctors most of the times are busy. They feel that scientifically they have done correct. They have done complete consultation, surgical procedure, but you have to give some chair time. And in this particular case, the most important thing is second opinion. Suppose there is the case of evisceration or something of that sort. Opinion by another ophthalmologist is a must, and that has to be documented again. That choice you should give to your patient. You shouldn't say that your friend is an ophthalmologist and he should go to that ophthalmologist only, because that is going to save you. Another important thing is whenever the patient feels, allow him to go to higher centers, allow him to go to super specialists. On the contrary, you must tell the patient that go to somebody else, take the opinion, so that patient feels that he had freedom to take consultations from various centers, from various doctors. So don't hide everything at your center or your clinic. And the worst thing in this scenario, like in ortho, the person can be seen by others. The same way if the person becomes blind, the surgical procedure, if it is correlated for that, I think you have been doing vitrectomy and in some cases evisceration, that particular thing, everything must be explained to the patient in a proper way. And I think with these words, you are now in a position to handle these cases and there shouldn't be any complication. I wish for all of you, but unfortunately, if it is there, you should be in a better position. Thank you. Thank you so much, all of you, for giving me the opportunity. Thank you, Dr. Deshpande, sir.
Thank you so much, sir. Marathi, sir. That was an excellent talk. I think Deshpande, sir, has left us. He's joining us. Also, we are joined by Honorable Dr. Santosh Kakade, member of State Consumer Redressal Commission. Welcome, sir, on behalf of all the team BOA and MOS for this medical legal symposium on endophthalmitis. We welcome you all, sir.
नमस्कार काकडे सर आमचे फार जुने
Yes.
मित्र आहेत.
Namaskar, Kakade sir.
Senior
Yeah, again, I
orthopedist.
am in the. I was a little bit out of range. Again, I came here. Will you like to give your keynote address just now or after 2? Whatever you decide.
I think I would like to listen to all, and then at the end.
And then, okay.
Judge gives the decision at the end. Yeah.
Yeah. Then I will start my lecture then, because that is just and afterwards to another speakers, and I will introduce yourself then, and you will continue. So let me share the screen. The grounds of protection of a doctor or hospital in a CPA court. So, sir, I will request you that my mistakes may be there in front of you. You please ignore them if I say something just beyond something. The basis of protections are facts, circumstances, supportive documents, records, clinical references, and case laws. So I will go each and everything step by step about the facts which are actually happened, and as patients attended OPD, admitted, operated, referred, dates, etc. These are the facts which are accepted by both the parties, which are accepted by the complainant. If the complainant accepts some facts in his own complaint, there is no need to prove the facts and to tell and much praise for those facts, because they are already accepted by the complainant, which are denied by the complainant, but denied by the complainant but supported by the documents or records. If the facts are denied by the complainant, but you have to show that though he is denying, if the denial has no support for documentary evidences or records, so they can be explained to the judge, which are supported by the documents and records. So these are the facts which are neither mentioned by the complainant nor mentioned by the opponent side, that is the doctor side, but which are supported, and the facts which are supporting the doctor and which are supported by the notes, records, case papers, certificates, consents, time to time which the patient and relations has given in writing, and investigation reports and hospital records. All these come in support of the doctor, and if they are nicely produced in front of the judge, they will definitely go in detail and will think over that. Now the circumstances are having equally importance, and that is whether he has come of his own for planned primary treatment. So whether the patient has come himself as a primary patient, or he is being referred, or he has come as an emergency patient or referred from another hospital with complications or a higher center. Many times a anterior segment problem comes and the patient is referred to the posterior segment person, and so this patient may have complications itself. So this is the circumstances where one has to understand what is the position of the patient, and he has come for his own because of the complications or unsatisfied treatment. That is also a thing which is to be considered. Reached in a very bad condition. Many times the patient comes in a very bad condition, but doctor cannot refuse. He has to take the patient and he has to treat. In all such circumstances, the record of the referral with notes are very important, which goes in support of the doctor. So the records, discharge card, follow-up record, notes in OPD card, in patient's case papers, certificates, referral letters, operation notes, for pathology, and other investigation reports, consents, OT maintenance record, and all records kept well will come in the help of the doctor in the court, particularly the discharge card and the follow-up record, which is with the patient and they produce in the court. They are very important in the case of the consumer. Clinical references, suitable clinical references from textbooks and journals, statistics and opinion of the clinicians and experts and medical boards are definitely useful in pleading. So all these are to be produced in front of the judge, and the support of the case laws should be taken. The case laws established by the Supreme Court, High Courts, and a National Commission on same facts and same circumstances. This is very important. You have to show that what is the same facts in the both the case same and the circumstances was also same, so that the impact of that the case law is always there and it goes in favor of the doctor, are definitely useful in the pleading. As doctor will not be held responsible under negligence if the treatment as per the standard textbooks or accepted professional practice and still the patient suffers loss or injury. This is the fact. Really, merely because a complication is happened, it is not a negligence, because basically complication is not a negligence, but not knowing the complication is the negligence, or not treating the complication is negligence, and case is always based on the negligence and not on the complication. The medical man is not an insurer. He does not warrant successfulness of the treatment or cure of the patient, because he can treat only, but he cannot give the guarantee to the patient that he will be curing the patient or the treatment will be successful. So why the doctor is defeated in the CPA court? This is also a very important thing. Why it happens? The common advocate is not able to explain the medical legal facts of the case, as he is not able to understand the basis of medical knowledge. So he doesn't know himself what is to be pleaded, what is to be brought in front of the judges, what record should be brought. So he becomes unable to plead the case nicely in front of a judge. If the judge is not a doctor, then he has to depend upon what is kept in front of him, because he cannot go beyond what is kept in front of him, because he cannot say that because you have to produce this, that, and all that. He has to give the judgment whatever is produced in front of him. The common advocate on behalf of the doctor only denies allegations without any factful reasons and supports. So the denial may not be accepted by the honorable judges, but a medical legal expert explains the facts and circumstances with the proper documentation, results of investigations, and risk and benefits of each step taken by the doctor, so that the judge, even if he is not a medical background, understands and gives the proper judgment. So it is very important that your side you should be shown to the judges very clearly and very nicely, and it should be supported with the documentation. So complication is not a negligence. There is a blurred line between a complication and negligence. So what is to be called as a complication and what is to be as a negligence? The duty of a medical legal expert is show it is to be honorable judge, and so the medical legal expert has to show that this is the complication and not the negligence. And so this blurred line is very important in giving the judgments. As the complications mentioned in the textbook is not negligence, and doctor cannot be held responsible for it, but not understanding the complication or not taking the steps to rectify it or not referring the patient to higher centers may be taken as a negligence. So these are the things. Even if you are taken, refer the patient, but you have no documentation, you are nowhere, because in the court documentation is a must, because judge has to rely on the things which are kept in front of him. You have referred the patient, but you have no referral letter. And so the patient may refuse that he was not referred by the doctor, he gone himself. So the referral letter should be there. The pre-operative investigations, proper directions to the patients and follow-up notes protects the doctor. So it shows that what is more important to protect the doctor is the record. And if you are having a very good record, doctor will not be punished. The Supreme Court, in case of Suresh Gupta versus government of NCT, says that for every mishap of death during medical treatment, the medical man cannot be proceeded against for punishment. So the attitude of the judges is that everything is wrong, means doctor is wrong. It is not that, but you have to produce that whatever he is saying is supported by documents. So another way of pleading is that nowadays, because of the under Supreme Protection Act, under Consumer Protection Act, civil liability for negligence, the solo practitioner is in his responsibility as he is the owner of the hospital. But in corporate, trust or government hospital, it is a hospital responsibility. This clue is also being taken in many cases. Why? Because there is a National Consumer Dispute Redressal Commission. New Delhi has given a decision. It has held that whenever a patient lands himself in a hospital, private or government, his direct contact is with the hospital and not with the attending doctor or staff individually. Moreover, the patient does not know which of the doctor or staff will attend him. Therefore, the direct relationship is between the patient and the hospital. The Supreme Court says that the patient, once they are admitted to such hospital, it is the responsibility to satisfy that all possible care was taken and no negligence was involved in attending the patient. So, in fact, it is the hospital who engages the treating doctor. Therefore, it is their responsibility. So, responsibility lies on the hospital. Therefore, no individual doctor is liable and can be held jointly or severely liable. Even visiting doctors or consulting doctors in private hospitals cannot be held liable. So, consumer does not avail the services of doctor directly by paying fees or consideration to those doctors directly, but the fees goes to the hospital and hospital pays in the form of salary or something to the doctor. So, basic thing, if we understand, doctor is not a rival of the patient. Doctor wants that his patient should be spoiled. No doctor will want that. No mens rea in 304A is there. So in such cases, why a doctor should treat a patient when he knows that the outcome may not be satisfactory and patient may sue him? So there is every time there is a fear that the patient will sue me. Where the patient will sue me, why then he should treat the patient? These things are coming in the minds of the doctors, and it is that the should allow to die such patients because of such a fear. So is it that such patients should not be treated? Is it that such patients should be allowed to die? No. And so this is to be strongly built in the mind of the doctors, that the judges or the judgments are always in not unnecessarily going against the doctors. It is the first of the should collect a proof of safety. Now, whether doctor should first collect the proof of safety and then start the patient? Is it that he should be a legal safety first and then life or disease of the patient? Should he allow to die or get the patient spoiled because for fear of the CPA case on him? Patients which will be required to call all his property and come onto the road because so much compensation has been ordered and he has nothing to pay for that. And if such is the condition, why new generation should choose medical profession and remain unstable and under the threat throughout the life? This is the real fact which the new generation is having in their minds, and this fear should be driven off from the new generation. So indemnity insurance is always in the comes in the help of the doctor and have a indemnity insurance with good coverage limit and a medico-legal consultant as advisor. All at all times feel need of medico-legal. Thank you very much. So this is specifically I have mentioned how the doctor can be saved in the courts, and the court has the attitudes to save the doctor definitely, because doctors are never the rivals of the patients. Maybe that some negligence has happened, and that if the negligence has happened, there is a punishment definitely. Thank you very much.
Thank you, Dr. Deshpande sir, for the wonderful lecture. I think Consumer Protection Act, the government feels that it is the patient friendly and doctor friendly also, but I think it is going other way, and there are so many complications. Government has started on its own. I think in presence of Dr. Kakade sir, I am doing this particular.
Kakade sir is going to speak in the last, definitely. So I will request Viral Shah to start his lecture.
So Viral Shah is chairman of Scientific Committee of Vidarbha Ophthalmological Society, the young blood in the scientific content at various conferences. He is expert in giving talks at medical legal sessions at various platforms, and he is our budding colleague in various fields of ophthalmology. Over to you, Dr. Viral.
Thank you so much, sir. Thank you, Dr. Anand Deshpande sir, for organizing such a nice symposium on medical legal aspects of endophthalmitis. Thank you, BOA and MOS, for the opportunity. Lahane sir, Ragini madam, Swapnesh, Pritam Samant, and Parikshit sir and all. And it's an honor to present my talk in front of Honorable Dr. Santosh Kakade sir, Dr. Anand Deshpande sir, Dr. Prakash Marathe sir, Dr. Anil Kulkarni sir, and Dr. Jagannath Boramani. So without wasting much time, I will start away with my topic, post-operative endophthalmitis, top pulse for diffusing a potential time bomb. So these are some of the dangerous symptoms: pounding of or racing hearts, sweating, chills, trembling, breathing difficulty, weakness, dizziness, tingling, numbness, chest pain, stomach pain, nausea. Can you guess what are the symptoms of? I will give you some more hints. Sudden apathy, discontent, helplessness, loss of interest, irritability, loss of sleep, sudden remembrance of God Almighty, resolve to complete the long overdue pilgrimage. जाना था, शिरडी जाना था, वैष्णो देवी जाना था, सब याद आ जाता है. चेक द बैंक बैलेंस, इज इट सफिशिएंट टू रिटायर. और आखिरी में ख्याल आता है मैं डॉक्टर क्यों बना, मैं ऑप्थेल्मोलॉजिस्ट क्यों बना. ये सब सिम्टम्स है. यस, यू आर राइट. These are the symptoms of a doctor who has just been on the street lamp and sees this patient which was operated yesterday or a day before yesterday. So these are all the symptoms of a doctor or ophthalmologist rather, who has seen a patient landing up with endophthalmitis, recently operated patient. So no need to panic. There are some ground rules that we can have to diffuse this potential time bomb. The top pulse that I would like to share with you is early suspicion, confirmation, communication, second opinion, prompt treatment, regular and frequent review, microbiology and culture report, early vitrectomy, referral to a hair center, meticulous documentation, and of course, last is audit. I will stress more in detail after that. Early suspicion, any post-operative, unusual post-operative reaction out of proportion to the surgical trauma should be and must be suspected for endophthalmitis. There is no two way about it. You have to confirm the diagnosis. In infective endophthalmitis, the presence of lead edema, chemosis, marked reduction of vision, vitreous exudates, and low intraocular pressure are highly suspicious that patient has got endophthalmitis rather than toxic anterior segment syndrome. So how do you communicate this news to the patient and relatives? The most difficult part, this is very sensitive issue also because no patient is willing to take any negative news. Thanks to trivialization of the eye surgery, अरे 5 मिनट का काम है, 10 मिनट में हो जाता है, दूसरे दिन से काम पे लग जाओ, गूगलाइजेशन, सब गूगल पे अवेलेबल information. So it becomes very difficult to counsel the patient if some undue complication occurs. There is always a potential for medical issues cropping up while communicating. You have to be very careful, and taking and talking with patient and relatives requires some degree of compassion. It is always advisable to take a picture of the anterior segment and fundus, even if it is hazy. Take the patient and relatives to a separate room. Ask them to wait in a separate room. Don't make them wait in the same chamber where you are sitting. or in the same waiting room where other patients are also there, take them to either a ward room or a special room and let them wait there for 5-10 minutes. You have to recollect yourself and then go and talk with the patient and explain what the pictures looks and how the normal picture is like. Discuss with patient and relatives that any surgery has the potential to have an infection despite the best precautions, and this can happen in the best of the setups anywhere in the world, and it is a known complication. Even in America, UK, Europe, any country in the world, it is a known complication. Explain that all is not lost and it is possible to have recovery in most of these patients. This can have a calming effect on the patient who was expecting to join back his work with full vision. Tell the patient and family that you will make the best possible efforts to help him recover, and there won't be any additional fees charged for your service. You can subtly imply in your communication. Second opinion is very important. You will be surprised that all your colleagues and seniors, they are most helpful during such stressful time. You only think in your own mind कि आप वो देखेगा तो क्या बोलेगा. They are all ready to help. I was personally experienced, and many patients from other doctors have also come, and I also always try to calm down the patient and suggest a good line of action to the treating surgeon. So it is always better that a senior surgeon in your setup or in your city or town sees the patient and is kept in the loop. This will assure the patient and more importantly his relative that the best possible is being done for the patient. If you are an anterior segment surgeon, you can have an opinion from a vitreoretinal colleague in your town or in your setup. If, however, VR help is not there in your setup or in your city, the best option is to give an intravitreal antibiotic injection and seek an urgent VR opinion. All ophthalmologists, either anterior or posterior segment, must be confident in giving intravitreal antibiotic injections as an emergency procedure. Prompt treatment is the keystone. If the diagnosis of endophthalmitis is confirmed and there is high index of suspicion, prompt intravitreal antibiotic injection should be given without delay, even if it is a holiday or a Sunday or a Holi or a Diwali, whatever, you have to give it on the same day. It is always better to give 2 antibiotics. All these algorithms are there. So it is a gram positive or a gram negative or a fungal or very severe or whatever you are suspecting, give according to the accepted norms. AIS has prepared a very nice chart for this. The 6th most important pearl is regular and frequent review. If the clinical diagnosis, you have diagnosed as toxic anterior segment syndrome and patient has been put on intensive steroids and cycloplegic, you have to review patients every 12 hours till the symptoms resolve. So if you are started in the morning, you have to call the patient in the evening. If you have seen the patient in the evening, you have to call it in the next morning. If improvement is there, then continue the medical treatment and review the next day and then daily. If you have given intravitreal antibiotics suspecting infective endophthalmitis, then you have to see the patient next day for signs of improvement and stabilization. Microbiology and culture report, they are very important. Once it is decided to give intravitreal antibiotics and do vitrectomy, it is imperative to take samples for culture and sensitivity. The best yield is with vitreous biopsy. Alternatively, aqueous paracentesis can be done and inoculation of samples should be done in the operation theater itself. Early vitrectomies, there are some indications where intravitreal antibiotics won't be working. So what are the indications where early vitrectomy is desired? If a patient doesn't respond to all your intravitreal antibiotics in 24 to 48 hours, no improvement is there. If endophthalmitis is very severe or fulminant with only PL plus is there, retained intraocular foreign body, you are suspecting some foreign body as nucleus piece has been retained or something has been retained inside the eye. If there is recurrent endophthalmitis or retinal detachment is seen there on the ultrasound, then you should go for early vitrectomy. Referral to higher center if the patient is not responding adequately to your treatment, surgeon is not confident of doing a vitrectomy. If facilities for vitrectomy are not available, and the patient must be referred to a higher center for vitrectomy. Meticulous documentation. Whatever the findings, please write them in the case sheets, preferably with a drawing and photographs attached. Daily, every visit of the patient, you have to put down the findings and your plan of action also. Also very important to write down your plan of action and the discussion you had with the patients and relatives. The details of every treatment given, smears made, culture sent, and should be recorded with date and time. So you have to create a log of everything, whether the patient was improving or deteriorating even after your best efforts. Remember, it is this documentation which is going to help you in the court of law if in the future litigation issue arises. Also remember, what matters in the court of law is that you have tried your best and given the best possible treatment, and not what was the end result, that doesn't matter, but whether you have tried to give the best possible treatment or not, that is what is most important in front of law. Special word about cluster infections. This is one of the most dreaded event in any of the ophthalmologist life. Occurrence of ophthalmitis which is much higher than the local incidence pattern, or occurrence of 2 or more cases of infection at us in the same day or at a same stage of time. Occurrence of repeated postoperative infection under similar circumstances with the same surgeon, same staff, or in the same operating room. This calls for many interlinked actions and responsibilities on the service provider. Occurrence of, if there is an issue of cluster infection, review all the patients operated on the same day, review all your sterility factors for any breach in protocol, inform health authorities and AIS or your local society, treating and referring all the patients to a higher center as required. Clinical audit and review of standard operating protocols is a must. This clinical audit and review of SOP is what is going to be the main audit to do. This essentially includes to treat the patient most appropriately to salvage the best possible vision, identify the source of infection to prevent another outbreak, and build psychosocial confidence in both the caregivers and the care seekers. There are 3 sources of infection, primarily the patient, the health personnel, and the surgical supply. Potential sources of this outbreak usually include bacterial contamination in the surgical instrument, irrigating fluid, IOLs, or the surgical environment. Isolated cases usually arise from patient's own commensal bacteria, and in contrast, gram-negative organisms are commonly associated with epidemics of cluster and ophthalmitis outbreak. Molecular microbiological methods, these are must to prove that it is a because of an unquestionable association of microorganism isolated from the vitreous of the infected eye and other suspected sources of infection. It can be a surgical supply or the hospital personnel. Every effort must be made to identify the source of cluster infection by microbiological tests.
Wind up, please.
Yeah. Sir, last slide. Yeah, last slide. However, this method do not establish the cause-effect relationship. Psychosocial aspects. Finally, the psychosocial aspects of care cannot be ignored in an environment of mental and physical trauma. One is required to maintain dignified calm and use an alert and logical mind to tide over the crisis. There is also a need for advocacy. A national policy must be made, and doctors and eye care providers should be assured that they won't be harassed or punished in the guise of conducting the audit. So thank you so much for giving me this opportunity, sir.
Thank you, Viral Shah. With kind permission from Buramani, should I keep the judges just keynote address before you, please?
No problem, no problem.
So I will request our Honorable Dr. Santosh Kakade.
Sir,
he is a non-judicial.
Not there, sir. He is not there.
He has disappeared.
He is not there in the meeting.
Okay.
Yeah.
He was there up till now.
Yeah, but now he is not seen.
So you can continue.
Okay, sir. Can you see my screen and can you hear me?
Yes,
yeah.
Yeah, I'll make it full screen. Yeah. Now let me thank once again Dr. Lahane sir, Ragini madam, the entire BOA MOS team, Honorable Justice Kakade, and I thank Dr. Deshpande sir also for giving me this opportunity, and all the esteemed panelists in the symposium. Now I am not a lawyer, so I'm a doctor, but I think most of the previous speakers have made my points very clear. There is a lot of overlaps on the topic. I'm going to speak on the records that protect a doctor in case of endophthalmitis. Gone are the days when doctor was considered a messenger of God or an angel. Now, because of the CPA Act, Consumer Protection Act, it is very easy to drag a doctor in consumer court. But at the same time, keep it in mind that it is not very easy to prove doctor's negligence, provided you are very meticulous in keeping all your records. But it is better to safeguard yourself by having a good communication skills with the patients. Hello, sir. Good academics and surgical skill also, and have a good record keeping. Now, generally in the court, the doctor's innocence is always presumed, and the complainant has to prove the negligence. which is very difficult for the complainant also. There are various reasons for the medical negligence cases. So I don't want to go through the details because already it has been covered. But what is the greatest asset in the court of the law? That I had done this thing, I had not done this thing. So it is a single, crucial, and most effective weapon in the hands of the doctor is only medical reports. Because unless something is shown to the judges that you have done this thing, it is written down on the paper, then only it can be believed. So before starting the talk, let me just show you some Campbell cases. Last year in month of July, there was a judgment from the National Consumer Redressal Forum about the blanket concept. I just read out. We note that the pre-printed and fixed informed consent come undertaking form with blank spaces for limited select handwritten entries and for the signature has been used. The main body of the form is pre-printed and fixed. It can fit into any procedure, any doctor, any patient after filling up the blank spaces for the limited select handwritten entries and getting affixing the signature. We note this to be administrative arbitrariness and one-sided high-handedness and to be unfair and deceptive on the part of the opposite party, number one. So many hospitals now also the format of taking the consent is मी कोणत्याही प्रकारच्या भूले काढली ऑपरेशन करून घेण्यास तयार आहे, isn't it? So this is just general consent form, even if it is a printed one. This court has not allowed it, consumer court has not allowed it. They have considered it as an unfair trade practice and they have penalized the hospital ₹10 lakh. This judgment was has caused a lot of uproar in the medical community last year. In the July, this thing was come. So how to go about it, I'll come to it later on. This is a case number 2 where Tripura High Court in a diabetic patient has held the hospital guilty because of lack of due care and attention in conducting the operation. Now, this is only because sufficient records were not, the hospital was not able to produce proper records in front of the bench. Now, in this case number 3, there was no negligence in the surgery. The case, endocrinologist case, was referred to a higher center and managed there. So I don't know what was the outcome, but the patient was insisting for furnishing the discharge summary and case sheet, which was not given. So in spite of repeated requests from the patients, the doctor didn't give the discharge summary and case sheet. And because of this, the court held that the doctor was negligent on this part and deficient on this part. Now, in this case, this is very interesting. This is a very reputed hospital, Jipmar Hospital. The case of endocrinology is developed. The case was referred to LV Prasad as well as the Shankar Netralaya. The experts there opined that there was no negligence. But the patient took opinion of some private doctors who said they shown in the textbook that you have to do the painting, draping with povidone iodine, you have to do a sterile drape. And because the hospital had not written in this the record, they penalized the hospital. There was one more surprising thing, that no antibiotic in any form was administered. Nowadays, we are not giving oral antibiotics in cataract surgery. But in this case, there was no mention of any antibiotic eye drop given. So because of that, the hospital was held negligent and penalized. So in the records, many times we start writing only from the incision onwards, but it is better to write now that you have done proper draping, cleaning with this much percent povidone iodine, draped with a sterile drape, because that has to be mentioned in the records. Now, this was a diabetic patient who was admitted for half day. Patient was operated in the evening and discharged on the same day. Here, the patient developed endocarditis and no blood sugar. Latest was done. Suppose blood sugar was done about 15 days back and the patient is getting operated now. It is better to see the latest blood sugar. And even after suspicious of endocarditis, patient was not advised blood sugar. This blood sugar was advised almost say many days after the incidence of endocarditis. And here again, the court held that there was a contributory negligence on the part of the doctors as well as on the part of the patient for not keeping the diabetes under proper control. So you know very well, I'll skip this slide, what should be there in the medical records. It is all the OPD, IPD history, examination finding, treatment given, reference history, so on and so forth. So why you should maintain record? Because the records is the only proof. If anything goes wrong against you, the medical record is your savior. So coming to the informed consent, I was discussing about the informed consent. Now, luckily in ophthalmology, you are having a printed consent form for different types of surgery. So all the consents should be specific for a surgery. The informed consent should contain all the benefits of the treatment, risk of the treatment, alternatives available. If treatment is not done, what are the risks patient is taking, and everything should be documented and patient sign there. I talked about a blanket consent, which was considered as an unfair trade practice. So even if we take a consent, proper consent with all the possible complications explained, it is better to have a blank space there and take in patient's handwriting that all my queries have been answered by the counselor and doctor, because this proves that you have discussed with the patient everything, and preferably it should be in patient's and relatives handwriting, at least 1 or 2 lines in a blank space, and take it again. And all the consent should be surgery specific. Luckily, our AIOS is now issuing all the specific consent in different languages also. So what is a good MR? It is a good MR shows all the abbreviations and acronyms used in the MR, and MR folder, if it is a hard copy, should be properly clipped, stapled, and even the numbers put on the pages. If at all there is some amendment is done in the paper, it should be rewritten by the physician, and reasons for rewriting also should be specified along with the signature and time. Now I'll skip this slide. Everyone knows how long the record should be preserved. Now the MCI also in MCI Act has said that effort should be made to computerize the medical records for quick retrial. I am also using a computerized medical records. It is very easy to record everything. It is very easy to retrieve also everything. Now the question asked many times is whether the EMR stands in the court of the law, because there is a tampering is very easy in the EMR, but many modern EMRs now have got the arrangement where once you put the records on a particular date, you can lock that record, and if you can prove to the court that once the record is locked, we cannot make any changes in that, the court can very well take it granted. Coming to all these reference notes and discharge summaries and other things. Now referral note should include again date and time of issues, to whom you are issuing, why you are issuing, what is the cost for reference, what is the procedure adopted, and always keep a copy of the reference note with you, and take patient signature. So that is a proof that you have given this type of note to the patient. Discharge summary also should be a detailed discharge summary, the time of admission, discharge, the procedure which was adopted. If at all complication take place on the discharge summary also, at least in brief, it should be mentioned. This was the complication, patient has been explained about this and that, and keep a copy with you with patient signature. It always protects you. Now, most of us are having standard format of giving post-operative instructions. So that also should be printed at the back of the discharge summary, and take on the indoor paper patient signature that they have received discharge summary, they have received the proper post-operative instructions. And in the post-operative instruction, it should be mentioned when to come again for follow-up, and specific warning that report immediately if pain is there or increased redness, reduced vision, or any odd sign or symptom, kindly report immediately. So even give some contact number. So even if your hospital is closed, whom should they contact? It should be mentioned on the discharge paper, and take the patient signature again. If at all tampering, adding to an existing record is a tampering. If at all you do any tampering, it is not generally taken as with the bad intention. So if at all you have to rewrite the records, preferably write in some different ink, write the date and time, write the reason why this has to be struck down and why this new note has to be added. The specific reason should be written. Now, other important records as far as the endophthalmologist is concerned, that you should have proper autoclave and fumigation result records. Now, this is from my clinic. We are maintaining the autoclave records. We are maintaining even the class B autoclave, which is a electronic one. It gives a printout. What was the vacuum? What was the temperature read? And what time it was reached. This is in the electronic format. So when, yes, sir.
Please.
Yeah. Okay.
It has little time.
Okay. Okay. So these are the records, and this is the monthly surveillance of the OT, and record the batch number and keep the batch number of the irrigating solutions. And I just want to make one copy. The patient's investigations, you should have the copies either in a scanned format or a physical format, because a diabetic patient can always hide the last control blood sugar from the court of the law, and then you will be in a suit. Physician's fitness should be also from MD or equivalent, and the physician should write the BP and everything on the note. So Dr. Shah has covered what to do if the endocrinologist. I'll skip this slide, and I acknowledge my friend Honorable Dr. S.M. Kantikar for helping me in giving the inputs for this preparation. Thank you very much.
Thank you, Dr. Boramani. I will request our Honorable Judge Santosh Kakade. I don't want to waste my time in introducing him because everybody knows him very well. Please, we are eager to hear you, sir. Yes, please. Unmute yourself. Unmute. Yes, please.
Yes. So good evening to all of you.
Good evening.
Good evening.
So I must appreciate the patience of the audience as well as the speakers who are present right now in this particular session, because already it is crossed 6 p.m. And what I heard that it is this particular online conference is since morning, is going on since morning. So I think without wasting much time, I will just speak for 10 minutes. I have a small presentation I'm going to share with all of you. So the dignitaries who were present in this session at the beginning, Dr. Lahane sir, then Dr. Anil Kulkarni, he was a teacher, I think when I was in the medical college and I was pursuing my MBBS, I got that opportunity to learn from him the ophthalmology, whatever little I could learn. So Dr. Anil Kulkarni, and then those who are present in this session, Dr. A. Deshpande, who is a senior most medico-legal consultant and ophthalmic surgeon himself, Dr. Prakash Marathe sir, as he has specifically mentioned, and let me tell you, I have this nice opportunity to seek his guidance in whatever programs being organized in IMA as such. So I thank the organizers for inviting me for this particular session. Then Dr. Boramani, Jagannath Boramani sir, I think we got introduced say three or 4 years ago, and by Dr. Kantikar sir, who is presently a member of National Commission. Then Dr. Viral Shah and the other organizers. So usually what happens, the medico-legal sessions, they are at the end. And most of the participants, though they are interested in this particular medico-legal aspects, probably they are knowing what to do, what not to do. So that's the reason I must appreciate right now that my previous presenters, they have very nicely in-depth discussed about the medico-legal aspects of endophthalmitis, and this is definitely a area of concern as the ophthalmology as such is concerned. The topic which in short I'm going to discuss is the award of compensation. Now let me inform all of you that the Consumer Protection Act 1986, this was replaced by Consumer Protection Act 2019, and this was on the day 20th of July 2020. And this has given very wide scope as well as authority, we can say, to both, there is the consumers as well as the consumer fora who decide, or rather forum word is not being used right now. It is the commission at the level, even at the level of district commission. Now let us directly come to the topic which I am going to discuss with all of you. Usually in all the conferences, it is discussed that nowadays the compensation being awarded against a doctor to a patient is being higher and higher day by day. In a way, it's somewhat true, I can say. But then, is there any system of deciding compensation? The answer is yes. Now, while discussing this, I'm going to share a presentation with all of you. I'm a general and orthopedic surgeon, practiced for 20 years. And then with this particular background and a legal qualification, I'm now in the State Commission as the member of the State Commission. Whether the presentation is seen right now?
Yes, yes, it is visible.
It is visible, okay. Yeah, so I'll just, right. I think, is it seen right now?
Yeah.
Right. Perfect. So award of compensation. Yes, please.
Perfectly seen.
Okay, that is fine. So award of compensation in medical negligence. How court decides? Now let me tell you, before joining this particular commission, as a doctor, I definitely had some queries in my mind. While pursuing even the legal education as such, I was wondering, when the judges and the advocates, they don't have medical knowledge, how they decide that particular doctor is negligent, and how the judge decides what compensation is to be awarded. But then gradually, with the experience and now more than 3.5 years in the State Consumer Commission of Mumbai, I came to understand that there is a particular system which works, and which is all the judges now in the consumer court system, they are known as members. Now the members are trained to calculate the compensation as such, and whenever any judgment and order is passed by any commission, usually while calculating the compensation, a certain formula is being used. I'm in a short span, I'm going to discuss that formula with all of you. Now, what is that particular formula as such? Shortly, medical negligence. What is medical negligence? It is commission or omission. We all have gone through this particular definition. Commission means doing certain thing which is not necessary, while omission is not doing certain thing. Certain thing in our case, that is in doctor's case, investigations are there, treatment part is there, either medical line of treatment or a surgical line of treatment, etc. So commission or omission leads to medical negligence. Though since historian days, the medical negligence was being taken care legally, I can say, by various acts. It is the Consumer Protection Act, now it is 2019, is taking care of even the concept of medical negligence. There was very much hue and cry when this particular act was applied in 1995. See, though 1996 this act was enacted, in 1995 this was applicable to the medical profession, and the same scenario was there in 2019 when this new act came. But then it is gradually has become, the picture has become clear. The medical profession still comes under the new act, that is the Consumer Protection Act 2019. Now, what are various elements? The complainant, that is a patient, has to prove that these particular elements must be there to prove that a doctor or a hospital is negligent. That means there exists a legal duty. When the legal duty of a doctor starts? When he examines the patient. So this is first thing. There is a breach of legal duty. So this legal duty, when it is breached, and in consequence to that, there is a injury to the patient. And now injury is nothing but a damage, we can say. It's a legally recognizable damage is there. Then the medical negligence can be proved, and if the advocate can convince the court that all these four elements are there, as well as it is supported by the documentation, the medical negligence is proved. Now, what has happened as there is a quite change in the scenario. So we as a doctors now need to take care not only of a clinical result, but of also the legal effect of that, or legal consequence of that. And now these are unfortunate terms or words which are used, that there can exist doctor-patient conflict. There are various reasons for that. Now, this particular, I found it on the internet, and when I went to US, I found that these are the advertisements which are there of advocates or lawyers in the US that promise the patients to give compensation from the court. So these are certain advertisements as such. So why compensation is being awarded? It is to recompense. Then second is, it is return for loss or damages which are sustained to the patient, and it's definitely a fine art, it is said. What is the aim of compensation? Is to pacify the affected party. It should act as a deterrent to the negligent party. It should mitigate the hardship to legal representatives of the deceased patient, and it is an action for personal injury. Now, this photograph I have specifically given, it is of Dr. Kunal Saha and his wife. In the history of medical negligence, or we can say legal medicine of India, Dr. Kunal Saha could convince the Supreme Court of India, and he was awarded highest compensation of around 6 crores, along with the interest also which was being paid as 6 crores. So total 12 crores were awarded to this particular doctor. I'm not going into the details. I think you should read. This is an interesting story how this particular happened, and it was due to the death of Anuradha Saha, his wife. This particular case came out, and after this particular judgment and order from the Supreme Court, Honorable Supreme Court, there definitely is increase in the we can say volume, or more and more compensation is being awarded. The compensation in a nutshell can be awarded for general damages and special damages. General damages may be pain and suffering, loss of amenities, loss of expectation of life. Special damages, loss of earnings, cost of medical treatment, loss of future earnings, etc. It is usually assessed like this. It should be a loss recognized by law. This is the first and foremost very important thing. And it should be, the loss should be attributable to the negligent action of a doctor. So though some personal injury because the treatment was foreseeable, if the doctor could not avoid, this can form an element for this. Usually the amount which is being awarded is reasonable, and there is a certain particular system for that, and which is known as a multiplier method, which is being used in the Motor Vehicle Accident Act. So Schedule 2 of Motor Vehicle Act gives this particular thing. That is a basic annual figure that is multiplicand, means if there is a death of a patient because of the treatment, and if it is proved that it is because of the negligence of the doctor or the hospital, this particular system is being used. What is multiplicand? Multiplicand is nothing but annual amount of compensation or earning of that particular person who died. There are multiple factors are there. Then next is a multiplier. Multiplier, what is the meaning of multiplier? If suppose the patient was young one, then the multiplier is higher one. So that means the number of years which probably this particular patient could have supported his family. So this is second point. And then third is the calculation of the amount is done. There is one case law which has definitely guided all the courts, that is Sarla Verma and others versus Delhi Transport Corporation and another. So this was actually in the 2009, and he has given guidelines. These guidelines that it is by 3 steps this is calculated. The multiplicand, as I have already told, that the annual amount which that particular deceased person could have earned. Then multiplier is number of years which he could have earned for the family, and the actual calculation. Of course, here 1/3 of the amount which that particular deceased patient has earned is separated out, and only 2/3 is considered, because this 1/3 is supposed to be considered for personal consumption as such. Now, it is right that while being discussed by all our colleagues, that the compensation being awarded, probably the amount is being increased. Now, if you have read the news, even the newspapers today, I think, or yesterday, the Madras High Court has actually come out with that even if that particular person does not demand higher compensation, if the court feels that some more compensation is to be awarded, it is right to award more compensation. So is the view of, I think, most of the courts. Now coming to the current scenario, as this was already being discussed, that fortunately, thanks God that the advocates, like advocates in the US, they have not come out in supporting the patients as such, like ambulance chasers as such. So that's a good thing in this particular scenario. But then, apart from that, violence against the doctors and the hospitals, it is a big menace, and this is a very challenging thing for the doctors and the hospitals. Now coming to the final part of this particular presentation, that is award of compensation has particular system which is being used. It is nothing but Motor Vehicle Accident Act, Schedule 2 is considered, which has a tabular form, and this tabular form is being used to calculate the compensation as such. Now, who are the legal heir? For the legal heir, this particular compensation is added, and there are certain other parameters also which are considered, and the compensation is being awarded. It is true that it depends on judge's discretion to decide the amount of compensation as such. So, the medical fraternity, we all of us, doctors, we are worried about the cases being filed before the consumer commissions. That is true. But then, as Dr. Deshpande sir is there, like medico-legal consultants who are there who help the doctors, and obviously it is the management of a risk, because this is a risk. This risk management must be considered by everybody, and one should prepare to face this particular case as such. And let me inform all of you that in the consumer courts, the advocates may not be able to defend you in a way in which they should defend. The main basic thing is that whenever they are defending you, they should get proper knowledge from you as such. But whatever they understand, with that they come out and try to defend you. But then there is definitely an opportunity. Consumer court system is the only system where you can come personally and defend yourself. So in person you can definitely come and you are allowed to defend yourself. So you have to prepare yourself like that. Last point, regarding documentation, usually what happens is the standard of documentation. So what is the meaning of standard of documentation? And what is the basis of that standard? The associations of specialties should come forward and create standard documentation of treating every disease, and this should be made available to all the members so that the members can defend themselves in the court of law before the consumer commissions as such, or even any court of law, and they can file this particular documentation which is prepared and created by the associations, specialty associations. And I think that should be a suggestion to the all association as such. Now with this, let me come to end of this particular presentation. I am thankful to the organizers, specifically Dr. Deshpande sir, Dr. Marathe sir, then Dr. Buramani sir, and those who have invited me for this particular session. I thank all of you for patient listening. Thank you.
Thank you, Dr. Santosh Kakade. You have given a very nice guidance to us, which will help us in doing the practice and defending ourselves. And another thing is that you have given a courage that doctor should not fear of the consumer cases, but he should face them nicely. And for that, the records are very important. About him, now I can have a chance to speak something. He is MS in general surgery, diploma in orthopedics, and he is FICS, LLM, and PhD in law. Such a high degrees, MBA in executive finance and hospital administration management. I think he has not left any degree which is required for this all the things. And I am very happy and very thankful to you, sir, that you have given a nice guidance to us.
एक वाक्य म्हणू इच्छितो काकडे सरांबद्दल. मला वाटतं आज लॉच्या क्षेत्रामध्ये जेव्हा मेडिकल क्षेत्रातली मंडळी नव्हती, तो काळ वेगळा होता. अलीकडे कंटीकर सर असतील, काकडे सर असतील, देशपांडे सर असतील, पण मेडिको लिगल अशा दोन्ही आस्पेक्टला आधारित असा ज्यांचा अभ्यास आहे की जे सहानुभूतीपूर्वक आपल्या मेडिकल प्रोफेशनकडे बघू शकतात, समजून घेऊ शकतात, आणि अशा प्रकारचे व्यक्ती टॉपमोस्ट पोझिशनला या लॉच्या क्षेत्रात आहे, त्याचा आम्हाला फार आनंद होतो. आणि आपले वेगवेगळे असोसिएशन्स असतील, ज्याला AIOS, MOS किंवा IMA या माध्यमातून आपण त्यांना कनेक्टेड राहू शकतो मला वाटतं हा एक समाधानाचा भाग मी मानतो. आणि आज काकडे साहेब या ठिकाणी आले आणि त्यांचे विचार आमच्या सगळ्यांच्या बरोबर त्यांनी शेअर केले. हा फार मोठा योग मी त्या निमित्ताने मानतो. ओव्हर टू यू देशपांडे सर, कंटिन्यू.
Thank you, Dr. Lahane and his team for allowing us to form this symposium and present in front of you. And thank you all the speakers and everybody. Thank you all.
थँक्यू everyone. काकडे सरांनी इनपुट्स खूप चांगले दिले. In short.
I think we have not left with any time for panel discussion.
ठीक आहे, पण एक तुम्हाला सांगायला हरकत नाही, तुम्ही मला संधी दिली तर मी दिवसभर बोलू शकेन या विषयावर.
हो सर, आम्हाला आवडेल सर, आम्हाला आवडेल. डेफिनेटली आम्हाला आवडेल.
आपण आपला म्हणजे जर्नल क्लब टाईप आपण 8-10-15 लोक जे इंटरेस्टेड आहेत ना, खऱ्या अर्थाने असं डिस्कशन करू सर. काकडे सरांनी जे सांगितलं ते म्हणजे थेरॉटिकल नाही, प्रॅक्टिकल टिप्स.
आपण जर परमिशन दिली तर अजून एखादा असा सिम्पोजियम आपण अरेंज करता येईल की ज्याच्यामध्ये एक्सक्लुझिव्हली आपण जास्त बोलाल आणि आम्हाला गाईड कराल. तर ते करता येण्यासारखं शक्य आहे. माझ्या दृष्टीने प्रयत्न नक्कीच करायचं.
हाफ डे सिम्पोजियम ओनली ऑन द मेडिको लिगल केसेस.
ऑन द मेडिको लिगल एक
बरोबर आहे.
तर ते खूप गायडन्स होईल. कारण सध्या खरं सांगायचं सर, एक हा 19चा जो आलेला आहे की ज्याच्या डिस्ट्रिक्ट फोरम मध्ये ही डिस्ट्रिक्ट कंझ्युमर कमिशन इज अलाउड टू ऑर्डर मोर दॅन 1 crore. सो प्रत्येक जण 1 कोटीच्या वरच मागताय. काय करायचं डॉक्टरांनी?
देशपांडे सर, थोडं मी याच्यामध्ये असं सांगू इच्छितो की वास्तविक पाहता हे ऍडमिनिस्ट्रेटिव्ह चेंज आहे, हा जो आहे याच्यामध्ये प्रत्यक्ष कॉम्पेन्सेशन हे 1 कोटीपर्यंत आहे असं नसून आता हे इट इज डिस्क्रिशन ऑफ द ऍडव्होकेट ऑफ द पेशंट. त्याला तुम्ही काय करू शकत नाही आता या क्षणाला, बरोबर आहे. पण 1 कोटीपर्यंत जर तुम्ही कन्सिडरेशन म्हणजे पैसे दिले असतील सर्व्हिस प्रोव्हायडरला किंवा एखाद्या प्रोडक्टसाठी, तर डिस्ट्रिक्ट कमिशनरला, म्हणजे याचा अर्थ असा आहे की बहुतेक सगळी मॅटर्स कंझ्युमरची ही पहिल्यांदा डिस्ट्रिक्ट कमिशनला जातील आणि मग अपीलमध्ये आमच्याकडे स्टेट कमिशनला किंवा नॅशनल कमिशनला जातील. असं आहे. 1 ते 10 कोटी हे स्टेट कमिशन, हे ओरिजिनल ज्युरिडिक्शन आणि नॅशनल. पण याचा अर्थ असा नाही की कॉम्पेन्सेशन खूप वाढलेलं आहे असं त्याच्यामध्ये नाही असं मला वाटतं. मी एक तुम्हाला आणखी सजेस्ट करेन की यू प्लीज फाइंड आउट द जजमेंट्स अँड द ऑर्डर्स इन फेवर ऑफ डॉक्टर्स आणि त्याचं एक तुम्ही कॉम्पायलेशन करून तुम्ही सगळ्या लोकांना दाखवा. म्हणजे अननेसेसरी आपले लोक घाबरणार नाहीत, भिणार नाहीत त्याच्यामध्ये. आणि काय करायला पाहिजे हे सांगायला तुम्ही इतके चांगलं हे
बऱ्याचशा केसेस तशा जमा करून कॉम्पेल केलेल्या आहेत, तर त्या केलेल्या आहेत. पण तरी सुद्धा सर इतकं सध्या आमचं फील्ड घाबरलेलं आहे. आपल्यालाच घाबरलेलं आहे म्हणाल काही हरकत नाही. आमच्या प्रोफेशनला घाबरलेलं आहे की न्यू जनरेशन म्हणते काय करायचंय आम्हाला डॉक्टरहूड. ज्यांच्या घरी पिढ्यानपिढ्या डॉक्टरचे हॉस्पिटल्स आहेत त्यांची सगळी मुलं डॉक्टर सोडून बाहेर जात आहेत. इस्टॅब्लिश्ड असेल तर जाऊ द्या वया म्हणतात, पण ते लाईफ अनसेटल्ड लाईफ नको. सो व्हॉट विल हॅपन इन द फ्युचर, वेदर द गुड डॉक्टर्स विल बी अवेलेबल ऑर नॉट?
प्रश्न आहे हा सर्वांपुढे, खरं आहे. पण त्याच्याकरता कंड्युसिव्ह जे वातावरण लागतं ते आपणच निर्माण करायला पाहिजे. लोकांना म्हणायला लागेल की बाबांनो घाबरू नका, तुम्ही प्रॅक्टिस करणार असाल तर तुम्ही न घाबरता प्रॅक्टिस करण्याचं वातावरण हे आम्ही असोसिएशन मिळून तयार करू असं म्हणायला पाहिजे. आणि विच इज डेफिनेटली पॉसिबल.
So once again, I thank you all. And any questions घ्यायचं घेऊ शकतो आपण? वेळ आहे आपल्याकडे?
नाही, 6:45 वाजले.
उशीर झाला.
So I will end this session and thank you.
Thank you very much.
Thank you.
बरं वाटलं फिजिकली, नाहीतरी आपण असं ऑन स्क्रीन भेटतो एकमेकाला.
iOS आपला सेशन 26 जूनला. iOS सेशन आहे आपला 26 जूनला.
हो आहे
संडेचा आहे. ठीक आहे सर, थँक्यू सर.
ओके, थँक्यू एव्हरीवन.
थँक्यू सर,
थँक्यू सो मच सर. मराठे सर,
थँक्यू एव्हरीबडी.
थँक्यू एव्हरीवन.
काकडे सर,
नमस्कार.
प्रत्यक्ष भेटायचा योग आला नाही. प्रत्यक्ष मॉस मध्ये एकदा भेट झाली होती, तेवढीच पुन्हा झाली नाहीये. पण लवकरच योग यावा, भेटायचा ही इच्छा आहे.
चालेल, भेटू.
ओके, थँक्यू. बाय एव्हरीवन.
थँक्यू. बाय.